Good morning. Welcome to the Northern Pain Refresher Course 2021, which is being held virtually this morning. And it's my honor today to present the new definition of pain by IASP 2021. Let us look at the definition. In 16 July 2020, IASP introduced a revised definition of pain, the result of a two-year process that the association hopes will lead to revised ways of assessing pain. So they defined it as plain pain being an unpleasant sensory and emotional experience associated or resembling that associated with actual or potential damage. So resembling that associated with is a new definition, is a new terminology that has been included in this definition. So the ISP and the task force that wrote the revised definition and notes did so to better convey the nuances and the complexity of pain and hope that it will lead to improved assessment and management of those with pain. So the definition of pain is further expanded upon by the addition of six key notes and the etymology of the word pain for further valuable context. So basically it has an additional points that describes the definition clearer. This is a multinational, multidisciplinary task force developed and revised definition with input from all potential stakeholders, including persons in pain and their caregivers. So it took into account the contribution from all the other providers as well. So what are the six keynotes here? All right, I will go through this again later. This basically is pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. Pain and nociception are different phenomena. Pain cannot be inferred solely from activity in sensory neurons alone. Through their life experiences, individuals learn the concept of pain. A person's report of an experience as pain should be respected. Although pain usually serves an adaptive role, it may have adverse effects on function and social and psychological well-being. Verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that the human or a non-human experiences pain. Okay, so what is the difference between two definitions? Okay, we look at the definition in 1979. It says that unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Here it excludes groups who could not verbally articulate pain because it needs to be described. Whereas in 2020, the new definition says that pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential damage. So this is replaced by a terminology that relied upon a person's ability to describe the experience to qualify as pain. So resembling that associated with actually does not require a verbal description. So in comparison to the earlier definition, the new definition includes the multiplicity of mind-body interactions and the ethical dimensions of pain, resembling that associated with. Drops the emphasis on verbal self-report from patients and includes non-verbal behaviors indicating of pain, such as in neonates, elderly, and the cognitive impact, where patients are not able to verbally describe the pain. Take into consideration the cognitive and social factors critical to the pain experience. And the IASP task force also sought input from multiple stakeholders, including clinicians, researchers, philosophers, and the public, which included persons with pain and their caregivers. So the new definition has these six keynotes that you have to take into consideration. All right. Pain is again the updated notes. Pain is always a a personal experience that is influenced by various degrees by biological, psychological, and social factors. Must understand that pain and nociception are different. Pain cannot be inferred just from the activity in the sensory neurons. Through their life experience, individuals learn the concept of pain. A person's report of an experience as pain should be respected. Although pain usually serves an adaptive role, it may have adverse effect on function and social and psychological well-being. Verbal description is only one of the several behaviors to express pain. Inability to communicate does not mean that the person does not experience pain. Okay, thank you for your attention. And again, all reference here are from the IASP terminology of pain. Thank you very much.
Assalamualaikum, a very good morning. I hope you're having a good time. I will start with basic science, a bit of neuroplasticity, central sensitization, to try to understand pain better, and I hope we can go in line with the theme of the symposium. We want to personalize pain care management to our patients. And to start off with, the pathway of pain maybe started with René Descartes, who described pain as something that comes and carried by a tug in the fibril, in the form of tube that goes from the peripheries to the brain, and there is a pore in the somewhere in the brain that connects to the pineal gland. Here, a singular structure in the brain. The others are duplicates, but pineal gland is singular structure. So this structure opens the pore to animal spirit, and it unleashes all the emotions, the fear, the aversion from pain. And a few centuries later, George Washington Cryle, a surgeon in the US, 1913, he got gold medal for this, described an NOC association of shockless operation state using cocaine to anesthetize his patient. And the patient come into surgery after a few days on cocaine. They get they are more calm. They're kind of in an anesthetized, less painful state. And he found that when they isolate the central nervous system from pain stimulation, the outcome is better. So other marks in history, we know the first order neurons that we are using this term at the moment, first order, second order, third order. It comes from a study on cutaneous sensitivity early in the 20th century. The autonomic nervous system, differentiation into autonomic and somatic nervous system, this was introduced as a unified theory back then. There's also a brave chap who did a frontal lobotomy for malignant pain, because he thinks pain gets perceived in the brain. So let's remove the brain, the frontal part of the brain. And what he did was he caused an extreme change in personality, but no change in pain. And I think one that deserves citation here is probably gate control theory, Melzack and Wall, 1965, one that everyone is well aware of, and it is a basis of many current theories. What we know is that it contributes to a current understanding that we have excitatory neurons, we have inhibitory neurons, and in between we have interneurons that control all this from being facilitated or inhibited. And the current understanding of pain processing involves transduction, transmission, perception, and modulation. Transduction, where pain gets converted, the mechanical, chemical, thermal stimulation gets transmitted into electrical signal from the peripheries, transmitted to the dorsal column, transmitted to the brain by the first, second, third order of neurons, if you like it. And from the brain, it gets further projected to different areas. The cortex will tell you where and how much pain is. Limbic areas will give you quality of unpleasantness, degree of emotions that is stimulated by pain. And brainstem will give a descending inhibition to pain, so that we can still live and go about our activities despite having a bit of pain in normal situations. So the 21st century research make us more understand on the key players of pain transmission and how it gets amplified. It can get amplified in situation of persistent pain. The sodium channel, transient receptor potential venoid channel, the TRPV1 channel, as well as NMDA and AMPA receptor. If you would like it, the pain track or pathway is akin to a highway. If you have a temporal summation and hyperexcitable state of neurons in the pathway, it gets congested, just like a hyper-congested highway. And if you have a calm nerve and every single car is running in order in its own lane, and you get a pain signal that gets transmitted accordingly, and they get inhibited as well to have the person or individual continue with their own function. So from dorsal horn of spinal cord gets transmitted to the midbrain, the medulla, locus coeruleus, and parabrachial nucleus is located there, and it gets projected to the thalamus as well as amygdala, and some of the fibers will go through spinothalamic tracts, and others will relay somewhere in the midbrain. And these are all not possible without the peripheral fibers, the A beta, A delta, and C fibers, which mainly in hyperacute stage, they get altered. The A beta, instead of giving you tactile stimulation, they will give you an allodenic hypersensitive kind of pain. So what is central sensitization? It is enhanced response to low and high threshold stimuli. So your receptive field around the dorsal horn of spinal cord becomes larger. So an area that normally ends around a deeper layer of dorsal horn, there is a rex lamina around the dorsal horn nuclei. They normally only stimulated in a high threshold state. They get easily stimulated because of interneurons that connects the C fibers from the peripheries and the delta fibers that comes in certain superficial and deep layers. So all this gets connected, and a simple non-painful stimulation will give us, will give one subject with hypersensitized state a really painful condition. And we know sodium channel has different subtypes. There are 1.1 up to 1.9. And what interest is in pain related pathway is 1.7, 1.8, 1.9. And we know in some situation they get mutated. So study on mutated person with mutated sodium channel. For example, in this situation, inherited erythromelalgia, they have family members who have spontaneous firing of sodium channels. But what was found was that the maternal side has resilience to pain, and this was expressed by potassium channel activities. So in normal individuals, what was found was that the potassium channel provide balance to sodium channels activities. And we know that the sodium 1.7 gets hyperexcited in the dorsal root ganglia. This is the target of a lot of modulation by modulation study in human compared to animal. And animal studies may give us different findings from human studies. So that is why we have difficulties translating findings in the animal studies to get to improve our treatment in a human subject. And we know human labor pain may be modulated by voltage gated potassium channels. That's why they're more resilient to pain during labor. And on top of that, the 21st century research also tells us that there are role of the neuron matrix, the other cells in the neurons. More than 80% of the neurons are formed of microglia and astrocytes rather than the neurons. And we know that they are involved with altered processing. They are involved with memory of pain. And in situation where you get a nerve that gets hyper stimulated and all the fibers gets hyper excited from beta delta and C fibers, they have spontaneous activities, ectopic activities going on. And this will cause the dorsal horn to express themselves in a multiple ways. And one of the studies on alpha 2 delta side of calcium channel, which is normally where our gabapentin and pregabalin acts upon, this site get hyperstimulated, it gets enlarged and hyper-expressed and modulates more activities in the event of hyper-stimulated, hyper-excitable state of painful stimulation. So from a simple non-painful stimulation, they get wound up. So a non-painful, non-noxious stimulation will become painful, and all this become altered in a hypersensitive state. And we also know that ketamine changes this. Ketamine block the NMDA receptor, but at the same time, it has some limitation for use. On top of changes in the microglia, changes in the receptor field of neurons around the dorsal column, we know that nerve get inflamed, especially when they are involved in trauma and major surgeries. And when they are inflamed, they start to release a lot of neurotransmitters, and there are structures, like I've mentioned earlier, microglia that gets it projects more important role in this situation. And one of the first studies on microglia in 2005 by Alex Nimajan, he managed to capture activities of microglia as it gets hyper stimulated in a situation where there is a noxious stimuli around the region. So in this, especially lab rats, when they put a laser potential somewhere within the microglia, the neuron matrix, you can see that all the microglia that get stimulated, they surround the area that is hyperexcited by stimulation of injury or noxious injury, and they form kind of a protected layer surrounding that injury, that potentially injurious state after 50 minutes of stimulation. Yeah. And we all know also that microglia has its role in opioid-induced hyperalgesia. Microglia has two types. There are ramified microglia, which is involved in anti-inflammatory cytokines. There's also reactive microglia, which is mainly inflammatory. And we know that activation of microglia will cause all sorts of problems with the opioid-induced hyperalgesia, and there are studies looking at how this could be minimized by newer drugs, experimental drugs. On the left-hand side, look at the table. All those are experimental drugs to try to look at whether opioid-induced hyperalgesia, side effects of opioid could be reduced by alteration in the opioid molecules. So now let's look at the descending modulation. There are good cop and bad cop. Mostly they behave in normal situation as a good cop. So the pain that is perceived in the brain will be eventually transmitted to the descending control area, the locus coeruleus and the preaqueductal gray matter. So this nucleus, preaqueductal gray nucleus, will start to form a network with the locus coeruleus and rostroventral medulla nucleus, the RVM and LC, in which these two systems will release noradrenaline or serotonin, which in a normal situation will act in balance to sort of switch off or switch on pain. And we know that the PAG, will not function in normal state if patient has a lot of mood problem, fear, anxiety, panic, sleep deprived, and low in motivation state. So there's a switch and a break that switch pain transmission on and off somewhere in the midbrain. And we know that the PAG gets activated by the limbic system, and all this will kind of assure that in normal state, in normal kind of situation, in acute pain state, patient can still perform their activities and function, and it still can get pain can still get to be inhibited naturally by the presence of PAG function. And in a placebo and nocebo studies, this area gets light up. If you look at the image, the functional MRI image on the left-hand side, the anterior cingulate cortex gets light up, and it relates to the PAG area around the brainstem, and the PAG area will give a descending signal down to locus coeruleus around the posterior aspect, and RVM, the rostroventral medullary nuclei, that both of these nucleus will start releasing inhibitory or excitatory control, as in switching on and off pain signal. But in a defective state, in one who have problem with persistent pain, the bad cop starts to emerge. The bad cop behaviors, all this descending excitation maybe gets upper hand rather than descending inhibition. So this is modulation that gets out of control. And we know noradrenaline is always the good cop. It has a lot of networks around the brain, communicating with the medulla, the pons, and thalamus and the cortex. And one of an important studies in the 2016 is presence of DNIC, diffuse noxious inhibitory control, where one pain on one side of the body will reduce pain on the other side of the body. This proves that there is an inherent descending control in normal individual, and this control gets affected in fibromyalgia state, in osteoarthritis state, in peripheral neuropathy, and also absence of DNIC control, diffuse inhibitory control, predicts one to get post-surgical pain. And those with peripheral neuropathy, fibromyalgia, IBS, migraine, temporomandibular joint disorder, OA, muscle pain, whiplash injury, all these patients have potential to have persistent pain, hypersensitized state. And one of the tests to see whether they have a problem with the modulation is by testing the DNIC, or diffuse noxious injury control. Diffuse noxious inhibitory control. Clinically, however, we have what we call a central sensitization inventory, which you can download from the net, and it predicts presence of a score of more than 40 predicts possibility of developing a central sensitized state. And in these subjects, if you have them in your ward, in your clinic, you might want to address their situation in a multidisciplinary, modalities way of management, rather than a simple PCM, NSAID, opioid. And neuroplasticity is one of the subject that also gets a lot of exciting finding. It is capacity of nervous system to change its structure and function in response to persistent pain. And in rodent study, they found out that the brain gets hypoplastic, the dendritic density increase, the turnover increase, activity of neurons increase, and more importantly, you can also have a non-pharmacological way to deal with pain, and they are proven to have impact on neuroplasticity in the brain. For example, the cingulate gyrus up here, cingulate cortex, By having mindfulness and meditation, it increases activities of the cingulate cortex, which in turn increase activity of the PAG. And by increasing distraction and CBT, for example, it reduces activity of the cingulate cortex. So all this will definitely modulate the balance in the PAG. The thalamus, for example, distraction will reduce its activity. Mindfulness and meditation will increase its activity. All these have impact on plasticity of the brain. So in conclusion, many exciting research in the field of neurosciences to address need to adopt multi-dimensional, socio-psycho-bio approach to acute and chronic pain. And we have to identify those with central sensitization so that they can be managed accordingly to prevent persistent pain. And we know that nowadays, with more understanding of the way pain is carried from the peripheries to the central area, we can target more areas, especially targeting the diffuse noxious inhibitory control with possibly drugs such as tapentadol and duloxetine, which express more noradrenaline in this state. Thank you very much. I'm sorry to take your time.
Hello, good morning to everybody. I'm Dr. Yeoh, pain specialist from Kang Nak Hospital. First, I would like to thank the organizing committee for inviting me to give a talk in the Northern Pain Refresher course. I was given a task to talk on basic R.A.T approach applying to daily clinical practice. Ideally, this topic is supposed to be an interactive session. So you can raise up your question and doubts, and we can have two-way discussion. But due to COVID pandemic, we cannot do that. Back to R.A.T, I'm sure some of you have heard about R.A.T approach. It was one of the topic talk during a pain-free hospital program. R.A.T was first introduced in EPM, Essential Pain Management. This program was created by Dr. Y. Morris and Dr. Rajah from Australia. This is an education program. Their aims are to improve pain knowledge, to teach students and health workers to recognize, assess, and treat pain, to address pain management barrier, to train local health workers to teach EPM. R.A.T approach or R.A.T. I use back the same R.A.T picture in EPM. So unrecognized pain is like a rat. Unrecognized pain is often hidden, not unrecognized, and it causes a lot of suffering. So R.A.T approach, it means R, recognize, A, assess, T, treat. R.A.T approach is just like ABC of resuscitation. R.A.T approach gives us a simple framework to manage all types of pain. So now we shall go to R first, recognize. Recognition is the first vital step. If pain is not recognized, it will not be managed adequately. Ask yourself whether the patient has pain. Do other people think the patient has pain? Let's look at this picture. Do you all think this patient is having pain? This is easily recognized from the patient's facial expression and her body posture. How about this woman? Is she having pain? She's sitting up with her smiling face. Maybe at this point of time, you will think that she's well. But if you look at it carefully, you can see that she's using a PCA pump. Maybe she was having a lot of pain before. How about this lady? Is she having pain? So the cause of pain is not always visible. It's important to believe pain is what the patient says hurt. Then only we can do an assessment. A, assess. Assess is taking a thorough pain history. First, ask about pain site. It can be one or multiple pain site. Second, ask about severity of pain or pain score. In Malaysia, we use MOH pain ruler to measure pain from 0 to 10. 0 means no pain, and 10 is the worst pain that we can imagine. Third, nature of pain. Ask the patient how they describe their pain, whether it's throbbing, down, aching, electrical light. This will give you some clue whether it's a nociceptive or neuropathic pain. Besides the physical pain, we need to ask, are there any psychological affecting patient's pain? How is the pain affect the patient's daily activity? At the end of assessment, we need to come to the conclusion. What type of pain is this? Make a pain diagnosis, whether it's acute or chronic, whether it's a cancer or non-cancer, nociceptive or neuropathic pain. By knowing the diagnosis, it will guide us with the pain treatment. R.A.T, treat. Two important points under treatment is, remember, non-pharmacological treatment and pharmacological treatment can be used for our patient. Non-pharmacological treatment, we have physical and psychological. We can use rest, ice, compression, elevation of the injured site to reduce pain. Besides that, we can go for acupuncture, massage, physiotherapy for pain relief. Under psychological, we can offer explanation, reassurance, counseling. Sometimes by simpler explanation to patient, make them understand about their disease, they will feel much better, relief, and hence less pain. Under pharmacological treatment, we have a simple analgesic drug such as paracetamol, NSAID, a COX-2 inhibitor, opioids, anti-neuropathic agent such as pregabalin, gabapentin, amitriptyline, duloxetine, and other adjuvants such as local anesthetic or ketamine. Next, I will go to 3 case scenarios to illustrate different types of pain. I hope that we can use R.A.T approach to apply in this case scenario. So the same way of thinking can be used in the real life when we see the similar case in our practice. Case number 1. A 40-year-old man has just had a laparotomy for bowel obstruction secondary to inguinal hernia. He is unable to get out of bed because of pain. How should we treat his pain using R.A.T? Recognize. In this patient, pain can be easily recognized. Patient can be crawling, maybe both hands holding up at the operation site. There is an obvious cause of pain. Besides asking pain at rest, we need to assess pain or movement as well. A, assessment. We need to ask about pain site. Don't assume pain comes from operation site only. Sometimes patient can have complications after surgery, such as deep vein thrombosis, such as angina attack. So pain can be at the leg or at the chest. Then ask about severity of pain or pain score. Laparotomy is associated with moderate to severe pain. Pain score can range from 4 to 0. How's the patient described? Whether it's down, aching, throbbing, and generalized. These are typical for visceral pain. Next is how pain affect their activity. Can patient perform incentive spirometer? Can patient sit up from bed? Whether their sleep is disturbed by pain or not. So at the end of our assessment, our diagnosis is acute, non-cancer, nociceptive, visceral pain with moderate to severe pain score. Then only we go to treatment. We can start with non-drug. This is what we normally do. Nursing care, help the patient to sit up, assist them with mobilization, and by explanation to patient that this is not a cancer, it's just a inguinal hernia. Patient will feel much relief. So not to forget about our pharmacological treatment. We always refer to acute pain to analgesic ladder. You can get this from our acute pain handbook. In acute pain, always start at the top of the analgesic ladder and step down the ladder as the pain improves. What I mean is, if you anticipate this is a severe pain, you must start from the top of the ladder, start IV morphine. Or if you can offer PCA or epidural service to patient, you must give the best service to control the pain well from the beginning. Then only you step down the ladder. It is inappropriate to give tramadol, and if pain continue tomorrow, then only you go up, step up to morphine. It's inappropriate. Nowadays, we have many guidelines to help us, such as this procedure-specific pain management, or short form, PROSPEC. In the second half of the course, we're going to go through a few of PROSPEC's recommendations for various types of surgery. This is an evidence-based approach. The recommendation will be including pre-op, intra-op, and post-op pain intervention. So in conclusion, this is moderate to severe, acute non-cancer pain due to bowel obstruction, nociceptive mechanism. Again, in acute pain, it's important to treat the underlying pathology. Acute pain will resolve when cause of pain is treated. Acute pain is a warning sign of actual or potential tissue damage. Psychological effects such as anxiety and sleeplessness will improve when pain is relieved. Then I will move to our second case scenario. This is a 55-year-old woman who has diagnosed as breast cancer for more than 6 months that has spread to her spine. She has several severe chest wall and low back pain, and she is expected to die within a few weeks. How should we treat her pain using R.A.T? Recognize, is easily recognized in this patient. Patient will look tachyxic with a very sad looking, have pain at multiple sites. Assess. We must ask each site of pain about the pain score and also the nature of pain. This patient may have both nociceptive and neuropathic pain feature because this is due to spread of cancer to spine. It causes bone destruction, and this can compress at the nerve root and give rise to shooting, numbness, electrical light sensation to lower limb. So it's important to recognize neuropathic pain in this patient. And not to forget is to assess the patient's psychological and social factor that can contribute to their pain. If patients have a lot of family, financial issue. So at the end of our assessment, our diagnosis for this patient is severe chronic cancer, mixed nociceptive bone and neuropathic pain. So with this diagnosis, we will move to our T treatment. So for non-pharmacological treatment, we can offer patients nursing care, feeding, any wound dressing. Then important is psychological and social support, not to neglect it. Sometimes we need to ask detail and we have to refer to social welfare. For cancer pain, our first line is always morphine. We can use WHO analgesic ladder and control the pain with morphine. And this patient again add anti-neuropathic drug such as amitriptyline or gabapentin. And we will convert, when pain is well controlled, we will convert to more prolonged release such as morphine prolonged release or fentanyl patch. We update on the latest WHO cancer ladder. These are the principles Number one, by mouth. If patient still can take orally, we would like to give our oral analgesic. Second, by the clock. Give oral analgesic by the clock and PRN basis. The latest update, they have removed by the ladder. It's not necessary to start from the bottom of the ladder. Sometimes in certain moderate pain, we will give morphine as well for the individual. This is important. There's no standard dose for each patient. We have to ask in detail and review again. The dose have to be balanced within the desired analgesic effect and any side effect arise from it. So we must review and balance about these two aspects. And we have to pay attention to details about the dose, how long pain lasts after taking the analgesics. And one important point that I want to highlight in this patient is not to miss out neuropathic pain, because our conventional drugs such as paracetamol, NSAID, opioid cannot treat neuropathic pain. If patient have neuropathic pain, we have to start with anti-neuropathic drugs, such as first group is under anticonvulsant. We have pregabalin, gabapentin, or carbamazepine. Second group, we have antidepressant, such as amitriptyline or Nortrip. If the patient have depression at the same time, we can start antidepressant so that we can treat two symptoms at the same time. Then next is SNRI, such as duloxetine, or in certain patients with severe pain, we need to start the patient on ketamine infusion. Next, I will move to our third case scenario. This is a 24-year-old woman present to a clinic with a 2-month history of severe headache. She described her pain at right temporal region, throbbing in nature, pain score of 8. How would we manage her pain using R.A.T? So again, R, recognize. In this patient, it's difficult to recognize the pain. Other people may think she doesn't have pain, and maybe we need to ask the patient relative for more pain history. Assessment, ask again the exact site, whether it's just unilateral or both sides. How about their pain score for the past 1 week, the worst score, the least score, and how is the pain pattern. Ask about their pain descriptor, and also look into any psychological and social problem in this patient. So next is R.A.T. So treatment is pharmacological and non-pharmacological. So with the history, with the little history that we gather, we need to make a pain diagnosis. So in this patient is acute because it's only 2 months. We are not sure whether this is cancer or non-cancer, and is more likely is a nociceptive pain. So we would like to start this patient with some simple analgesics such as NSAID plus minus paracetamol. We will use opioids when needed, especially during the severe attack. And again, as I mentioned, in acute pain, it's important to further investigate to find out any underlying cause, any organic cause in this patient. So this patient had a CT brain performed, and it was reported as diffuse arteriovenous malformation. Then we refer this patient to our neurosurgeon. They have seen the patient. They concluded that the lesion was inoperable. She has to live with this lesion. So now the story continues. 3 years later, she came back to the same clinic with the same similar problem, persistent headache at the same site and pain score of 8. She has no new neurological deficit. How would we treat her pain using R.A.T? So R, recognize. This patient is difficult to recognize, as in any chronic pain patient. We cannot see It's not visible. The pain, the side or the cause of pain is not visible. Other people may think she doesn't have pain. A, assessment. Important to ask exact site, right temporal. How is patient's pain score? So it can vary from 0 to 10. Certain day patient has no pain at all, that we call good day. Certain day patient will have very severe pain score of 10. We can't find any specific stress factor aggravating and any relief factor. From the social history, she has stopped working after the diagnosis of AVM. She had depression, seeing our psychiatrist under their follow-up. She had very frequent ED visit for similar pain. This is not I make up the story. This is a very common scenario in our chronic non-cancer pain in real life. So at the end of our assessment, our diagnosis is chronic non-cancer with nociceptive, maybe neuropathic, and patient have severe psychosocial consequences. Next, treat. So non-drugs and drugs technique. So first we'll reassure the patient that this is not a brain cancer. In chronic non-cancer pain, we emphasize a lot on non-pharmacological treatment that we can offer to this patient, such as acupuncture, massage, relaxation therapy. And she needs to see a psychologist or psychiatrist for counseling and their therapy. In terms of pharmacological treatments, we will start with paracetamol and NSAID. It may be helpful. NSAID should not be used for long term because of the side effect to upper GI can cause bleeding, perforation. So in this case, we may want to start some tramadol, but maybe tramadol may be helpful, but avoid strong opioids. Last, do consider anti-neuropathic agent if you think that neuropathic pain is present. So a lot of you may want to ask, why not strong opioids? Chronic pain is no more a symptom, but is a disease. We do not use strong opioid to treat the pain score in a chronic non-cancer patient. It's important, we cannot treat all the pain the same. It's not when patients have pain score of 8, then we will use strong opioids as what we do in acute pain. Here, I have listed down the do and don't for the use of strong opioid in chronic non-cancer. So don't use strong opioid as a monotherapy. We have to introduce non-pharmacological methods to these patients, such as relaxation, coping skill, pacing in their activity. For sure, we need an interdiscipline and multimodal approach. We involve many other disciplines, such as occupational therapy and psychologists, psychiatrists. If we think that we want to try strong opioid in this chronic non-cancer, we must sit down and have a long discussion. Help the patient to set up their goal, long-term and short-term goal, what they want to achieve. At the end of the session, patient have to sign a contract to spell out their right and responsibility. And strong opioid is not a lifelong treatment in chronic non-cancer pain. We will tell the patient when we will stop the medication. And please not to increase the strong opioid more than 120 milligram equivalent to oral morphine. In long run, we see more side effect. It's only more risk than benefit if we start a strong opioid in a chronic non-cancer if we do not know when to stop it. Patient will have problem with their hormonal hypogonadism, immunological suppression, cognitive impairment, issue of addiction, tolerance, and opioid can induce hyperalgesia. If you all want to find out more about this, we have a guideline, the use of strong opioid in chronic non-cancer by MASP. You can look up for how to stratify the addiction risk before we start. You can find a opioid contract. They will tell you how to start and when to stop and how to check the patient aberrant behavior in this chronic non-cancer pain. So, like I mentioned, chronic pain is not easy, it's difficult to treat. We need to understand about few principles. In chronic non-cancer, we focus on the pain management rather than to cure the pain. No need to repeat in CT scan, MRI every year again and again. Our main focus on non-pharmacological treatment. When they have a severe pain, try to apply this. Our goal is to improve patients' function in occupational, social, and emotional domains. Pain relief is de-emphasized. We are not treating patients' pain score. Behavioral rather than a disease prospect. In clinic, we teach about cognitive behavioral therapy, thought challenging, how to have effective communication when you have severe pain, when you have people talking behind you in the workplace, how to manage stress and anger. We emphasize an active rather than a passive approach to treatment. No bed rest, no hot and cold pack. Patient must do stretching, strengthening exercise. It's time for patient to get up from their bed. No more long MC, no light duty. So in any chronic disease, we can see that promulgation of self-help. Patient role is active. Patient is responsible for their own improvement. And in the clinic, we have our team member, we have interdisciplinary team member to help them from various aspects. So without fear also, we will teach the patient about patient education about chronic non-cancer pain. It is very important for patients to understand about their disease. So in Malaysia, we have this patient education program called Menang. In Selayang, we can refer our patient for this intensive pain education. So here I have come to the end of my presentation. I would like to end my presentation with this saying, remember R.A.T, share and teach your other colleagues about R.A.T, apply R.A.T approach in our clinical practice. By using this simple framework, we can improve life around the world by training health workers to recognize, assess, and treat pain. Thank you for your attention. Thank you.
Good morning, everyone. My name is Violet. I'm a pharmacist currently working in Hospital Sultanah Bahia, Alostar. And first of all, I would like to thank the organizers for giving me the opportunity to share a little bit regarding this topic, safe prescribing practices in pain management services. As all of you already know, pharmacists do not prescribe medications, but we process all prescriptions prescribed by doctors and try our very best to ensure that the medications dispensed to the right patients are of the right drug, right strength, right quantity, right dosage, right frequency, and right formulation. All steps undertaken in the pharmacy are to ensure safe and effective medication management for the patient. So for these 15 to 20 minutes, let me humbly share some of these subtopics for safe prescribing practices in pain management services. We will first go through the list of common pain medications available in most facilities, their side effects and management, contraindications, drug-drug interaction, and common errors or insufficiencies that we see in prescriptions. Pain medications are divided into 4 main categories: paracetamol, NSAIDs, opioids, and under adjuvants there are anticonvulsants, tricyclic antidepressants, serotonin norepinephrine receptor inhibitor, and SNRI, lidocaine medicated plaster, and there are many more such as ointment or cream that contains analgesic or anesthetic properties. And for paracetamol, we have the tablet formulation, and in KKM setting, it is a 500 mg tablet. The syrup formulation, we have 2 strengths, suppositories with 2 strengths. And for injection formulation, it is a KPK item. KPK is now known as UKK item, ubat kelulusan khas. And we have NSAIDs. Under NSAIDs, there are non-selective type, the diclofenac, mefenamic acid, naproxen, ibuprofen, ketoprofen gel, and so on. And we have selective COX-2 inhibitor, such as Celebrex, celecoxib, 2 strengths, etoricoxib, and also paracoxib, dinastat injection. For paracetamol and NSAIDs, they are mostly used for mild to moderate pain. For moderate to severe pain, we can use opioids, and we have weak opioids such as tramadol, 50 mg cap, and also dihydrocodeine, known as the F118. As for strong opioids, we have morphine, such as aqueous morphine, oral formulation, and also injection morphine. Oxycodone, we have the immediate release formulation, the prolonged release formulation. Note the different strengths available. Oxycodone injection, oxycodone plus naloxone, known as Targin. We have 4 strengths available. Naloxone is actually to reduce the opioid-induced euphoria and constipation, which is the common side effect of oxycodone. We have also fentanyl patch, fentanyl injection, buprenorphine patch, pethidine injection, and also methadone syrup, but it is less widely used. Under adjuvants, we have anticonvulsants. As you can see in the photo, we have gabapentin 100 mg, 300 mg, and 600 mg strength. Pregabalin 50 mg is UKK item, and 75 and 100 mg cap also available but LP item. Carbamazepine 200 mg, normal release, and controlled release we have 200 mg and 400 mg. Tricyclic antidepressants, we have nortriptyline and amitriptyline 10 mg, which are UKK item, which means they need special request from the specialist, and also 25 mg, which is the standard item. SNRI, we have duloxetine 30 and also 60 mg. The side effects and management. For paracetamol, also known as acetaminophen, it is generally safe and well tolerated. Adverse effects include rash and allergic reaction. And to avoid, we can actually ask the patient whether they have any allergy history with PCM. And if they do, whether they know the brand or not, because some of them only allergic to certain brands. And if patient develop the allergy reaction, doctor can actually fill up the allergy form and request pharmacists to issue an allergy card for the patient to avoid future allergies with PCM. And in the allergy card, you can note which brand patient is allergic to, okay, and the symptoms that develop. For pharmacists, we can advise the patient to bring the card everywhere they go and even show to the dentist or to the pharmacy when they buy any medication. Okay. PCM can cause fatal hepatotoxicity if overdosed, so we will advise the patient to take within the recommended dose. For non-steroidal anti-inflammatory drug and NSAID, the common adverse effects are GI disturbances, GI discomfort, nausea, diarrhea, GI bleed, and also ulceration. As prevention, we advise the patient to take NSAIDs after food, with food or after meal. Okay. We can also, to reduce the duodenal and gastric ulceration, prescribers can give selective COX-2 inhibitors such as Celebrex whenever possible, or to give NSAID with a gastroprotective treatment. For example, MMT tablet, MMT syrup, or PPI such as pantoprazole. So I've summarized the criteria on when to give gastroprotective treatment into A, B, C, D. A, if the patient is more than 60 years old or patient is taking alcohol. B, is if patient has any bleeding history, gastro bleeding history. C, patient is taking concomitant corticosteroids, anticoagulants, or cigarette smoking, active smoker. Or D, patient has any dyspepsia history. So if patient fulfills any of these criteria, prescriber can consider to give gastroprotective treatment together with the NSAID. And last but not least, do not use more than one NSAID at a time. Other adverse effects of NSAIDs include platelet dysfunction, renal failure, hypertension, hypersensitivity reaction, rashes, angioedema, bronchospasm, increased cardiovascular events, headache, dizziness, insomnia, vertigo, hepatic damage, and also fluid retention. Okay, there are two things that we can avoid in adverse effects for NSAIDs. First is to avoid AKI, also known as triple whammy, drug-induced renal failure. So if patient is taking ACE inhibitor or ARB such as perindopril or ramipril, and ARB such as valsartan or temlisartan, and patient is also on a diuretic, for example, furosemide, we will try to avoid NSAID in this type of patients because it might induce renal failure, AKI, acute kidney injury. Okay, so it is good to know the current medication from any facility and to advise patient if really necessary to watch out for the effects and also monitor patient closely. But best is still to avoid NSAIDs in this type of patient. The other thing that we can avoid is bronchospasm or any hypersensitivity reaction in patients with asthma, to avoid NSAID in patients with asthma. Okay, if patient develop any hypersensitivity reaction with one of the type of NSAIDs, they might also develop in another type of NSAIDs due to cross-sensitivity. So it is best to avoid any types of NSAIDs in this type of patient. But COX-6 are generally safer, such as Celebrex. So we have to challenge it with care. Okay, we go to case number 1. Mrs. M just undergo total knee arthroplasty. After operation, she was prescribed with Denastat IV for 2 days. Patient's medication prior to operation include Celebrex 200 mg OD, which is also served after operation when patient can tolerate orally. So as healthcare givers, we should try to avoid a situation when IV NSAID and also oral NSAID is given together because it is often seen in the ward also. Okay, so we will try to avoid this scenario to avoid the adverse effects. Okay, case number 2, Mr. Q was admitted for chronic abdominal pain. Upon interview by the pharmacist, he admits buying analgesics from different retail pharmacy twice. First, he got mefenamic acid, and the second time he bought ibuprofen within 2 weeks due to other pain. And when he went to A&E last week, he got diclofenac. So in this scenario, this is a real case scenario. This patient was taking NSAID, 3 types of NSAIDs around the same time. So it is very important to get the full history from patient and to look out for patients who are buying NSAIDs themselves outside. Okay, so we can avoid and also counsel patient to teach patient to avoid 2 or 3 types of NSAIDs at the same time. Okay, for opioids, the side effects are dizziness, drowsiness, irritability, sedation, confusion, constipation, respiratory depression, withdrawal symptoms, and constipation. It can be easily avoided if we give patient laxatives, for example, lactulose or bisacordyl, especially for patients with long-term opioids. Okay, So for pharmacists who realize in the prescription there's only long-term opioids without any laxatives, we can actually intervene or discuss with the doctor to see whether there are any available laxatives for this patient, okay, to avoid constipation. Because patient is already in pain, so if patient further develops constipation, the pain will not go away and further worsen the pain. Okay, for gabapentin and pregabalin, common side effects include dizziness and drowsiness, mild peripheral edema, GI symptoms, and for gabapentin, there's a risk of dysphagia due to depressed CNS. Okay, so it is best to start gabapentin or pregabalin with ON dosing and slowly titrate up when necessary. For contraindications, analgesics in renal impairment is one of the common questions from prescribers. Which type of analgesic is the best for patient with renal impairment? Okay, for fentanyl, there are no active metabolites and not removed to any significant degree by dialysis. So no dose adjustment needed. For fentanyl injection, it is quite safe to start with fentanyl injection in patient with renal impairment. But do not start fentanyl patch in any patients that are opioid naive. Okay. For morphine, the major metabolites M3G and M6G excreted via kidney and it will accumulate in renal impairment. It will lead to delayed sedation and also neurotoxicity. So dose adjustment is recommended, or we should use any alternative opioids whenever possible. As for oxycodone, the metabolite oxymorphone is active, but the plasma levels are normally negligible. So no dose adjustment required in most patients. We only need to monitor and also adjust if necessary. As for pethidine, accumulation of norpethidine, the active metabolite, can lead to neuroexcitation and leading to seizures. So it's best to use alternative agent. For tramadol, the increased mu opioid effects from the active metabolite M1 is renally excreted. So dose adjustment is recommended. We should use alternative in significant renal impairment. Gabapentin and pregabalin, I will share the tables for these two medications later, because the impaired renal function reduces clearance in direct proportion to creatinine clearance. Okay, so dose adjustment is recommended based on the creatinine clearance of the patient. As for amitriptyline, it is metabolized in the liver to nortriptyline, the active agent, but there's little evidence to indicate the need for dose reduction. Okay, these are the tables that I would like to share. For gabapentin, as you can see in the table, if patient's creatinine clearance is more than 60, which is normal, the total daily dose can go up to maximum 3,600 in TDS. If patient's creatinine clearance is 15 to 30 only, the maximum can go up to 700 mg only, OD. Okay. As for pregabalin, if the creatinine clearance is normal, more than 60, the total daily dose can go up to 600 mg per day. Okay. But if the patient's creatinine clearance is 15 to 30 only, the maximum dose that can go up is until 150 mg only. Okay. Okay. The other category in contraindications that we often get is analgesics in pregnancy. Okay. Paracetamol, the pregnancy category is A, is generally safe and well tolerated. But for opioids and NSAIDs, the category is C. For opioids, it may cause respiratory depression and withdrawal symptoms in newborn, whereas for NSAIDs, it may cause closure of the fetal ductus arteriosus, fetal renal impairment, inhibition of platelet aggregation, and delayed labor and birth. For gabapentin and pregabalin, the category is B1 or B3. For amitriptyline, category is C. The withdrawal symptoms in newborn infants have been reported with prolonged maternal use of this class. And carbamazepine, the category is D. Spina bifida occurs in about 1% of pregnancies in which carbamazepine is used as monotherapy. It can also cause coagulation defects with consequent risk of hemorrhage in the fetus. So avoid carbamazepine is the best. But for opioids and NSAIDs, it's best to avoid them unless the benefit outweigh risk. Okay, and we have to tell the patient regarding this choice and whether the patient accepts it or not. As for drug-drug interactions, I've summarized it into one short table. Okay. For tricyclic antidepressant, for example, amitriptyline 25 mg, try to avoid in a combination with MAO inhibitors such as selagiline, because it might increase the serotonin level in patient. When the serotonin level is too high in our body, it might lead to serotonin syndrome. The symptoms are such as palpitation, agitation, confusion, sweating, and also in worst case scenario may lead to seizure and also unconsciousness, which may be quite dangerous. So if the combination is necessary, we have to tell patient regarding this and to inform if there's any symptoms of serotonin syndrome. Okay, next is if there's SSRI such as sertraline, prozamin, or escitalopram, or any anticholinergic agents such as tortarodine, we have to tell patient regarding the increased anticholinergic side effects to watch out for, such as dry mouth, dry skin, urinary incontinence. Okay, and also if patient is on any antiarrhythmic such as amiodarone, best to avoid amitriptyline because the arrhythmia might be worsened. And if patient is already on tramadol, which is in most of the chronic pain patients, it might increase the seizure risk and depress CNS. So it is best to avoid in patients with any seizure history, and also to counsel patient to inform the prescribers if there's any seizure to monitor them. Okay, best to avoid amitriptyline and tramadol together. But if really necessary, we have to inform the patient. Okay, and also to avoid any agents that prolong QTC interval. As for SNRI, such as duloxetine, best to avoid with any MAO inhibitor or tricyclic antidepressant. And also tramadol, it might lead to serotonin syndrome. And as for warfarin, it might increase the bleeding risk. It will disrupt the INR level. So best to avoid duloxetine in patients with warfarin or to monitor the INR very closely. As for anticonvulsants, carbamazepine level is affected by the cytochrome 3A4 inducers and inhibitors. Okay, and also the level might be increased if taken together with grapefruit juice. As for antacids, it will affect the absorption of gabapentin and pregabalin antacids such as MMT syrup. Okay, so best to counsel patient to take at least 2 hours apart if really needed to be taken together. Next, we'll go to the common errors and insufficiencies in prescriptions that we often see. First is regarding unit confusion. So between mg and ml is often confused, which I will explain more later in a case study. Second is the duration of medication not stated. For example, PRN, but it is not stated as PRN. Maybe the medication must be taken until the TCA, but only prescribed for 1 or 2 weeks, which is not enough until the TCA date. Third is did not prescribe gastroprotectants or laxatives whenever indicated, which I've explained earlier on. And fourth is the strength not stated, especially for manual prescription, or the wrong strength is prescribed. For example, doctor intended to give gabapentin 300 mg, but accidentally ordered 100 mg. Okay. So this is case 3 regarding the mg and ml confusion. Mrs. X follows up clinic and is prescribed with aqueous morphine 10 ml. Upon asking by the pharmacist, Mrs. X claims that she used to take only 5 ml and doctor didn't mention to increase the dosage. So upon asking the doctor, actually doctor would like to continue the current dosage, which is only 5 ml or 10 mg, because aqueous morphine, it is 10 mg per 5 ml. So instead of writing 10 mg, accidentally wrote as 10 ml. we are using the system, his system. So sometimes the mg and ml, if I click wrongly, it might the order will be wrong. So we have to be careful about that. For case number 4, Mr. K is prescribed with aqueous morphine for severe acute pain post MVA for 2 weeks. However, no TCA date was given until 3 months later. So this case, patient is having severe acute pain. So actually, patient will need the aqueous morphine for until the TCA for around 3 months, but only prescribed for 2 weeks. So around 2.5 months, patient is do not have any analgesics. So this is very important because it might lead to chronic pain if the acute pain is not treated properly. Okay, so these are some of the references that I've used, and I thank you all for your kind attention.
Very good morning to everyone. Today I'll be presenting on multimodal analgesia from a clinical perspective. Hi, I'm Dr. Kerpagam Nadarajan, currently working in Hospital Sultan Bahia. What are the goals of perioperative pain management? Basically, one of the goals is to relieve suffering or reduce pain in the patients. When we reduce pain in the patients, we're able to achieve early mobilization after surgery. And by reducing suffering and achieving this, we can thus reduce length of hospital stay and achieve a better patient satisfaction. One of the optimal strategies for perioperative pain control seem to be multimodal analgesia. So when we administer 2 or more drugs which act by different mechanism and thus providing additive of synergistic analgesia, this is known as multimodal analgesia. So when we say multimodal analgesia, it is when we administer the drug via a same route or different routes, and it reduces the dependence on a single medication and mechanism. Multimodal analgesia also helps to lower the doses of each drug that needs to be administered, and thus reducing the adverse effects of the drug. It also eliminates or reduces the need for opioids, and the synergistic relationship between opioid and non-opioid medications reduces the overall opioid dose as well as opioid-related unwanted side effects. And the WHO analgesic ladder, which is modified, is used for management of acute pain. So basically, the ladder is used in reverse. And as we all know, postoperative pain patient's pain can be quite severe. And usually we will start at step 3, where we use stronger opioids such as morphine or oxycodone. And then as the pain reduces, we can taper down to a milder analgesic such as paracetamol and NSAIDs, or sometimes they can all be used in combination. And also we need to give appropriate bowel prophylaxis and also antiemetics to the patients. And may need to add antineuropathic agents or steroids, and also original box wherever possible. So multimodal analgesia basically reduces the doses of drugs that we use, gives improved pain relief because it acts on different receptors, reduces the severity of adverse effects of the drug, and this gives rise to earlier discharge and overall decreased cost of patient stay in the hospital. What are the target points of analgesic drugs? So when we look at the pain pathway, from the point of the surgical stimulus up to the brain, there are many points at which our drugs act on. And at the point of the skin or the nociception, where the surgical stimulus occurs, the transduction of pain is blocked by corticosteroids, NSAIDs, coxips, and local anesthetics. This is also done by opioids, gabapentinoids, and clonidine. The transmission of pain, if you look at it, is blocked by local anesthetics, and the modulation of pain basically by drugs such as opioids, gabapentinoids, clonidine, and the coxips. At the CNS level, we have ketamine and paracetamol acting at this point. The pain response in the surgical stimulus with the surgical stimulus seem to be hyperalgesic and also allodinic. So what happens in these patients is that when we look at this graph, this is a normal pain response in the patient, and a graph is shifted to the left in the patients who has had injury or when there is any surgical stimulus in the patient. So they have a heightened pain response to a similar stimulus intensity, heightened pain response. So this is known as hyperalgesia, and to a lower stimulus intensity, also a heightened pain response known as allodynia. So many drugs such as ketamine and Brisedex helps to reduce this hyperalgesic and alginic response over the period of pain. What are the factors affecting decision? How do you decide on the type of or mode of analgesia? So these are the questions that we need to ask ourselves before we decide what mode of analgesia to use. How much pain is actually associated with surgical procedure? Is it a major op? Is it the pain can be very severe? Then we need to use stronger opioids, or we use epidurals and regional blocks to actually overcome the pain. How long is the pain expected to last? So we have to roughly estimate and make sure that analgesia is provided throughout the period of pain. Is the procedure amenable to use of regional or local analgesic techniques? So advocate use of regional or local analgesic wherever possible. What are the patient factors that affect the choice of analgesia? Is it a child? Is it a pediatric case? Or is it a patient who's had a chronic opioid usage? These are patients in which the choice of analgesia is important, and we need to look through it carefully. Also look into human resource. Are there enough staff to manage the APS post-operatively? Are there enough staff to troubleshoot in case of any faulty machines, such as the PCA machines or PCRA machines? What are the available drugs in your hospital? And what is the clinical environment in which the patient is put in post-operatively? And are there enough staff to monitor any complications that may arise from your analgesic technique? These are the analgesic modalities that are available currently. And okay, let me start with paracetamol. Basically, it's a cheap, safe drug. It can be given orally, rectally, or intravenously. Good for mild pain. And when there is moderate to severe pain, it can be used in combination with other drugs such as tramadol and NSAIDs. In liver failure patients or in patients with liver impairment, we try to avoid paracetamol. Okay, this is a graph showing effect of IV paracetamol and oral paracetamol compared to placebo. It's found that IV and oral paracetamol gives adequate good analgesia when compared to placebo. And of course, the IV paracetamol shows a rapid onset and peaks faster compared to the oral analgesia, but the duration of action is similar in both IV and oral. Okay, paracetamol has been found to have opioid-sparing effects, and in most surgeries, we find that there's a reduced total morphine consumption. Example, in orthopedic surgery, spinal fusion, hip arthroplasties, and various other surgery types, it is found that with IV paracetamol, the total morphine consumption comes down. Paracetamol is often given in combination with drugs such as tramadol or NSAIDs, and I find that it produces a synergistic effect, so dose reduction is applicable when they're used together. And also this combination is good in patients with medical issues such as gastritis, or if they have hypertension, CVA, ischemic heart disease, or any renal impairment. It's quite a safe combination to use. However, the dose of tramadol may need to be adjusted slightly in renal impairments. So there are a few studies that were done showing the usage of paracetamol and NSAIDs on its own versus in combination, and the combination of the drugs shows enhanced analgesic effects. So this shows a combination of paracetamol and NSAIDs offer superior analgesia compared to either drug alone. Okay, move on to NSAIDs. So usage of NSAIDs is basically for acute pain and also for any chronic inflammatory conditions. Can be given oral, IV, or IM. And there are two types of NSAIDs. It's the selective and also the non-selective NSAIDs. Selective COX-2 inhibitors include the celecoxib, pericoxib, and the non-selective includes the Voltaren, mefenamic acid, naproxen. Okay, there are many different types of NSAIDs available in the market. So NSAIDs, ideally, we should not use in patients with renal impairment and also patients with bleeding tendencies on anticoagulants. And we need to use with caution in patients with gastritis, maybe add on a proton pump inhibitor. Patients with IHD and stroke, asthma, and ICB may need to be used with caution. However, short-term use in these patients have been found to be quite safe and does not induce an ischemic event. Okay, when we use NSAIDs, we always have to weigh the pros and the cons, the benefits and the side effects. If the side effects overweigh the benefits of the drugs, then of course we need to find an alternative. So NSAIDs versus COXIBs for postoperative pain, it is found that COXIBs are a better alternative compared to the non-selective NSAIDs. And as COXIPs are associated with reduced GI side effects and also absence of antiplatelet activity. So if you have to choose between the selective and non-selective for post-op pain, they suggest that we go for the selective COX-2 inhibitors. All right, then I move on to opioids. Opioids basically can be given IV, oral, subcutaneously, or via patch. Can be used for moderate to severe pain. And opioid analgesics are widely accepted for acute pain. However, for chronic pain, usage of opioids remains controversial, and we do not start opioids for chronic pain unless really we have run out of options, right? And even then, opioid contracts are needed. The synergy between opioid and non-opioid medications reduces both overall opioid dose and unwanted opioid-related side effects. There are many different types of opioids in the market. The ones that we have in our hospitals, is dihydrocodeine, morphine, oxycodone, fentanyl, and pethidine. So they basically act on mu agonists unless they have agonist-antagonist effect or partial agonist effect like buprenorphine. Then there is some action at the kappa and the delta receptors. So before we start opioid, we need to look into the rules of starting. Basically, we need to prescribe the lowest effective dose of the immediate release opioids. And basically, we give the treatment for 3 days or less, which is usually quite enough for most post-operative conditions. Follow-up is definitely needed by the APS team and until we stop the strong opioids. Of course, opioids have to be prescribed according to the laws in the place where you work, and also we need to provide instructions on how to taper opioids in some patients where maybe the opioid usage is slightly longer than the 3 days. Side effects. There are some side effects associated with opioids, such as tolerance. So meaning that, especially this is seen in patients who have chronic opioid usage, they might need to take more of the same medication to provide the same amount of pain relief. Some patients may be constipated, nausea and vomiting can be seen. However, if it's severe, then we need to stop the opioid and consider an alternative. Dry mouth, sleepiness and dizziness. So in these patients, you have to be careful. If we overdose the patient, then we may need to reduce the dosage of the opioid given or stop altogether. And physical dependence, meaning you have withdrawal symptoms when the medication is stopped. This can develop within a few days of administration of opioids. In some studies, up as early as 7 days after administration. Confusion in some patients, especially in the elderly. So we try to avoid usage of strong opioids unless necessary, and even then doses will be reduced. Some patients, depression and itching. Okay, these are adjuncts that we can use as part of the multimodal regimen. Ketamine. Ketamine is a potent analgesia, sedation and amnesia. Many are using ketamine now perioperatively. It's found that ketamine preserves respiratory drive and airway reflexes. It acts also as an indirect sympathomimetic, so it's quite good for patients who are hemodynamically unstable. Usually I use ketamine for patients who are undergoing intra-abdominal surgeries, just bolus doses of 0.2 to 0.3 milligram per kilo, and also as a combination together with my regional anesthesia. So low-dose ketamine is advocated for pain management, usually in the range of 0.2 to 0.3 milligram per kilo bolus, and if needed as infusion, running at 0.1 to 0.2 milligram per kilo per hour. And some other side effects associated is delirium, dissociative anesthesia, dysphoria, and vivid illusions. However, with low-dose ketamine, this seems to be less. Okay, this is a consensus guidelines on the use of IV ketamine by the American Society of Regional Anesthesia. So they recommend sub-anesthetic ketamine infusions, sub-anesthetic doses, and advocate ketamine for opioid-dependent or opioid-tolerant patients undergoing surgery. And the doses recommended as follows. Okay, a systematic review and meta-analysis of role of ketamine in perioperative analgesia showed that ketamine basically reduced pain scores, reduce opioid consumption, especially in thoracic, upper abdominal, and major orthopedic surgeries. And this reduction is seen up to 72 hours post-operatively in some of the studies. Alpha-2 agonists. The drug that we have in our center is dexmedetomidine. It is good as an intraoperative analgesia in general anesthesia, given as a loading dose of 1 mic per kilo, followed by maintenance of 0.2 to 0.7 mic per kilo per hour. So it plays a good role in opioid-free anesthesia. Okay, these are some of the uses in the operation theatre. There are many different types of surgeries that we can use Presidex for. And in a study comparing propofol-based sedation and Presidex-based sedation, it is found that in Presidex-based sedation, 72% did not require morphine, compared to 37% in the propofol-based sedation. Okay, another study done comparing Dex infusion versus fentanyl infusion, it is found that the post-operative analgesia duration was more in the Dex group and shorter in the fentanyl group. And the sedation was highly profound in the fentanyl group, and also the quality of recovery was better in the Presidex group compared to fentanyl. Dexamethasone is another drug, a steroid that we use intraoperatively. Dexamethasone is found to improve post-op pain when used in doses of 8 or 10 milligrams. It lowered incidence of post-op nausea and vomiting. Shorter length of stay, and also, however, occurrence of post-op pain did not differ between the patients. However, there's a slight hyperglycemia seen in some patients, so need to monitor the blood glucose, especially in diabetic patients. Gabapentinoids, namely gabapentin and pregabalin, it gives good analgesia for neuropathic pain, has got some anxiolytic and anticonvulsant effect. It has got opioid sparing effect, and in our setting, we use it for patients who have undergone spine surgeries, who preoperatively may be already on gabapentin, so we continue it post-op. Patients who have undergone amputations who exhibit signs of phantom limb pain, and reconstructive surgeries where there are a lot of tissue damage and possible nerve damage as well. And this helps in preventing chronic neuropathic pain. So some studies that have shown gabapentin and pregabalin for post-operative pain management, it's found that it reduces the usage of opioid, and it allows opioid to be stopped early. However, the drawback was that there was many variation in clinical practice regarding the timing of when the gabapentin was given and also the doses. So the gabapentinoids basically enhance analgesic effects and when used synergistically with NSAIDs, such as celecoxib, and is found to be superior to either single drugs for post-operative pain following spinal fusion surgery. Okay, another technique that we can use as part of the multimodal regimen would be the regional anesthesia. There are many different types of regional anesthesia: intravenous block, peripheral nerve block, plexus block such as brachial or lumbar, and neuroaxial block such as epidural or spinal. So advantages and disadvantages, basically it helps us to avoid general anesthesia in high-risk patients. It provides stable intraoperative conditions because it does not affect the hemodynamics so much, and it is effective as a perioperative, intraoperative and postoperative analgesia. And because it is a localized effect, so there's not much nausea and vomiting. It helps in some ways. There is some degree of vasodilatation, especially when the block is given at the limbs, and this helps to reduce risk of deep vein thrombosis. Usage of regional anesthesia actually avoids usage of opioids in the elderly, and preoperative pain control, it can be used for patients with ischemic limb, even preoperatively, and there's no effect on bowel motility or urinary function. And by giving regional anesthesia also, we find that patients recover from the surgery very fast. By the next day, they're sitting up on the bed, they're moving their joints with minimal pain, and most of them are ready to go home, right? So what are the disadvantages? Disadvantages is that you need a certain set of skills to do blocks, and it takes time. It takes a bit of patience, and also in best hands, there are about 5% risk of failure rate. So when we compare regional anesthesia to on-demand systemic opioids such as PCA, we found that pain scores are improved, less nausea and vomiting, there's improved hemodynamic function or less hemodynamic dysfunction, decreased risk of chronic pain, there's no ileus, there's a lower risk of deep vein thrombosis, And because of the less pain, mobilization can be started earlier, and it helps in rehab. Okay, these are the few scenarios that we have for multimodal analgesia. These are the common surgeries that we usually do in most of the hospitals. Minor deep care surgeries, for example, children coming in for maybe inguinal hernia surgery or for orchidoplaxis. And so for these patients, maybe we try to avoid strong opioids as we will be discharging the patient early. So drugs such as paracetamol, a combination with NSAIDs, and also a combination of regional or local anesthesia helps in discharging patient early and also pain-free during that period. So regional, for example, inguinal hernia surgery, we can do a ilioinguinal block for the patient. And most we add short-acting opioids during induction. For extremity surgeries such as lower limb or upper limb surgeries, regional anesthesia can be used unless there's a contraindication. And for post-operative pain, we can add on paracetamol, NSAIDs, or paracetamol tramadol. For some of the examples would include a brachial plexus block for radius ulnar fracture. And for minimally invasive abdominal surgeries, such as laparoscopic surgeries, sometimes all you need done under GA, we can add on PCM and NSAIDs and also give a local infiltration analgesia. For some abdominal wall surgeries, maybe we can add on an interfacial plane block, such as a TAP block, or rectus sheath block for midline surgeries. For major abdominal thoracic surgeries, of course, we need a higher end analgesic technique such as epidural anesthesia, interfacial plane blocks such as erector spinae plane block or paravertebral blocks. It helps to reduce pain in these major abdominal thoracic surgeries. And also we can add on PCM combined with NSAIDs together with ketamine intraoperatively. And if epidural and blocks are contraindicated, then we may consider PCAM or PCAF or oral oxycodone once a patient has started taking orally. Okay, in arthroplasty surgery such as TKR, THR, usually we try to do it under regional anesthesia, combined spinal epidural, unless it's contraindicated. Intraoperatively, usually we will top up the epidural, and postoperatively in our center, what we do is we remove the epidural catheter. Prior to that, we give them a block such as a fascia iliaca block or a adductor canal block, or a femoral nerve block with catheter inserted. If the surgeon requires extensive physio postoperatively, they would tell us, and we would insert a catheter for the patient. And for these patients, we find that the postoperative pain control is very good, and patient usually ambulates quite early and discharge quite early. And sometimes for patients with this block, we also add on oxycodone as rescue analgesia. For patients with craniotomy, usually we try to avoid strong opioids, so we give them drugs like paracetamol or short-acting opioids like fentanyl if needed, gabapentinoids, and sometimes we add on scalp block to minimize opioid use if NSAIDs is not an option. Okay, usage of NSAIDs and ketamine needs further research regarding the safety. Okay, for patients who have had amputations, preferably we try to do it under regional blocks and add on PCM NSAIDs or PCM weak opioids post-operatively. And if there is any during our visitations, during the APS rounds, if there are any complaints of phantom limb pain, then we may add gabapentinoids for these patients, or even amitriptyline. For patients with nerve injuries, we try to avoid regional blocks in these patients. No nerve injuries. So for them, we usually go for paracetamol, NSAIDs, weak opioids, and other drugs wherever possible. Okay, in special populations, such as patients who are morbidly obese, so in these patients, there's an increased risk of respiratory depression with opioids and sedatives. So therefore, we opt for regional anesthesia wherever possible. We minimize the sedatives and opioids, combined spinal epidural maybe, and if need oral analgesics, paracetamol, NSAIDs, or weak opioids. And if patient needs strong opioids, maybe a PCA fentanyl. For opioid-dependent patients, in these patients, opioid requirement may be high and unpredictable. So we try to opt for other techniques such as regional blocks wherever possible. And of course, PCM, NSAIDs, ketamine, and lignocaine wherever we can. So in these patients, maybe there are special indications for opiate-free anesthesia and analgesia. So this includes patients who are obese, patients with obstructive sleep apnea, COPD, patients with complex regional pain syndromes, opioid addiction, and also cancer surgery. Okay, so breastfeeding patients, we avoid codeine and tramadol because of the potential transfer of active metabolites into the maternal milk, which may cause infant sedation and fetal overdoses in some cases. And avoid pethidine and aspirin also because these drugs also spill into the breast milk. Drugs such as PCM, NSAIDs such as diclofenac, ibuprofen, and opioids such as morphine, oxycodone, and hydrocodone displays very low concentration in the breast milk and can be used for breastfeeding patients. Okay, pregnancy is another condition where regional anesthesia is used wherever possible. Spinal anesthesia or combined spinal epidural together with intrathecal morphine, or if epidural is inserted, epidural morphine. And sometimes if it's done under general anesthesia, we would include local infiltration analgesia, intraoperative opioid if it's under GA whenever needed, and maybe can add on PCM, tramadol, ketamine, and also NSAIDs for postoperative pain relief. And also if under GA, maybe some patients are discharged with PCA morphine or PCA fentanyl. So in conclusion, multimodal analgesia is found to improve the analgesic experience of the patient. It reduces the doses of the drugs that need to be used, thus reducing side effects of the drugs. This allows early mobilization, early enteral feeding, rapid recovery from the surgery, and also a lower cost in general. So in multimodal analgesia also, when we include epidural or nerve blocks, it produces the optimal analgesia, but also may prevent occurrence of chronic pain after the surgery. Okay, so our ultimate aim is to have the patients looking like this post-operatively. This is Mr. S. He underwent quite extensive surgery for GIST tumor. So this is post-op day 2. We did the patient under GA with thoracic epidural, and post-operative day 1 in the morning, his pain scores were around 5 to 6. His in-situ spirometry was probably about 1 ball at the time. And what we did was we increased the infusion of the epidural, and then we added on IV PCM and IV Danistat. This was the next day, post-op day 2. He was much more comfortable. Pain scores were around 1 to 2. He was happy. Was able to blow up to 3 balls in the in-situ spirometry. Post-op day 3, I think he was discharged home. With that, I end. Thank you very much for your attention. Hoping soon for the days when we can travel again. Here's me signing out. Thank you.
Assalamualaikum and a very good day. So we're going to proceed with our next talk, will be the maximizing labor analgesia. So a good labor pain management would contribute to an improvement in maternal and fetal outcome, improving in breastfeeding, improvement of mom and baby bonding, and also mothers with good pain relief also had a better psychological outcome. Labor pain management has been shown to contribute to the reduction of postpartum depression based on these 2 studies. The stages of labor can be divided into 3 stages, and it is associated with different description of pain by the parturient. In the first stage of labor, there will be maternal perception of regular painful uterine contractions and ends with the complete dilation of the cervix. Second stage is probably the most intense stage in which the cervix will be fully dilated and ends with the birth of the infant, followed by the third stage, which is the birth of the infant and ends with the delivery of the placenta. This is the peripheral pathway and mechanism of labor pain. You can see here, this is where our epidural analgesia would take their actions. Labor analgesia can be divided into two different methods, and the first would be our bread and butter, as in obstetric anesthesia, regional or neuraxial analgesia, followed by what it can be also given by the midwives or the obstetrician themselves, pethidine, nalbuphine, or PCA, fentanyl and remifentanil, which will be prescribed by us anesthetists, and also the nitrous oxide. So I'm going to talk more on the PCA fentanyl first as a systemic analgesia. This is our second most method of giving labor analgesia in Hustanah Bahia. This is especially so in patient who is contraindicated for direct cell blockade, such as sepsis, dengue, low platelet, high intracranial pressure, or patient who had any coagulation disorders or anticoagulant therapy. We also offer PCA fentanyl in patients who had intrauterine death, and also if patient being subjected to a medical termination of pregnancy, we also offer PCA fentanyl. So this is the suggested protocol and the usual protocol that we have been using in Arshad. There has been increasing interest in PCA remifentanil, and whether the usage of PCA remifentanil can actually reduce or can be offered as a better or equal alternative to labor analgesia. So it has been shown that PCA remifentanil is an ultra short acting synthetic phenylpiperidine. The onset is very rapid, so does its offset. There is no accumulation even after a long period of time, but the maternal adverse effect is quite worrying. The fact that from all the 32% of patients studied, there are some degree of ventilatory depression, and there has been emphasized on the need for capnography monitoring to identify these complications. And a lot of obstetric units are now questioning the safety of PCA remifentanil. Probably in a center where you can actually afford one-to-one midwives and patients monitoring, and the labor unit is well equipped with resuscitation and intubation, and the medical officers in charge is not far away from the labor suite, and that probably would be an ideal setup if you want to give PCA remifentanil. It provides a very good analgesia for patients, but it must be prescribed by an anesthetist, and you can't allow the nurses or the midwife to actually use this PCA to administer to the patients. So this is the suggested protocol that has been used in HKL obstetric analgesia service. I honestly do not have the experience of using this in my own center because of the lack of staffing, and if you look into the current issues with all the pandemic, the staff in labor suites are sometimes really short with quarantine and staff being deployed to other places. You also must remember that if you wanted to prescribe PCA remifentanil, you must also give patient antiemetic because of its very highly potent. It also can cause quite significant significant nausea and vomiting, so you have to prescribe either IV metoclopramide or ondansetron. There's a recent study, I think 2-3 years back, in which they look into the usage of pethidine versus PCA remifentanil. So they looked into the outcome of whether there is any increase in epidural conversion, and they compared this between two groups, which is PCA remifentanil versus pethidine group. And you can see that overall maternal satisfaction was very high in PCA remifentanil, and patients who used PCA remifentanil, they have a lower incidence of requesting to convert to epidural analgesia compared to pethidine group. And yes, the episode of desaturation or surgery requirement is much higher in remifentanil group, and thus the question is also being raised about the possibility of using this in a very busy labor unit in which you can't really afford to have a stringent monitoring of the patients. So let's talk about neuroaxial labor analgesia. This is probably the gold standard in labor pain management. In multiple studies, it has been shown that patient relief, pain relief in patient is the greatest in patients who receive epidural analgesia. So the mechanism and contraindications can be looked into this from this slide. You can see that it blocked the impulses from the first stage and also second stage of the labor itself. And this is the absolute and also relative contraindications. Absolute contraindication needs to be assessed during pre-anesthetic evaluation. But sometimes there are certain cases, certain cardiac conditions that would benefit from epidural, and some experienced anesthesiologists would still often give the axial anesthesia in this group of patients. So these are the component central to the decision making in what's best to give to the patients. So what are the methods that you want to use? What type of local anesthetic that you are familiar with? And what can you add to improve the quality of your block without causing more complications? And how do you maintain those analgesia? And also whether you wanted to use a high volume with low concentration or low volume with high concentrations. So we will look into that. So we are familiar with epidural technique. We are also quite familiar with CSE technique. I do use CSE technique, and I would suggest that for CSE technique, you can use this in patients who presented to labor suite with very high pain score. And this is also a method that I really prefer to use in a patient with morbid obesity, because with the finding of a CSF flow, I am quite guaranteed that my epidural would be midline and in space. Compared to the conventional epidural, sometimes you may get a patchy block or it may not work. So it is important to look at also the characteristic of your patients before you choose whether you wanted to employ the usage of epidural or CSE. But there is one very interesting new method that was introduced in 2018 studies by Choo et al., in which the dura is perforated. It's the same as CSE technique. The dura is perforated with spinal needle, but we do not give any intrathecal medication. So this method has been shown to had a fewer side effects compared to combined spinal epidural. We noted that in combined spinal epidural, yes, patient will have more itchiness, especially when you use fentanyl, and you had an incidence of hypotension. It's higher in CSE methods. And of course, when you compared DPE to epidural, or even CSE with epidural, you can see that the asymmetric block is much higher with a conventional epidural, because you do get the sensation of loss of resistance, but you can't really guarantee that you are in the midline. And you may have this asymmetric block as part of the complications of a conventional epidural. So what about the maintenance of the labor analgesia? We have moving towards patient control epidural analgesia for the past, I think, 10 to 15 years, and now we are going into this program intermittent epidural bolus. So the conventional continuous epidural infusion, we do use it in our center. We still use it, especially after hours. Sometimes some of the AMOs who just started their MOT posting, they are not really familiar with PCEA. Sometimes they do use this continuous epidural infusion. The problem with continuous epidural infusion is you may have regression of block, because when you infuse continuously, the local anesthetic might just stay in one place, and your block is not going to be as wide, as broadly spread as other method that I'm going to talk after this. So we try to broaden our usage of PCEA as much as possible, and these are the regime that we use. We use a concentration of 0.05% ropivacaine with fentanyl 2 microgram, and this is the maintenance that we use with our CAT legacy PCEA. A lot of centers in Klang Valley, and I think probably in Penang or Ipoh, they have probably moving into the program intermittent epidural bolus. We do have one machine. We are going to start using it as soon as practical, as soon as possible. But unfortunately, we are also seeing less and less since the pandemic. We are seeing less and less delivery and also referrals for epidural. But nevertheless, this is very, very modern, very, very advanced, and very, very useful technique to actually employ in our labor as part of our labor analgesia. It has proven to have a greater spread within the epidural space. You have a much better sensory block. It has a local anesthetic sparing effect. It has been proven to have a much fewer instrumental vaginal deliveries and less motor blockade. This is because we are using a much you can see here the bupivacaine that they use, the ropivacaine that they use, although it's more or less the same. You can see that they will use a much diluted concentration of local anesthetic, and that leads to a fewer instrumental vaginal deliveries and less motor block, and this leads to improvement in maternal satisfaction, because the pain sensation is lost, but they still can maintain movement of their lower limbs. So these are the side effects of neural analgesia and complications. Both of these need to be explained to the patients prior to embarking to your neuraxial labor analgesia. Record keeping and monitoring is very important, as this will be a piece of paper that you're going to use for you to hand over to your colleague who's on call, and also for medical legal purposes. Right, so it's also important to clarify with the patients, because there's a lot of myth surrounding epidurals. Probably one of the most famous myth is the fact that it can cause back pain, whether it's permanent, temporary, or some thought that it can cause paralysis to the mother. So serious complication, you have to explain that serious complications are very rare, and some women have discomfort in the lower back for a few hours or days, but it doesn't last long. It won't harm the baby because of the amount of medication that reaches the baby is so small, and it does not cause slowing down of labor or increase the risk of having cesarean section. And it actually improves birth experience, and patients can also get any epidural at any time. Of course, this part of reassurance to the mother may not be agreed by some residents or some anesthetists, because towards the end, why do you want to still give to the patient? But patients in pain, you have to respect her request, and as much as possible, you wanted to make her experience as comfortable as possible. So that's the end of my talk. Thank you very much.
Hi everyone. In these 20 minutes, I'm going to present a topic about incorporating regional blocks for acute pain. This is the overview of my topics. We're going to talk a little bit about history of regional anesthesia, multimodal analgesia by definition, a little bit about the benefits of peripheral nerve block, the clinical efficacy, risk and the limitation of peripheral nerve block. The approaches to the nerve block were expanded during a period during 1980s and 1990s by the use of nerve stimulation guidance as an adjunct to surface anatomy. So, not surprisingly, this has declined in recent years with the advent of ultrasound guided approaches. In 1994, there is the first recorded ultrasound guided application in a real-time direct visualization of the brachial block at the supraclavicular level has led to an ever-increasing use of ultrasound as a tool in the field of regional anesthesia with the advent of more detailed, flexible, and mobile ultrasound scanners. By definitions, multimodal analgesia is referred to the use of combination of analgesia which acting with different mechanisms, and by doing so, we take advantage of the additive and the synergistic activity of each. By this technique, we can help to minimize the adverse event if we are using a single analgesic at the larger doses. Peripheral nerve block techniques are now commonly incorporated into multimodal post-operative analgesic strategies. With the advantage of ultrasound technologies, it's able the anesthesiologist to visualize neural structure, needle advancement, and local anesthetic spread in real time. Thus, this will help to prevent complications such as intraneural or intravascular puncture or systemic toxicity. This is the benefits of peripheral nerve block. It helps to improve in the postoperative pain control and reduce the use of opioids, reduce in hospital length of stay, prevention of hospital readmissions, reduce in the postoperative nausea and vomiting because we are not using opioids or less using it. It will provide faster recovery, early participation in physical therapy, and improve patient satisfaction. Let's talk about the clinical efficacy of peripheral nerve block. If we compare between PNB versus opioids, there are a lot of studies that have been published in the research. For example, I take Cochrane Library as my reference. In this is a big study where they compare between the single shot of femoral nerve block to intravenous patient-controlled analgesic opioids. It includes 45 eligible randomized controlled trials, involve about almost 3,000 participants from 47 publications. As a conclusion of this Cochrane study, it shows that there is a significant reduction in pain at rest and on movement for up to 24 to 48 hours, respectively, with significant less opioid consumption also for up to 48 hours. This is amazing. Before we go further, do we have an ideal peripheral nerve block? This is the few characteristic of ideal peripheral nerve block. Number one, it must have a sufficient duration of action to provide pain relief for the most intense period of post-operative pain, but at the same time do not cause dense block that could unpleasant the patient and can lead to safety issues such as falls. Number two, the ideal peripheral nerve block must has minimized to extent possible of complication, such as infection, neurologic complication, bleeding, and systemic toxicity. An ideal peripheral nerve block should also be easy to be performed, independent of technical skill of the anesthesiologist, and with minimal chance of failed procedures. And lastly, the ideal peripheral nerve block should be convenient to patient, easy to manage in the post-operative period. But unfortunately, currently available peripheral nerve block techniques fall short of this ideal in a number of ways. Let's discuss types of peripheral nerve blocks that we are commonly practiced. The first one is a single shot peripheral nerve block. The advantage is simple to perform, and it avoids all the hassle of putting the catheters, securing. But this is the advantage of the single shot. One of the biggest limitations is the short duration. And this kind of blocks, which single shot peripheral nerve block, is only best suited for post-operative pain, which are not expected to exceed between more than a day. How about continuous peripheral nerve block? The advantage, of course, it has a prolonged duration of analgesia as long as the catheter is there, and it has the flexibility to control the duration, to control the intensity of the analgesia by playing with the volume and also the concentration of local anesthetic. And because we are using a diluted local anesthetic solutions, the risk of local anesthetic systemic toxicity is minimal. But there is a disadvantage of continuous peripheral nerve block. One of them is the risk of catheter dislodgement, catheter obstruction, leakage, and also infection, especially when the catheter are left there for more than 48 hours. And one of the biggest also disadvantage in the busy operation theater is time. Sometimes it consumes times for the operator to perform the catheter to secure it. So this is not practical. And also the cost of the set of epidural or the set of peripheral nerve block with catheter is much more expensive compared to single needle injection. I would like to continue my presentation by example of case. Okay, so in these cases, I incorporate the rectus spinae plane block, supraclavicular block, and selective truncal brachioplexus block in one patient. 68 years old male patient, active smoker with history of ischemic heart disease, involved in accident, motorbike versus car, and he has a head injury, but it just says upon arrival at 14/15, the CT's brain show minimal acute subdural hemorrhage with multifocal infarct. The neurosurgery plan for only conservative management. And further examination, we noted that this patient also have a multiple rib fracture of the right chest. with pneumohemothorax, and chest tube are inserted in emergency department. On top of that, you also have a closed right humerus shaft fracture, which are put on spleen. And this case referred to the NS team to be admitted to ICU for close monitoring, also for ventilator support, when they noted that this patient SpO2 started dropping. And on examination, this patient, we noted the patient is in pain. The pain score is about 10/10. He's tachypneic, and we also noted that the right chest is reduced in expansion. And we put the patient on non-invasive ventilation, put him in CPAP mode. So we conclude that this patient having a look into the X-ray first. When you look at the X-ray, it shows there is a multiple rib fracture. So we conclude from this that the pain actually that caused the patient to be desaturated. And we perform a rescue block for him by doing erector spinal plane block over the right chest. Under ultrasound guidance, we use a catheter or a needle set inserted at the level of T5, and then we give a bolus of 20 cc of 0.375% of ropivacaine with 1 in 200,000 adrenaline, and followed by infusion at 5 mL per hour of 0.2% ropivacaine. And amazingly, the pain score reduced from 10 to 3/10. The right chest started to expand, breathing become more regular, the SpO2 pick up, and we managed to remove the NIV. This video will show how we perform the erector spinal block under ultrasound guidance. We can see here, this is the level of T5. The needle is on top of the T5. And then we can see that when we injected the local anesthetic, it pushed up the erector spinal muscle up. Yep. Then we anchor the catheter so we can continue with infusion later on. This is the patient a day after the block. He looks very happy, no pain. Unfortunately, 2 weeks later, the same patient is booked by the orthopedic for interlocking nail over the right humerus. But when we go and review this patient preoperatively, we note that the blood gas is not that great. The PO2 is only about 43. SpO2 on air only 75%. Is having a chesty cough, even if he was not tachypneic. And that time, the availability of the ICU bed is very critical. So after discussion, our team decided to perform awake selective truncal block over the right side of the hand. This is the X-ray to show you the complete the fracture of the shaft of the right humerus. So as decision making done, we perform a awake selective brachial plexus truncal block for this patient. We use 1:1 mixture of lidocaine 2% with 1 in 200,000 adrenaline, and we add in the levobupropion, the carocaine, 0.5% for the block. So we mix together. The total volume is about 20 cc, and in conjunction with that, we continue with intravenous sedation, Presidex, 0.1 to 0.4 mic per kilo per hour. This is the patient on the day of the surgery in the operation theater. The next I will show you the video how we perform the selective truncal block. Okay, this is when we are starting to blocking the superior trunk. This is the needle. This is the C at the superior trunk level. Okay, we dissect it with local anesthetic. We inject it. So this is the superior trunk. The next video is the middle trunk. So we insert the needle between the upper and also the middle trunk, and we dissect it with local anesthetic surrounding the middle trunk. Okay. Okay. And lastly is the lower trunk. This is the first ribs. Okay, the needle is here. We push up the lower trunk up with local anesthetic. And before we end of the block, we perform the last block by blocking the supraclavicular nerve, which are located between the superficial and the deep cervical fascia. So this is the area where usually the location of the supraclavicular nerve on top of the middle scalene muscles is very superficial between the two fascia. Okay. And this is the post-block testing. Yeah, this is the area. This block show there is a complete sensory motor blockade of the entire upper extremity, except of the middle aspect of the upper arm. This is not covered by this block. And this is the video to show intraoperatively. Patient is very comfortable. Surgeon starting the surgery. This is at the middle of the operation. The patient is sedated. Okay. And this is the patient post-recovery. So if you look very comfortable, then we able to do the surgery without have to put the patient under general anesthesia. And with the proper technique, we able to avoid blocking the phrenic nerve. So this patient is one of the example of if we can apply regional anesthesia in a selected patient, it can benefit for the patient for acute pain management. So as a conclusion, when you use regional anesthesia appropriately and in combination with other treatment modalities, regional anesthesia techniques have the potential to reduce or eliminate the physiological stress response to surgery and trauma, decreasing the possibility of surgical complication and improving the outcomes. Also, they may reduce the total amount of opioid analgesics necessary to achieve adequate pain control and the development of potentially dangerous side effects. And lastly, carefully selected patients and well-trained anesthesiologists, peripheral nerve block can be a safe and effective post-operative pain management strategy. Thank you.
A very good day to everyone. I'm Shawn. I'm a clinical psychologist specializing in chronic pain management. So thank you for having me today to talk about the role of placebo in pain management. I will start this session by clarifying some of the common false beliefs about placebo. So most of what I'm about to share are actually not new findings. In fact, these studies that I'm about to share have gotten quite prominent in the past few years. However, people who are not actively looking out for this information in the literature may not be aware of it. So after we have established a more accurate and updated understanding about placebo, I will share about what experts in this area think about the role of placebo in clinical care is. So these opinions are not mine specifically, but I agree with them a lot. So let's start with a bit of definition. Placebo is the improved clinical outcomes following administration of a substance with no known pharmacological properties. Give someone a sugar pill, tell the person that this is a medication for hypertension, and then you see changes in blood pressure. A lot of people thought that the placebo effect is mainly psychological, it's all in the mind. And placebo would only work if the patient thinks it's real. If the patient finds out that they have been cheated, if they found out that they have received a sham surgery or sham kind of intervention, the effect will be gone. People also tend to think that individuals responding to placebo interventions are suspicious. They may have a bit of mental problem, or they may be a bit manipulative to get what they want. Also, some people believe that placebo effects are usually short-lived. So even if you see actual improvement, this kind of improvements will be like a bubble effect and it will be gone in no time. Now we have enough studies. Some of it were done in laboratory, some of them were done as clinical trials to show that all these kind of beliefs are actually not true. So I'll be presenting to you some of the studies to argue against this kind of false beliefs. So this is a study done to examine the effect of minoxidil for hair loss. What they did in this study was that they randomized individuals with hair loss into 3 treatment groups. The first group was a group that received a 5% solution of topical minoxidil. The second group received 2%, and the third group basically received some placebo solution where there was nothing inside. So they gave these 3 group of participants the same type of instruction: 1 meal twice a day, 12 hourly for consecutively 48 weeks. And throughout the trial, they measured the participants' non-villus hair count using computer. They also asked the participants to rate for themselves whether they feel that their hair were getting more thicker. And also they asked the researchers to evaluate whether they feel that their patients, that the participants' hair were getting thicker. So the outcome of this study was pretty ideal for a clinical trial. We can see that in the 5% group, participants improved a lot by week 16, and then by week 32, basically the hair count dropped a little, and by week 48, there was a slight drop from week 33, but it was way better than the baseline. We also can see improvement in the 2% group with a very similar change pattern here. And we can see that the 5% group is performing better than the 2% group, and both the 5% group and the 2% group are performing better than the placebo group. So in a clinical trial, this is generally what we want to see. We want to see that our treatment is more effective than the placebo group, and we also want to see that there is some form of dose effect, where the group receiving a higher dose performs better. So everything seems pretty ideal. But if you think about it, why should there be a change in the placebo group, right? So in the placebo group, you can see that there is a very similar pattern of change. By week 16, participants in the placebo group doubled in terms of their hair count compared to week 8. And by 32, it reduced, and by week 48, it reduced further. This trajectory is exactly the same as those in the treatment group. If we really think about the reasoning behind that, we should feel that there is something interesting going on there, because by right, these participants were not receiving anything that is active. So these kind of changes in non-treatment groups in all these clinical trials, have been something that researchers ignored in the past. So they just saw it as something like a random finding or a nuisance variable or something that does not warrant further attention until the evidence has become so overwhelming that they notice that as long as you observe, as long as you measure, you will see some kind of changes in participants who are not receiving active treatment. Placebo effect is everywhere. We have seen placebo effect improving patients with asthma. We have seen placebo effects in terms of increasing the likelihood of people getting pregnant. We have also seen placebo effects in a lot of symptom management interventions. So we are now comfortable to say that as long as you measure, as long as you start to pay attention, you will notice that any treatment, even when there is no active mechanisms, will actually lead to some form of changes. And anyone can have a placebo response. It is kind of like a normal and natural human reaction to things. When we are being introduced to something, whether a treatment, whether a procedure, our body will just naturally react to it, and there is nothing suspicious about it. So people who get better from interventions that we cannot comprehend should not be judged. Another common misconception that people have is that placebo will only be triggered if the person does not know that they are getting a sham treatment. So they thought they were getting a real treatment. So this group of researchers did a study to test this idea. What they did was they recruited a group of participants with irritable bowel syndrome, and they randomized them into two groups. The first group was an open label placebo pill group. What they told the participants was this: you know, placebo pills, something like sugar pills with no medication in it, it's really nothing, have been shown in a lot of clinical testing to produce significant mind-body self-healing effect. So they told the participants that there's nothing in this pill, but it seems that when people take this pill, their body will heal itself. So that was the open label placebo group. In the other group, they simply did not give the participant anything. In this particular study, they controlled for the patient-doctor relationship and contact time because it is a known thing in the field of placebo that therapeutic relationship and the time doctors spend with patients can have an effect on placebo response. In terms of clinical measure, they used several IBS-related rating scales. And also they did some pill counts to see whether the participants actually took the placebo pill. And the outcome, the results showed that the open placebo group outperformed the no treatment group on all possible measures, right? In both conditions, the participants were actually not getting anything pharmacologically valid. The open placebo group was just a sugar pill, yet participants performed way better. Another way of interpreting this particular result is that doing something that is basically nothing is better than doing nothing at all. Another very influential paper that has really redefined the meaning of placebo for a lot of people, especially in the surgical field, is the study by Bruce Moseley, who is an orthopedic surgeon himself. So Dr. Moseley wanted to examine which is more effective, whether arthroscopic lavage or arthroscopic debridement was more effective. So when he wanted to do the study, he consulted a research consultant who insisted that he should include a placebo group. Obviously, introducing a placebo group in surgical studies is something that is rarely done, right? But in this case, they went with it regardless. This study included 180 participants, and what they did was they stratified the participants according to their OA severity and then randomized them into 3 groups: arthroscopic debridement, arthroscopic lavage, and a placebo procedure. What I would like to describe further is actually the placebo procedure. They did it in a way where the participants were not able to tell whether they received a real one or a sham intervention. So during the procedure, they actually showed the participants a pre-recorded procedure, and then in the surgical theater, they simulated all the processes and procedures like how they would have in a real surgical setting, in a real intervention setting. So all the nurses played along, all the assistants played along, and the participants were actually looking at a video recording, whether they are conscious or not. They still did the whole thing. And they actually drilled 2 holes in the knee as well. So the participants could not know whether they, which procedure that they received. So they followed up the participants for 24 months, and the outcome of the study showed that throughout the 24 months, there were no significant differences among all 3 groups. So they couldn't actually identify which group was doing better because all of them did quite similarly. All of them got similar level of pain relief. Now, after 24 months, they had to do a debriefing with the participants because that's a requirement according to research ethics. But even after that, even after they debriefed the participants, those participants who experienced pain relief from the sham surgery still continued to experience relief. So even after they were told that they did not actually get anything real, they continued to experience no pain. That is something very interesting for us to consider. Now, so far, we have spoken quite a bit about placebo, but I believe it is probably even more important for us to talk about what is known as the evil twin of placebo. So nocebo is defined as negative suggestions following administration of an inert substance resulting in an adverse outcome. Give someone a sugar pill, tell this person that this sugar pill is going to cause you nausea, and you see the person vomiting after that. I personally believe that if we were to pay attention to placebo, we should pay equal attention, if not even more attention, to nocebo. We know that placebo is powerful. It has a lot of potential, but we know very well that this same effect can actually influence our patients in the opposite direction. So before we start sensationalizing placebo, we probably need to pay more attention to nocebo first. Now, so far, our understanding of placebo is comparatively more developed than nocebo, because when someone display or manifest some form of negative effects or side effects, we don't think of it as nocebo in the initial phase. Just like when we see improvement in patients, right? Most of the time we would attribute it to some active treatment component rather than placebo. It is only after years and years of undeniable evidence that we start to acknowledge that placebo exists. So same thing with nocebo. A lot of times, maybe some of the side effects that were caused by nocebo were explained away by some of the treatment component as well. We notice placebo first, then only we notice that the same effect can happen in the opposite direction. Our understanding of nocebo now is sort of like the flip of placebo. We did quite a lot of research to understand placebo, and then we sort of flipped these kind of findings to infer that nocebo is probably contributed by the same factors, but in a reverse manner. Here I will present to you some of the well-established theories and contributing factors to the placebo effect. Of course, these same factors would also contribute to nocebo if it's in the opposite direction. Pavlovian conditioning is a theory that most people would have heard of by now. Basically, when you present two things together frequently enough and repeatedly, these two things will get connected. If you show patient this pill with a particular color and a particular shape, and after patients take this pill, the patient always feel pain relief, patient's brain will associate this color and shape with pain relief. So in the future, if you give a sugar pill that is shaped and colored in the same exact manner, this sugar pill will actually cause the patient to feel the same level of pain relief as well. So that's Pavlovian conditioning. Expectation is where patient expects certain things to happen. When patient expect a certain medication, a more famous medication to be more effective, chances are the medication will be more effective. And if you shape and label a sugar pill in the name of the famous drug, that sugar pill will also become more effective. Certainty or uncertainty about treatment would affect placebo. If we know quite a lot about a treatment, patients tend to respond better, even if we know that the treatment is not particularly effective. If we can tell patient that this particular drug or this particular surgery has this level of efficacy, we have done a lot of studies, we know about it a lot. As long as you tell patients that, even if the findings say that this particular intervention is not super effective, for the patient, they are still likely to exhibit placebo effect. Similarly, a potentially effective treatment, but if we tell the patients that there are still a lot of uncertainties, we really don't know whether this is going to help. According to our preliminary studies, it seemed to be very effective. That uncertainty can actually lead to nocebo. So the way we communicate our treatment then becomes very important. Therapeutic alliance is the concept of doctor-patient relationship. Obviously, if the relationship between the doctor and the patient is a very positive and supportive one, the patient is more likely to exhibit a placebo response. Choice of treatment or sense of control basically means that if patients are given a choice for their treatment, so if they feel like they chose the treatment, they are more likely to exhibit a placebo response. If they had the impression that there is no other choice, I am only left with this, even if that treatment is actually very powerful, it is very likely that they will still exhibit a nocebo response. So again, the impression that the patient has a choice seems to produce placebo effect. The next is hope for improvement. The belief is that if the patient wants to improve very badly, there is a higher chance of eliciting placebo response. So this has some face validity. However, based on the review that I went through, there seems to be lack of data to support this idea. So we are not saying that this idea is not valid, but we will probably need to collect some data and do research to specifically test for this idea. But there is indeed face validity because hope for improvement is associated with expectation, and we know that expectation is an established contributing factor. Now, next, these neurobiological mechanisms have been associated with placebo response, particularly in placebo analgesia. So some of the neural anatomical regions involved in placebo response include thalamus, somatosensory cortices, anterior cingulate cortex, amygdala, basal ganglia, prefrontal cortex, and nucleus accumbens. If you look at these areas, and if you're familiar with the pain matrix theory, you should find them very familiar because thalamus, the somatosensory cortices, anterior cingulate cortex, amygdala, and also the prefrontal cortex are in the pain matrix. In terms of the neurochemical mechanisms, endorphins and dopamine have been indicated in placebo analgesia. And the evidence for this is that previous studies have found that placebo analgesia for dental post-operative pain was reversed when naloxone was administered. So they introduced some procedures to elicit placebo analgesia, but when they administered naloxone, the pain started to come back again. And another study also found that nocebo responders decreased in dopamine and opioid neurotransmission in regions where increased neurotransmission was observed in placebo responders. So this kind of evidence seems to be quite strong in suggesting that endorphins and dopamine are involved in producing placebo analgesia. Although we are just beginning to pay more attention to nocebo, but so far what we have observed is that nocebo may be even more prominent than we think. Luana Koloka and her colleagues conducted a study to examine the role of learning and conditioning in nocebo analgesia. So the procedure of their study was quite complicated, so I'm not going to describe it in detail. But overall, what they found is that it is harder to induce placebo than to induce nocebo. With placebo, simply saying that something is effective is probably not enough. The person must have some form of previous positive experience about the treatment in order for your suggestion, for your your good recommendation to be effective and to elicit a placebo response. However, with nocebo, even when the person has no previous experience of a particular treatment, but if you tell the person that this treatment is going to cause you some harm, that effect is very likely to happen. With nocebo, they managed to make something that is not supposed to elicit pain become painful, and something that is painful become even more painful. This phenomena that nocebo is more powerful than placebo has been supported by a review paper. In this particular paper, which is titled "Bad is More Powerful Than Good," the authors noted that doctors might have induced a great deal of nocebo response in medical consultation. So validation refers to communication that makes people feel accepted and understood. Invalidation refers to communication that makes people feel rejected or denied. The authors suggested that invalidation is very damaging and is very likely to elicit nocebo response. And they also noted that a lot of times in medical consultations, both doctors and patients may unintentionally invalidate each other, which basically can be very detrimental to the treatment outcome. So this invalidation from a patient's perspective is the feeling of being dismissed and disbelief by the healthcare profession, or encountering clinicians or doctors who did not invest in them or show insight into their conditions. So the patient is describing their problem, but the doctor dismisses whatever the patient say and portray that the doctor knows more than the patient, or feeling an increased need to justify their condition because they're worried that the doctor does not believe in whatever they have, and that the doctor has his or her own theory about the patient's condition. So from a clinician's perspective, this invalidation can come in the form of receiving conflict and criticism from patients, encountering patients who held entrenched views or would not believe their diagnosis. So this invalidation is a two-way thing. It's not necessarily that the doctor invalidates the patient. The patient can also invalidate the doctor. But either way, it can be detrimental to the treatment and elicit a nocebo response. So to answer the question that the organizers of this forum gave me, is there a role for placebo in pain management? So experts say that healthcare professionals should be trained to maximize placebo and minimize nocebo. So yes, there is a role for placebo in pain management, and in fact, in all kinds of clinical care. And the goal generally are two things. Number one, to maximize placebo. Number two, to minimize nocebo. The next question is then, how do we maximize placebo? In this systematic review, the researchers compared different types of placebo intervention, and they noted that there seems to be no consistent difference in the effects. We have talked about some of the factors that would contribute to placebo just now. By manipulating these factors, it seems likely that we can elicit a stronger placebo effect in some people, right? So let's say if we focus on saying certain things or repeating certain procedures or changing the person's expectation, we expect that there should be a stronger placebo reaction. But this systematic review seems to suggest that there's no significant difference in placebo response, regardless of whether your placebo intervention is more or less intensive. All we can say now is that we know about the factors that would lead to a placebo, but we don't know enough to apply it. We haven't found a way to manifest its power. Definitely we'll need more research to truly understand the application of these factors in eliciting placebo effect. Now, on the other hand, I think minimizing nocebo is more imperative. It's probably something that we need to focus on more than thinking about maximizing placebo effect. With that study that I mentioned just now, we know enough to know that the bad is more powerful than the good, and that we have been doing the bad without realizing it, according to the authors. Before we think about exploiting placebo, we should probably think about correcting our current mistakes that we are doing, which are already harming our patients. In medical ethics, we are often faced with the dilemma between beneficence and non-maleficence. Do we focus on doing no harm first, or do we focus on what benefits the patient the most? When we think about applying placebo treatment or using placebo deliberately in clinical care, there is an ethical issue here. How do we do it ethically, and is it justified? In order for us to really consider using placebo as part of our clinical care, routine clinical care, we definitely need to plan more carefully, right? And we need more research to see whether it is even justified to include placebo interventions. Minimizing nocebo, however, requires no further explanation. It should be addressed immediately because we are not introducing something new, right? We are just correcting what we are currently doing. So just a few take-home messages here. Number one, placebo and nocebo exist in all treatment, whether you acknowledge it or not. Part of your treatment efficacy comes from things that you did not intend, you did not plan, it's not contributed by your medication or your surgery. It's just there. And whatever you do would actually cause some harm to the patient, whether or not you acknowledge it. Number two, we do not understand placebo enough to yield its effect. And so introducing ethically questionable methods to elicit placebo response is not justifiable. I have seen some clinicians justifying giving medications that are not indicated or doing things that has not much evidence, but justifying that, well, as long as the patient is getting better, even if it's placebo, so what, is not acceptable at this point, because we simply just don't understand it enough to allow ourselves to breach our ethics in this sense. Number three, minimizing nocebo should come before maximizing placebo, because we know that the bad is more powerful than the good. So if we don't know how to help, at least do not harm. And lastly, be nice to people, avoid invalidating people in our clinical practice and our interaction. Thank you very much.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and very good afternoon to everyone. Thank you to the organizing committee for giving me the chance to talk to all of you. My name is Dr. Rostam bin Najid. I'm currently the consultation liaison psychiatrist in Hospital Sultan Bahia, in which I work together with our team in Hospital Sultan Bahia in managing the patient with psychological issues. And of course, I'm trying my best to co-manage patients together with our colleagues in anesthesiology. And today my topic is about managing pre-procedural psychological stressors that is actually quite common among our patients. And I will try to make sure that this talk be very short, and to make sure that I make it very simple, because I have only 20 minutes with all of you, and I will assure you that if there is any kind of question or any kind of information that you need to get in terms of you want to know more, you can always contact me or the organizing committee, and they will relay the question to me later. Okay, guys, I start with why we need to do this, because psychological stressors or psychological issues is quite common, as I said just now, among our patients, especially when they are actually having gone through a lot in their life in terms of managing their own pain. The pain that they have might have been a chronic pain or an acute pain. And when they are coming to us, they have some kind of expectation, very high expectation. And all those things can actually jeopardize their psychological well-being. And because the unpleasant symptoms they have, there's a high tendency or high chance for a patient to have psychological issues behind it. There is a possibility of the psychological issues can heighten the symptoms of our patient, especially in terms of the pain. I'm not saying that the pain that they have is psychological in nature, but of course, psychological well-being of a patient will actually dictate how the patient perceive their pain, and how they manage their pain, and how they perceive the information that they get, and what are the expectations that they have when we offer them any kind of procedure, or when they are asking for any kind of intervention in terms of managing their problems. So when we are talking about psychological issues, right, it can be something that can be diagnosable, means that patient has any kind of mental disorders or mental illness, or it can be a very subtle kind of psychological problems, such as a psychological factor affecting other medical conditions, in which this diagnosis that is actually quite new in our DSM-5 is talking about patients that are not able to maintain a good optimum level of health despite optimum treatment because of their underlying psychological issues, in which it can also jeopardize any kind of intervention that we are planning to do to them. And of course, in terms of underlying psychological issues, also it can jeopardize the procedure itself, because sometimes the expectation of the patient is too high or too low, or the therapeutic relationship between the patient and the therapist is not as good, and there's possibility of misunderstanding because of so many reasons behind it. And of course, this is because of the psychological issues that they have at the back of their mind. When I'm talking about psychological issues, right, I'm not talking about any kind of specific diagnosis in psychiatry, such as generalized anxiety disorder or any kind of anxiety disorder. I'm not talking about a major depressive disorder or automatization disorder or somatoform disorder, or I'm not talking about problems like, as you all know, such as what we call that, malingering or factitious disorder. But I'm talking in general term, because there are lots of other mental health issues that is not diagnosable, but still can actually influence how patients perceive the management or treatment that we want to do, or the intervention that we want to do, and also how they perceive the success of the treatment, and how they perceive their life post-treatment, especially the quality of life post-treatment. So, and all this need to be managed before we can actually do the procedure to them. But of course, when I talk about this, it seems that it's quite difficult for us to cater all the needs of the patient. That is not our main objective in terms of learning how to deal with the psychosocial issue of the patient, but more of number one, acknowledging the possible underlying issues that can jeopardize the intervention, number one. Number two is actually to understand the patient more. Whenever the patient becomes difficult to us, when the patient demands, when the patient asking for something that's actually beyond our capabilities to do it or to deliver. So all these things actually will be able to help in terms of our expectation and our views or perspectives towards the patient too. So that's why we need to learn about this. And of course, most of the issues that they have is actually situational. Means that the problem is only when they want to go through this procedure, such as when they learn about this procedure or that procedure. Sometimes it can cause what we call as that a kind of psychological ambivalency, in which they feel like, should I go to that procedure? Should I not? Because sometimes, right, patient will try to push the decision to us, in which in our current practice that's not supposed to be done, because in terms of management, of course, we want to do it as impartial as possible. It means that we need to do a shared decision in terms of dictating what kind of intervention that we want to do with the patient. Okay, so how we want to do this, right? So how we want to do this, I will go through what are the problems behind it, number one, and then after that, the very simple steps that we can do in terms of how to make it easier for us and also for the patient. So when we are talking about this, right, we don't only see in one perspective, don't only see in one way, means that don't only see about the patient, but also from our point of view also, because it actually dictates on how we interact and react to the patient's requests or questions, and also how the reactions towards their response later. Okay, so first and foremost, when we are dealing with patient with psychosocial issues, right, whatever that we do to the patient can be a placebo or can be a nocebo to patient. You know about nocebo, right? Nocebo in which something that can something that a person perceives can do harm to them, while placebo is actually something that a person perceives can do good to them, despite there is no evidence or minimal evidence, or despite that there is not yet an intervention for the patient. Or it can sometimes strengthen the effect of the intervention that we do, but at the same time it can also lessen the effect of the intervention that we do. So how we do it, how we approach the patient is very important. Number one is actually the therapeutic relationship between us and the patient. And that's why nowadays we always try to emphasize that all patients must be seen by the same clinician every time, or at least the patient has seen you once and they are seeing you again and again in the clinic, not necessarily seeing you, but seeing one of your team members. The therapeutic relationship is pertinent in terms of trying to maximize or optimize the effect of our intervention, because a good therapeutic relationship will do wonders to our patient and also to us. It makes things easier for us. They can also actually reduce the possibility of negative effects or complication or morbidity of the intervention that we do, if there is or if there are. And also at the same time, it will reduce the possibility of the patient to complain. Not that we don't want them to complain, but of course we don't want them to complain, but actually it will reduce the level of dissatisfaction when something is not as good as they are expecting it. So therapeutic relationship is actually a two-way situation, in which when we have a relationship with the patient therapeutically, there are the elements of transference and also counter-transference. Transference means how the patient sees us as their clinician, and the counter-transference is actually how we see them through their transference. This is a very difficult concept, but I just want to tell you about it, because the transference and counter-transference actually dictates what will be the kind of therapeutic relationship that we will build with the patient. It's very important for us to make sure at least we have a very, I would say, that a cordial kind of therapeutic relationship with the patient. If not great, but we don't want any kind of very, I would say, a distant kind of therapeutic relationship, or like a chip small kind of relationship, or touch and go kind of relationship, but we want to have a consistent. That's why working as a team and seeing the patient together if not by only one clinician, is very important. Number two is actually the what are the things that will dictate the psychological issues or stressors of the patient is actually depending on whether the procedure is actually an emergency procedure or an elective procedure. Because I think I would say that an emergency procedure is much easier than the elective procedure, because the expectation of the patient is not that much, because they might be going through it for the first time, and they are actually in emergency situation in which the most important part of it, they want to survive through the emergency. So the expectation is not as great as, or it's not as complicated as when we do this as an elective procedure. Because when we are talking about elective procedure, patient can go through it slowly, number one. Patient can think out of it, number two. Number three, patient can ask around about the advices of the others, number three. Number four, patient can actually research about the procedure by themselves and trying to compare other things that might work for them. Number five is actually sometimes, right, patient will change their mind along the way. So emergency is actually much easier compared with the elective procedure. So that is actually can also dictate how patient react to us, and how they receive the treatment that we give to them. Number three is actually the expectation of our patient, and of course, in terms of patient who has going through chronic pain or very severe pain, uncontrolled pain, all those things, their expectation is very high. So sometimes the way we deliver the message can be misleading. Even though we try to do good to our patient, but sometimes we can worsen their expectation towards the treatment. And this is actually must be delicately managed in terms of how we deliver the message and how we deliver the information. And the expectations of the patient can actually kill them, and also can kill us in a sense, because expectation is something that we cannot really gauge in a way. But actually, right, we can investigate on how high or what are the expectations of the patient when we talk to them. But it must be done in two-way communication, in which I will try to explain to you a bit later. And then number four is actually the underlying psychological issues. And of course, in this situation, I'm talking about a diagnosable mental illness, or the current psychosocial issues like financial issues, issues of loss, issues of grief, issues with adjustment and other stressor that might be happening in their life, interpersonal relationship issues, communication issues. All those underlying psychological issues might also jeopardize or actually influence your management or treatment or intervention that you want to do. And the next one, the fifth one, is actually the past experiences that they have, because the past experiences that they have is actually give rise to their expectation. It can lower the expectation, but it can heighten the expectation too. And sometimes patient with past experience has gone through a lot of trauma. Sometimes some of them might be having kind of phobia towards certain things, like phobia towards certain procedures, certain kind of medication, or phobias pertaining to the environment that they stay before. And there was one case that I saw. Patient was phobia with the hospital itself because of the experience that they gone through before. But they are okay if the procedure is done outside of that hospital. So all these things must be actually investigated or must be asked before we go, before we want to really do something to the patient. And sometimes, right, the effect or the impact of the intervention that you want to do is actually based on also it actually depends on the situation of the patient, in which some patient will have other issues that comes together. Sometimes we talk to the patient in a room, a very busy or crowded room, which is actually not conducive for the patient to really understand what we want to try, what we want to tell them, and what we want to do with them. And sometimes patients feel pressured to give the answer as soon as possible, despite that it's actually an elective procedures. and sometimes there are other companies, right? Like their spouses, their children, or their friends that actually influence the way that they perceive the information that they get. And that's why in this situation, right, we might be it's actually good for us to try to use the way that we breaking bad news with the patient, in which we actually tell them how many people should be inside the room together with us when we are actually explaining to the intervention to the patient, and then the place that we want to take the patient through the procedure or intervention, the person who deliver it, and the person who will do it later. So all these things must be taken into account when we are dealing with this kind of patient. And the next one, the details, right? Okay, the first one, when we are talking about pre-procedural intervention in terms of psychological, right? Number one, we need to re-emphasize on the previous knowledge of pertaining to pain control. Because sometimes, right, when patient knows that they will be going through another intervention that they perceive is a better one than the previous one, they will stop doing the things that they should do every day, because they thought that there's no more important for me to do this, so I can just think about the other intervention that I'm looking forward to, and let it off like that, and they were just thinking about the new procedure, new intervention that would be great. So it's very important for us to emphasize on previous knowledge pertaining to pain control. Especially we need to emphasize on certain relaxation techniques, such as breathing relaxation. They must do it properly, regularly, not waiting for them to be anxious and then only they do it, but they must do it regularly, as like when they do it for their pain. And also progressive muscle relaxation for PMR, in which PMR is actually one of the techniques to actually reduce the muscle tension, reduce the physical tension when dealing with anxiety symptoms or anxious provoking environment, especially pre-procedure and other things. We might be also telling them to practice mindfulness, in which I don't have time to talk to you about mindfulness, but generally it's actually about another techniques of relaxation. And then when we deliver the message, right, make it simple, consistent, and minimize technical jargons, because technical jargons can also increase the possibility of the anxiety of the patient. It can also create panics, because when they hear a lot of words that they cannot understand, they will be lost in translation, because once they are stuck with one word, right, they are trying to figure it out. Most of the time they won't ask us about that, but if let's say they ask us about that, they will be more confused with another technical words. So try not to use technical jargons, try not to use all these fancy words in medical, because even though it's maybe in English or maybe in Malay or maybe in any kind of bahasa, but still that is actually an alien to the patient. So make it very simple, make it as consistent as possible. Try to use the same messenger every time when we see the patient. I don't say that don't allow the patient to talk to other doctors about that situation, but don't allow our doctors to talk to them about the same procedure again and again, unless they do it in front of you, or if the patient asks for the second opinion. But when in a situation in which patient requests for a second opinion, of course we want them to see another specialist or another consultant to do it, rather than we are asking our juniors to do it, right? And then that's to what extent the patient wants to know. Avoid info overload. Sometimes, right, we treat our patient as if we are in a final master exam or in our paper exam, in which that's wrong. Our patient is not the examiner. So we need to know to what extent that they want to know about the procedure. Sometimes, right, we just blurted out everything, but patient doesn't want to know everything, and patient cannot listen to everything that you give. So sometimes we can ask the patient, okay, Pakcik, saya nak buat prosedur ini, dan Makcik nak tahu yang mana mana yang makcik nak tahu. Sometimes that is more than enough for the patient. And some patient will try to avoid hearing about complication, but we will try to encourage them to know certain things, because even though they don't want to know about the details, but we still need to tell them a bit about the possible of failure of the procedure, because sometimes they are in denial. It means that they just want to know the good news, but they don't want to know anything bad about the but if let's say we don't touch that, it can be difficult post procedure later, because it can actually cause pain more to the patient in terms of psychological. And then there are patients that need sedative hypnotics prior to the procedure, especially at the night before the procedure. And I've seen a lot of patients that are so anxious about the procedure that they want to go through, in which we give sedative hypnotics like benzodiazepine just the night before to make them relax. And then in the morning, they feel a bit better. They have a good night's sleep, at least, and they become calmer during the morning of the procedure. And then at the same time, emphasize on the shared decision making. Try to make sure that our patient who make the decision, not we pressured them to do it, or we push them to do it, or we actually, what we call as trying to convince them to do it. More of like a two-way communication, even though we try to convince them, but we try to convince them indirectly rather than directly tell bagus, ini kena buat, ini kena buat. That is not the way. So shared decision making is something that the patient must decide, despite we try to influence them in a way, but not directly. And last but not least, if there is a need, please refer to us. We have psychologists in, for example, in Al-Star, we have psychologists, clinical psychologists that can do pain intervention, psychotherapy intervention for pain. We have counselors too that has experience in dealing with patients with psychological issues, and of course our psychiatric team. And sometimes our service also needed for to assess the capacity assessment of the patient. And of course, when we are talking about capacity assessment of the patient, we would like your help to really explain to the patient about the procedure, because when we do the capacity assessment, we will base our assessment on the information that was given or that is given by the primary team. So I think that's all from me. 20 minutes, just a very short one. I hope that we can see each other later, and I can deliver a longer lecture to all of you and more details. Thank you so much for your time, and see you again later. Thank you.
Assalamualaikum and good day everyone. I'm Sharifah, a rehabilitation medicine specialist in Hospital Sultanah Bahiyah Al-Ustar. I'd like to thank the organisers for inviting me to be a part of the Northern Pain Refresher Course 2021, whereby I'll be sharing on the role of rehabilitation for patients planning to go for major surgeries. My talk will explore the rehabilitation medicine perspective on enhanced recovery after surgery, ERAS pathway. As part of the ERAS protocol, we will also discuss regarding role of prehabilitation prior to surgery as opposed to rehabilitation post-surgery, and how we can monitor functional outcomes of patients after their major surgery using the International Classification of Function ICF framework. Despite steady advances in anesthetic and surgical techniques over the years, post-operative complications remain one of the major drawbacks of surgery. Patients rarely die on the operating table during the surgical procedure itself, but rather from the pathophysiological response to surgery and its complications. Keller et al. Have identified these challenges to post-operative recovery, and they are described in the ERAS protocols. The primary mechanism leading to a risk of post-operative organ dysfunction is surgical stress response, which comprises of complex neuroendocrine and inflammatory immunological responses. The endocrine metabolic response leading to catabolism can be reduced by regional analgesic techniques. Out of the several recommendations in R.A.T, only minimally invasive surgery has so far been proven to be effective in reducing undesirable inflammatory changes, thus reducing fatigue and pain and enhancing recovery. Needless to say, sufficient pain relief is a prerequisite for enhancing recovery. I'm sure that is why most of us are attending the course today. Post-operative cognitive dysfunction can be due to pain, opioid use, sleep disturbance, neuroinflammatory response. Post-operative ileus is an undesirable stress response that occurs predominantly after abdominal surgery. Fluid management is important and is complex. It includes choice of fluid, either crystalloids, colloids, the volume management, and goal-directed fluid therapy. The perioperative and post-operative period is a prothrombotic state for the patient, and thus patient is at risk of getting deep vein thrombosis and pulmonary embolism. Blood management has also proven to be a challenge. Preoperatively, diagnosis and treatment of anemia needs to be established. Reduction of blood loss need to be reduced intraoperatively, and post-operative anemia and transfusion management has to be optimized. Patient can also have adjustment issues, stress, anxiety, and depression that needs to be addressed preoperatively and even post-operatively. To prevent orthostatic intolerance, patient needs to be mobilized early, as soon as possible. So this is an important diagram for me. It shows the functional status of patients undergoing surgery. So this is prior to surgery, and this is the period after the surgery. So this red line is line of dependency, meaning those who are above this line are independent in terms of function, and those below this line will require some assistance. So if you look at the purple line first, all patients undergoing surgery will experience a reduction in functional status post-operatively, followed by a period of recovery whereby they will regain their premorbid functional status. So if the patient was independent before, then after surgery, the function dip a bit, and then patient recover well and become independent again. However, if there are complications post-surgery, the period of recovery might be longer, might be a slower process, and the recovery might be incomplete, meaning patient cannot regain their independence and they will require some assistance. What if we increase the patient's functional capacity through a series of interventions prior to surgery, so that after surgery, even though there is a reduction in function, the reduction won't be as much. And even if there is some complication and patient experience slower recovery, patient will still be above the line of dependency. Patient might still be functionally independent. So that is the concept of prehabilitation. The concept of enhanced recovery after surgery (ERAS) was developed back in 1990s, whereby it was initially known as fast-track surgery. There was bundling of some perioperative treatment for CAVG, and it showed that there was reduction in length of stay in the ICU by up to 20%. Khaled, again, made a case series showing rapid recovery after sigmoid resection using a multimodal approach. So this multimodal approach reduces the surgical stress response and hence reduces complication and enhances recovery. The concept of ERAS encompasses some key components, mainly a multidisciplinary team working together around the patient. So no man is an island in managing a patient undergoing surgery. There is a multimodal approach to resolving issues that might delay recovery and cause complications. This approach is procedure specific and highly personalized to the patient. It is a scientific, evidence-based approach to care protocols. And a change in management using interactive and continuous audit is used via objective and measurable outcome measures. So this diagram shows the relationship of patients undergoing surgery to the multidisciplinary team who will be taking care of the patient prior to surgery and up to discharge. So of course you have your surgeons, you have your anesthetists, you also have your physicians, your nurses, dietitians, your psychiatrists, counselors, psychologists, and also your rehabilitation team, which comprises of a rehabilitation medicine specialist, a physiotherapist, and occupational therapist. So this basically shows the pathway to functional deterioration post-surgery. Begins even pre-operatively with the patient's premorbid functional status and his comorbidities, and perioperatively due to the anesthesia procedure, the medications used, the surgical procedure itself, and post-operatively might be due to the complications, the precautions taken, immobilization that is instituted, and patients' underlying mood, such as adjustment issues, stress, anxiety, or depression, can contribute to the functional deterioration post-surgery, not to mention nutritional status of the patient. So does this pathway work? Well, it does. That's why I'm actually telling this today, right? So it has been proven in the meta-analysis that it shortens the length of hospital stay by at least 30% or 2 days compared to the control group, and it did not affect hospital readmissions after discharge. The pathway also reduces overall morbidity, especially non-surgical complications, probably due to the fact that we increase the cardiorespiratory fitness of the patients prior to surgery. There was no difference in surgical complications such as anastomosis leakage and surgical site infection. This is a diagram listing the components involved in ERA's pathway. As you can see, it addresses the identified possible peri- and post-operative challenges of major surgeries that we have discussed earlier. The evidence-based management does indeed cover the whole lot, from nutrition optimization, appropriate fluid management, minimally invasive surgery option, analgesia, hemostasis and blood requirement, early removal of tubes and drains, and to promote mobilization. It definitely involves a whole team of experts to ensure the patient's best chances of recovery. So where does rehabilitation comes in? In fact, it comes in quite early. It's so early that we can't even call it rehabilitation. It happens before the surgery, and we are part of the prehabilitation process. So this is the part where we try to increase the patient's health condition and especially their cardiorespiratory fitness in preparation for this big marathon-like race, which is major surgery. Because we know that after surgery, all patients will deteriorate, especially if they encounter any post-operative complications. This preoperative increase in functional capacity is what prevents patients from dipping too much in functional deterioration and makes it easier for them to recover. Patients will also be encouraged to mobilize as early as possible, all within limitations advised by the surgeons, of course. Outcomes should also be monitored, be it in surgical or non-surgical complications, functional outcomes, either objectively or patient-rated, as well as utilization of hospital resources. This slide just shows the list of protocols for ERA's pathway, from your GI surgeries to your obstetrics, your arthroplasty, head and neck cancer surgery, bariatric surgery, as well as your spine surgery. You can look it up at the link provided here. So let's take a minute to see whether I've confused you or not. We've had a few terms so far: rehabilitation, prehabilitation. So there's another term actually, habilitation. So let's just try to get the definitions right. So rehabilitation is a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in its interaction with the environment. It is reactive to the patient's impairments. So that's why we don't call patients who undergo training or intervention prior to surgery as rehabilitation. We call it prehabilitation because surgical prehabilitation is a proactive strategy taken prior to the surgery by optimizing the patient's modifiable risk factors and increasing their functional capacity through exercise training in preparation for the expected decline post-operatively due to physiological stress of surgery. Habilitation, meanwhile, as opposed to regaining the lost function through rehabilitation, habilitation means we apply this to mainly children with developmental disabilities. The rehabilitation process promotes gaining new skills and functions. So in the case of a child with developmental delay, the aim of rehabilitation is to promote development to as close to age as possible. So does it matter when you give the intervention prior to surgery or after the surgery? Apparently it does. Okay, so there's a randomized control trial where they studied patients who are electively planning for colorectal surgery for cancer. They prescribed moderate intensity aerobic exercise as well as resistance exercises at home. And one group they gave the intervention prior to surgery, the other group they gave immediately after the surgery. And what they looked at was this 6-minute walk test, which is an established outcome measure functionally. So they noticed that 2 months after surgery, which is at 8 weeks post-op, those who were in the prehabilitation groups who underwent the exercise training prior to surgery were able to walk significantly further in 6 minutes compared to the rehabilitation group, those who exercised after the surgery. So what are the components of prehabilitation? Up until today, there are no specific prehabilitation protocols, surprisingly, but it does encompass patient education, which is very important. Patients should be aware of their condition, of the surgery that they're going to undergo, so that they will be empowered and be more participative in their management. Nutrition should be optimized, anemia should be identified, and other nutritional deficiencies should be addressed prior to surgery. Functional capacity assessment should be done so that therapeutic exercises can be prescribed so that their functional and cardiorespiratory fitness is increased prior to surgery itself. Modifiable risk factors, including medical comorbidities, behaviors such as smoking and excessive alcohol consumption, should be addressed prior to surgery as well. Psychological well-being should be identified, whether there are any stresses, anxiety, any pre-existing psychiatric diseases, so that this can all be treated prior to surgery to promote recovery post-surgery. Why do we put emphasis on physical conditioning prior to surgery? Well, physical inactivity accelerates age-associated declines in maximal aerobic capacity. In simple terms, your cardiopulmonary fitness deteriorates with physical inactivity. Lack of physical conditioning also increases risk of developing chronic conditions such as cardiovascular diseases, obesity, and type 2 diabetes mellitus. These conditions will definitely put patients in higher risk for morbidity and mortality during and after surgery. not only do we need to treat the chronic conditions, but the added physiological stress from major surgery will further compound patients' chances of full and timely recovery. So this meta-analysis shows that prehabilitation program prior to major abdominal surgery can reduce overall morbidity, especially the pulmonary complications. Again, there are no specific protocols established yet, and it is up to further research. How does the inclusion of exercise training in prehabilitation enhances recovery after surgery? Well, it is multifactorial, but it is thought that through cardiopulmonary training, the patient's physiological reserve is increased prior to surgery. So this will minimize risk of perioperative complications, especially the pulmonary morbidity. So now the patient comes to you during pre-op clinic, probably 1 or 2 months prior to surgery. So of course, you assess their current health status, any comorbidities, what are their current treatment and medications, any ongoing investigations. Don't forget to identify relative and absolute contraindications to exercise as well, because you are going to prescribe exercise to them. You are going to recommend exercise prescription to the physiotherapist. So any untreated cardiac disease poses a high risk for patients who will undergo exercise training. So you do need to look a bit more detail into that. Patient has any of those conditions. Patients' prior and current levels of physical activity should also be assessed. You can't prescribe a high intensity interval training to a patient who has been sedentary their whole lives at the first meeting, right? It has to be gradual. And you also need to objectively evaluate the functional capacity. One is to look at the baseline. Second is to look at the improvement after your intervention of exercise training. So an easy test that you can do is your 6-minute walk test. It's a sub-maximal aerobic test used to assess your cardiorespiratory capacity and endurance. Okay, so it doesn't take too much of your time. You just need a hallway, I guess, to accommodate the test. And don't forget to assess patients' psychological well-being as well as the quality of life. So now your assessment is complete. You are ready to prescribe the exercise training to your patients, and your patient is actually willing to undergo the exercise training. So what type of exercise should you prescribe? Whatever it is, it has to be tailored and individualized to the patient, targeted to the patient's condition. You also have to think about the type of surgery. What are you going to improve? So in general, obviously you want to improve the patient's cardiopulmonary fitness, their functional capacity, but there are other exercises that can help with certain types of surgery. What stage of disease the patient is at, and you also know the preoperative functional capacity, so you need to tailor your exercise training to patients' functional status. You can't be giving, like I mentioned in the previous slide, high intensity interval training to a patient who's not fit at the first meeting. Patient's age will also contribute, okay, although the geriatrician would probably disagree with me. Patient's expectations should tally with treating doctors. Very important for that communication to be open between your patients and also the doctors. So now comes the fun bit. You are actually going to prescribe the exercise now. So you use the FITT principle. Okay, F is frequency, I intensity, T time, another T is type. So what type of exercise? Okay, you need to decide on that based on the surgery requirements. And then frequency, how frequent are you going to prescribe the exercise? If there's strengthening exercises, how many reps, how many sets, how many times per week? Okay, intensity, usually we use according to heart rate or Borg scale rating of perceived exertion. You can look that up. And then for time, aerobic usually for moderate intensity is about 150 minutes per week, or if it's vigorous high intensity exercise, it can be 75 minutes per week. So these are the common types of exercises that we prescribe to patients in preparation for their major surgeries. Okay, mainly we will prescribe aerobic exercises. Main aim of aerobic exercise, of course, is to improve your cardiopulmonary fitness, yes, your functional capacity. So a simple aerobic exercise is, of course, your walking, as simple as that. Your jogging, running, swimming is also a very good form of aerobic exercise. Next, you have your strengthening, okay, your respiratory muscle training. Some surgeries do require strengthening of certain muscle groups, maybe your upper limb or lower limb. Okay, so you can also address that. Flexibility, balance, and coordination exercises complement the aerobic and strengthening exercises. They may help to reduce risk of fall post-surgery. This is an example of an exercise prescription for patients undergoing intra-abdominal surgery. So you can see the types of exercise prescribed. Your aerobic exercise, inspiratory muscle training, and some resistance exercise. Okay, so of course, I already reiterate, aerobic exercise is to increase patients' cardiopulmonary fitness. So how do you prescribe the intensity? You use the calculation of your maximum heart rate, or using the Borg scale, rating of perceived exertion. So we can actually tailor the intensity to achieve the desired outcomes. And it can be gradually increased by adjusting the duration, frequency, and intensity of exercise once the patient is able to tolerate and adhere to the exercise. So for example, okay, you prescribe 150 minutes per week of moderate intensity exercise. So probably for 5 days, you have 30-minute sessions of aerobic training, okay, either running or swimming. Or if patient has lack of time, can only work out during weekends, then yes, you can allow them to have 75 minutes per week of vigorous intensity exercise. So you do need to stratify the patient's risk of exercise. Patient who has very low fitness level won't be able to tolerate this type of high intensity exercises. So this can be limited to 2 to 3 days. Inspiratory muscle training is useful in reducing post-operative pulmonary complications. So there is some tools that you can use for inspiratory muscle training. In fact, it's called IMT. Okay, so it gives resistance to the patient, and the initial load will be about 20 to 30% of the maximum inspiratory pressure, and it can be gradually increased to 60%. So the patient can do this 15 to 30 minutes per session for daily or up to 5 days a week. For resistance training, it can be complementary for intra-abdominal surgery patient, okay, because you do need to increase the upper limb or lower limb strength. So it can be moderate to vigorous intensity, 8 to 10 types of exercises of the major muscle groups, 2 to 4 sets of 10 to 15 repetitions per set, and 2 to 3 sessions per week. So the patient has undergone the prehabilitation phase, is compliant to exercises prescribed to him. So he's undergone the surgery and now is in post-operative stage. Early mobilization should be the main aim of rehabilitation at this moment post-operatively. This is due to the fact that prolonged immobility causes multiple complications that can negatively affect the patient's recovery. There can be increased insulin resistance, causing difficulty in metabolic control, reduced muscle strength and loss of muscle bulk, which will be difficult to rebuild. Orthostatic intolerance will cause the patient not want to sit up because of dizziness. Patient has risk of getting pneumonia due to lung atelectasis. Cognitive dysfunction will manifest as delirium, and poor skin integrity will cause pressure injuries. All this can lead to the systemic condition known as deconditioning, which is something that the rehabilitation physician does not want to see, because one, is very difficult to treat, and number two, the patient will take a long time to recover. It will probably be 2 or 3 times as long as a patient who did not develop this systemic complication. So prevention is better than cure. How do we prevent it? It's through early mobilization. Saying that, we do get referrals for ambulation of patient very early after surgery with lots of bulky drains and catheters still attached to the patient's orifice or body. It will be quite difficult to ambulate those type of patients, so we might be limited to just mobilizing on the bed or at the bedside. So only after the early removal of these catheters, drains, wires, then it's easier for us to mobilize patient to transfer to wheelchair or for ambulation. Again, similar to the prehabilitation phase, the rehabilitation aim post-surgery are patient-centered and highly individualized according to the patient's level of impairment. Type of surgery also influences therapeutic interventions due to restrictions of mobilizations and precautions. Premorbid conditions of the patient, including stage of disease and baseline function, will also affect our rehabilitation goals post-operatively. Patient's age and expectations should be taken into consideration during formulation of the rehabilitation goals. So after all the intervention that has been done for the patient, how do we know that it works? In rehab, we use the World Health Organization, WHO International Classification of Function, ICF framework to monitor for functional outcomes. We know that the disease itself does not independently affect the outcome of the patient. It is multifactorial. There's a lot of factors involved, including environmental factors, which can be the infrastructure involved, the house, any barriers for patients with disability, and also personal factors, patients' mood, patients' motivation. Okay, so the disease will of course affect the patient's body structures and function. We call it impairments, which will lead to limitation in activities such as walking, communicating, feeding, as well as participation limitation, meaning patient has difficulty in community reintegration, such as returning to work or school. So this is an example of the ICF framework for patient with colorectal cancer and how it affects the patient's body structure. We call it impairments, and how does the impairment lead to limitation in activities and participation. There are also contextual factors for the patient that will affect the patient's outcome, be it the environment factor or the patient's personal factors. Another example that we can use is for patients with fall and fractures in knee or hip osteoarthritis. So it's I think more visible compared to the previous slide. The impairments will be pain. So this is the outcome measure that they can use to monitor the pain after, prior to intervention, and after the intervention they use a KOOS questionnaire. The isometric strength can also be assessed. Stiffness, function, and pain can be assessed using the WOMAC outcome measure. So activity limitation, you can actually test the patient in terms of mobility. You can ask the patient to do either 6-minute walk test or simple 20-meter or 400-meter walk. Can patient do sit to stand, and also from outcome measures such as WOMAC. Limitation in participation can be either patient has returned to work or not. How about recreation, which is incorporated in KOOS, and physical activity. The environmental factors, as I mentioned just now, the living situation, any barriers for patient with disabilities, personal factors of the patient will also affect the patient's outcome. Rehabilitation does play a role for patients undergoing major surgeries. In the preoperative stage, during prehabilitation, our aims are to educate the patient, increase functional capacity by prescription of therapeutic exercises, optimize modifiable risk factors, and to address any nutritional needs. Post-operatively, rehabilitation aims to prevent complications due to prolonged immobilization by early mobilization. We also aim to promote recovery and to optimize patients' function to current level of impairments, to establish a safe discharge and ultimately improve the quality of life for patients as well as their caregivers. How do we monitor the outcome of our intervention? We need to choose the appropriate outcome measures, be it the patient-rated outcome measures or objective outcome measures. ICF framework can assist us in choosing the correct and suitable outcome measures according to the domains, and periodic goal assessment is performed to see whether our objectives are achieved and to look for further improvement. Right, we have now come to the end of my talk. I'd love to hear any questions that you might have. You can submit your questions via email or snail mail if you prefer. Do feel free to browse the Facebook page communityrehab.kedah, which was established by the Department of Rehabilitation Medicine, Hospital Sultan Bahia. Here we share the latest news, updates, and also videos of therapeutic exercises as well as other rehabilitation interventions. Have a good day. Assalamualaikum.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi and very good afternoon to all participants. I'm Dr. Awisul Islah bin Azali from Hospital Taiping. First of all, I would like to thank the organizing committee for inviting me to deliver a talk, managing chronic pain patient going for surgery. So as introduction, severe chronic pain is often devastating for the affected individual, causing substantial suffering, health impairment, and a very low quality of life, including significant negative consequences for the patient and for society. Patients with complex pain disorders are seen often in relation to anesthesia. They deserve special attention and require long-time hospitalization and multiple contact with healthcare providers after discharge from hospital. So a little bit about the magnitudes. In Malaysia, based on the data 2006, the population prevalence of chronic persistent pain is about 7%, with expected higher proportion in older groups. The prevalence reported was lower than the European survey, which reported that chronic moderate to severe pain occur in 19% of adult population in Europe. So based on number, we can see at the pie charts that in 2006 there are around 1.834 million people suffering from chronic pains, but now in 2021 the number maybe is increasing more. So out of all the chronic pains, chronic back and neck pain affected 20 to 30% of the general adult residents populations. So due to the chronic pain, patient has high probability to be treated with opioids. Patient on long-term opioid treatments has grown rapidly over the last decades. As a result, anesthesiologists will have to face opioid users and abusers who require surgical treatment and facing challenges in getting adequate perioperative analgesia. So just as a simple revision here, we can see what is the opioid effects toward the pains. Actually, the opioid decrease the perception of pains. The opioid also decrease reaction to pain, and it's also increase the pain tolerance. However, apart from the good effect of opioids, opioid itself also will have the side effect such as sedation, respiratory depressions, and also constipations. So how about the chronic pain patient with prolonged opioid use? Usually they will have some problems such as underlying central sensitization, increased nociception, opioid tolerance, and rarely some may have opioid-induced hyperalgesia. So all the four things I mentioned are part of pathogenic mechanism which interact with the preoperative chronic opioid use along with acute post-operative pains. So due to central sensitizations, patients taking opioid medication are more sensitive to pain, and the opioid-induced vulnerability may persist long time after opioid withdrawals. Due to increased nociception, chronic pain patients treated with low dose of opioid had an increased risk for post-operative pain at rest and also during walking after total knee arthroplasty. And they even can have hyperalgesia before surgery. This is interesting info for this talk. Preoperative opioid usage is the strongest predictor of persistent post-operative opioid usage. Preoperative opioid dependency is also a risk factor for uncontrolled and problematic pain after surgery. So if we have such a type of patient who has problematic pain after surgery, we can investigate whether patient already have long-term preoperative opioid use before the surgery. Interesting info, again, chronic opioid users who taper their dose before surgery achieve significantly improved outcomes compared with those who did not taper. So this result highlight the need to decrease opioids before surgery in patients with chronic opioid use. So it is important for us to know the history of opioid usage in chronic pain patient going for surgery, and our efforts to reduce the opioid usage is very beneficial to the patient intraoperatively and also post-operatively. Another interesting info, even a small decrease of opioids preoperatively for at least a month before surgery may result in a reduced intake of intra and post-operative opioids and may improve pain after surgery. Now we come to the opioid tolerance as part of the problem faced by chronic pain patients with prolonged opioid use. Opioid tolerance is characterized by a progressive lack of response to opioids that can be overcome by increasing the dose. This condition leads to the decreased efficacy of opioid analgesic effects. So opioid tolerance may be assumed to be present with a daily intake per oral opioid equivalent over 72 mg morphine per day for 1 month duration. Or if we give IV, the opioid tolerance may be assumed to be present in patient who was given morphine intravenously 1 mg per hour for 1 week duration. For example, a chronic pancreatitis patient who was given morphine infusions 1 mg per hour or 20 mg per day for 1 week durations. They are the group of patients that we can expect to have the opioid tolerance. How about other opioids rather than morphines? So this chart shows us, apart from morphines, other opioids also, we can expect for patients to have some opioid tolerance if they use codeine oral around 150 mg per day, oxycodone oral 30 mg per day, fentanyl patch 25 mics transdermal per day, methadone oral 20 mg per day, methadone IM 10 mg per day, Petidine IM 75 mg per day, tapentadol oral 150 mg per day, or buprenorphine patch 30 mics transdermal per day for around 1 month's duration. So all patients who consumes this amount of drugs may assume to have opioids tolerance already. So there are facts about the opioid tolerant patient going for surgery here. Scientific evidence suggests that only a relatively small doses of opioids, less than 50% of the preoperative dose, is needed to prevent withdrawal symptoms. The effect of surgery itself may be to increase or decrease opioid requirement. For example, if the surgery itself is targeting to reduce the source of pain, so the surgery itself might reduce the pain itself. However, if the surgery is not related to the chronic pain that the patient suffer, so we can expect the increase of 20% or more above the baseline opioid requirements have been reported, depending on the surgical procedure. So what is our goals of perioperative pain management for the chronic pain patients undergoing surgery? So we can summarize here the goals of perioperative pain management for the chronic pain patient undergoing surgery. First one is we need to ensure adequate analgesia. Second one, we need to prevent withdrawal symptoms. And the third one, we need to prevent the adverse outcomes. So what is our strategies? There are three big strategies here. The first one is the multidisciplinary management. Second one is the multimodal and balanced analgesia. The third one is the opioid sparing techniques. So in summary, this is part of our strategy in managing perioperative pain in chronic pain patients undergoing surgery. First, minimally invasive surgical technique is procedure of choice. This is, of course, the surgeon responsibility. Second, for elective cases, a small reduction of opioids preoperatively around 3 to 4 weeks before surgery will give benefit for post-operative pains. Third, patient control analgesia using morphine will help titrating the patient's demand towards opioids. For patient on opioid patch, might continue the patch perioperatively or stop the patch and replace with PCA. Number 5, multiple types of opioid sparing techniques should be used by anesthetists to reduce the opioid consumption. So here I show you all the multiple techniques of the opioid sparing techniques. The first one is the local anesthetic techniques. The local anesthetic technique, of course, is very important. We can give it via the peripheral nerve blocks or truncal nerve block or even the epidural anesthesia. It is known to reduce the opioid requirements and also is very is considered an advantage in opioid dependent patients. So other opioid sparing technique is the simple techniques that like the using combination of paracetamol and NSAIDs, non-steroidal anti-inflammatory drugs. We can use the maximum paracetamol 1 gram QID, or now even the IV paracetamol also available, and we can combine with NSAIDs. Doesn't means only ketorolac and celecoxib, but we can use other type of NSAIDs such as Dinostat and Celebrex also. Other opioid sparing technique is the gabapentinoids. Such as gabapentin and pregabalin. So gabapentin and pregabalin is known to help in reducing the neuropathic pains. So patients who are already on gabapentin or pregabalins preoperatively, we should continue the drugs throughout the surgeries. However, the benefit of using gabapentins and pregabalin is still uncertain in opioid sparing techniques. in patients who are not yet on these drugs. Another opioid sparing technique is ketamine. Ketamine is getting popularity to help reducing the opioid needs, and ketamine also is known to inhibit the development of opioid-induced hyperalgesia in patients who chronically using opioids. So apart from ketamine, magnesium also is known to reduce the opioid needs 24 hours post-operatively. Another one is the lidocaine infusion. Lidocaine infusion or lignocaine infusion is very important in helping to reduce the opioid requirement intra and post-operatively. So in patients where the peripheral nerve blocks or truncal nerve block is contraindicated, lidocaine infusions play a significant role. Lidocaine is potent anti-inflammatory, anti-hyperalgesia, and also able to decrease pain score, reduce opioid consumption, and reduce the opioid side effects. So apart from lidocaine, magnesium, and ketamines, clonidine and dexmedetomidine as alpha-2 agonists also important in reducing the opioid requirement and also able to reduce the opioid side effects. A steroid dexamethasone given stat dose pre-operatively 8 mg able to reduce the post-operative pain and opioid needs up to 24 hours post-operatively. And patient also will feel less fatigue after operation after getting dexamethasone. However, as we know, dexamethasone is a steroid and it enables to elevate blood sugar, especially in diabetic patients. So, so many techniques for opioid sparing. As conclusions here, just give a simple techniques how to choose from the multiple techniques available for the opioid sparing. So the first, we should know where and how such a drug act in body, which receptor involved, advantages and the disadvantages of certain drugs. Usually, drugs that act at different receptors can be combined together. Number two is by knowing the indication and contraindications of the drugs. So, such a patient may be indicated for certain drug, but another patients may be having contraindication for certain drug that can lead to the opioid sparing techniques. Number three is we deal with the drug that we are more familiar first. For example, if we are more familiar with lignocaine infusions rather than ketamine, so of course we use the lignocaine first rather than ketamine. Number four, we willing to try the new drugs and technique with proper preparations. For example, if we don't have any experience with ketamines to reduce the opioid requirements and to reduce the opioid-induced hyperalgesia, we need to do a few readings. We need to ask the experienced persons before we start using it, and we need to prepare for any side effect that may occur. Number five, we should have adequate skills and safety to perform certain technique. For example, if we want to perform ultrasound-guided truncal nerve blocks or ultrasound-guided peripheral nerve block or even thoracic epidural analgesia, we should have adequate skills and safety. This is all to ensure that patients will get a proper care and safe during anesthesia and during all the techniques to reduce the opioid usage during perioperative periods. Then our target here is the chronic pain patients who undergoing surgery and predicted to have and predicted to have more pains than compared to other normal patients. I think this is all I want to talk for this afternoon. Just a short topics. So with this, I hand it back to the organizing committee if there are any discussions or questions. So it's lunch time already. So thank you. Enjoy the durians at your own risk. Thank you again. Welcome.
Good afternoon. I'm Mr. Sudha, orthopedic surgeon from Hospital Pulim. Thank you for inviting me to share surgeon's perspective in regional blocks for surgery, especially orthopedic surgeries. Orthopedic surgery, when we talk about pain in orthopedic surgery, basically it comes from soft tissue dissection. When we are handling the bones, drilling the bones, cutting the bones, it comes from the pain comes from the bone. And other than that is a neuropathic pain. Pain is there all the time, pre-op, intra-op, and post-op. And nowadays, we have many subspecialty procedures in orthopedic surgeries. Those subspecialties are, basically trauma, arthroplasty, hip and pelvis, spine, foot and ankle, and such a thing. Basically, from my side, I'm dealing more with trauma, arthroplasty, spine, and we cannot deny the importance of managing pain before, during, and after performing those procedures. So regarding the regional blocks in performing surgeries, we have pros and cons. And I think I don't want to elaborate. This is, I think, we all know, and would have been explained by most of the pain doctors, but I just put it as a refresh here. And those contraindications, these also, I've just put it as a, not every time we can use these regional blocks, but we have to choose it wisely and use it wisely. And again, you can see here, if the patient is on anticoagulant, antiplatelet and all, we can't be using, or we may have to follow the protocols strictly. And now comes to the place where these are the things that we do, orthopedic surgeons, these are the things that we do. You can see in the pictures, the first one, you can see the distal humerus part, which is a very comminuted fracture. We are doing fixation for this comminuted fracture. And these are really painful for the patients. You can see the deformity, how the patient is standing with the varus knee, such a bad deformity. And you can see how we cut the bones and throw the bones, and performing all these kind of surgeries is really very painful for the patients. So I have to mention something. I would like to share the thing. When you ask about my opinion, this thing happens to me when I was a houseman. When I was a medical officer in Hospital Seberang in the year 2000, I used to admire. There used to be one medical officer from anesthesia. Most of the doctors at that time in anesthesia, they will perform surgeries by giving general anesthesia or either spinal or epidural anesthesia. I used to think only these are the things that exist. These are the things that is around. But I used to admire this one medical officer who used to give blocks even at that time in the year 2000. he used to give blocks, and we used to, my medical officer from orthopedics used to perform plating of ulnar radius, wound debridement, plating humerus, plating tibia. So he used to be very, he used to be very, I used to see him as a totally different from any other doctors. And I've continued life as a medical officer and as a surgeon. And now I used to only see my patients being given spinal, epidural, general anesthesia. Only these three things that has been given. And sometimes we orthopedic surgeons, we give local and perform carpal tunnel release, trigger finger release, this kind of surgeries. And lately, after we can say evolution, where we can see after pain subspecialty have come into practice in anesthesia, we started hearing about these blocks while performing the surgeries. Especially for me, now I really have to mention about this doctor, my anesthetist, Dr. Azmi from Hospital Pulim, who is doing very well with blocks. And actually, when I post the case for surgery, nowadays, when I perform a lot of these arthroplasties, total knee replacement and total hip replacement, total hips, total knee replacements, and also other trauma cases, where Dr. Azmi will come and perform these blocks for me. And actually, now I've started admiring Dr. Azmi again, because he has given me, he has helped us a lot in managing I can say pre-operative, intraoperative, and also post-operative pain. The pain care that is being given by Dr. Azmi, I'm very happy with him. So maybe this is one of the examples you can see in this picture. You can see how happy the patient is actually sitting down there, sitting on the chair. The evening, the same day in the evening of the TKR, total knee replacement surgery is performed. And the surgery was done in the morning, and in the evening you can see the patient is sitting comfortably on the chair, and actually he has been given block pre-operatively in the OT by Dr. Azmi. And it is a continuous infusion by using e-catheter. And the patient is so happy. All my patients nowadays, after the total knee replacement, is being pushed out from the operative theater with a happy face, smiling face. And compared to those days where patients are in severe pain. So by these blocks being given, we are very happy. Surgeons will be very happy, and also patients are very happy because you can see those days after performing total knee replacement, when I go back at night, I used to get calls from my medical officers. They used to say, boss, this patient is in severe pain, what to give. So we have to crack our brain. We have to crack our brain, and you have to crack our brain and we have to find what kind of analgesia to give, and especially you see these surgeries are being done on the old patients. What to give? IV Dynastat. Then you think about cardiovascular complication, Arcoxia, Celebrex, and giving Tramal in old age, headache, nausea, vomiting, so we used to struggle. In fact, I would like to share one of the incident where I lost one patient. I lost one patient who happened to be my staff. I did a total knee replacement on him. He was a known case of ischemic heart disease, but pre-op testing, everything was done, and he was fit for the surgery. We did the surgery, and that night, the night of surgery, patient was in severe pain, and the pain triggered the angina, and I lost this patient. So you can see, but with these blocks being given, especially in arthroplasty, and in fact, I've suggested these to my other colleagues, my other orthopedic surgeons, foot and ankle surgeons and all, to start practicing, or to start practicing and getting the help from Dr. Azmi, and try to provide the service for most of orthopedic procedures, because these blocks really works well, and this has reduced the use of other mode of analgesia we used to practice. You want to give IV PCM, you want to give IV Dynastat, Pethidine, morphine, all those kind of drugs are not necessary anymore. And in fact, you can see the next day, you can see the patient post-TKR, he is walking the next day. The second picture, you can see he's walking the next day itself. With the dose adjustment given in the infusion, patient had the strength, not much of motor block, and patient can walk happily, smilingly the next day of the surgery. So you can see the patient is actually, it's very good for the surgeon, it's very good for the patient. So I think I really have to thank the anesthetists for providing good pain care service. Thank you. I think with that, I end the presentation.
All right. Assalamualaikum warahmatullahi wabarakatuh, and good afternoon to everyone. First of all, I would like to take the opportunity to thank the organizing committee for giving me a chance to be here today. Although the topic today is a little bit off from my specialty, but I will give it a try. And it is a very important in terms of surgical treatment, especially the post-operative pain management in open colorectal surgery. So I have no disclosure relevant to this presentation. Okay, this is the outline of my presentation, which is the issue with the colorectal surgery. Next, it is opioid in post-operative pain. After that, I will go through the epidural and other alternative regional techniques, and last but not least, about the prospect guidelines. So in colorectal surgery, main bulk of our job is dealing with the colorectal cancer. And of course, the mainstay of curative treatment in surgery. Colon cancer, we manage with colectomy, right? It's either right or left hemicolectomy, or even torticolectomy in the case of synchronous tumor, and anterior resection for rectal cancer. And in the case of locally advanced rectal cancer or recurrent rectal cancer, the patient will need more complex surgery, which is compact pelvic surgery, such as abdominal perineal resection or pelvic exenteration. All the surgery can be done as open method or laparoscopic approach. And as we all know, the laparoscopic procedure are more superior in terms of reducing the post-operative complication, rapid recovery, and reduce hospital length of stay. So generally, along the way managing colorectal patient, there are few problems that could stop us giving the best treatment with minimal complication. Okay, this is the problem. And the problem often starts with the patient poorly informed about the disease perioperatively, about the surgery and what to expect. The preoperative counseling is very important to reduce the surgery-related anxiety, prepare the patient mentally, and these act as a psychological support. Problem number 2 that we face is a consequence associated with delaying oral intake after surgery, leading to poor nutritional status, poor healing, wound adhesion, anastomotic leak, surgical site infection, as well as increased inflammatory response and prolonged ileus. And what about problem 3? Is related to the narcotic or opioid, which could decrease the respiratory drive, immobilization, and prolonged ileus. And problem 4, let patient be on the bed for a long period of time, is cause of pneumonia, deep vein thrombosis, pulmonary embolism, pressure ulcers. And believe it or not, this perioperative complication is very common, and the rate is reported as high as 50%, especially after major elective colorectal surgery. And one of the solutions is attacking the problem with multimodal patient with surgical pathway, starting from the outpatient clinic until the day that patient being discharged, as what illustrated here, which is enhanced recovery after surgery pathway. And one of the components of this multimodal approach is what are we going to discuss today, the post-operative pain management. So I will start with the traditional one, which is the opioid. No doubt, opioids are effective forms of analgesia for acute pain and remain mainstay of post-operative pain management until now. And the rate of usage have increased as a result of published studies and guidelines. For example, the effectiveness of PCA morphine, no doubt giving excellent satisfaction for the patient. And this is reflect why the national usage of opioid with Malaysia was recorded the largest increase of opioid consumption among the 5 Southeast Asia countries. And this was recently published in Journal of Pharmacy and Bioallied Science, November 2020. Okay, unfortunately, right, opioid carry many adverse effects or opioid-related adverse drugs event, also known as ORADES. These include post-op nausea and vomiting, urinary retention, gastrointestinal complication like ileus, respiratory problem, hypotension, altered mental status of fall, and then the DVT or deep vein thrombosis, pulmonary embolism, and prolonged immobilization. And long-term usage can lead to addiction. Okay, addiction. So these opioid-related adverse events occur at 10%, and most ORADE were moderate or severe and have potential for harm and associated with significant worse outcome. Okay, based on the study by the Shafi S et al., they observed inpatient mortality, all right, with higher, about 30%, with higher 30 days readmission rate, longer length of stay, and higher cost of hospitalization, right? And we have existing guideline to incorporate the strategy to limit the opioid usage after surgery. So again, all right, ERAS is widely spread, cover almost everything. It can be applied piecemeal and not something that you have to apply every element of the recipes. Okay, opioid can be reduced by regional anesthesia, adjusting the intraoperative anesthesia by the anesthetist, and usage of the multimodal post-operative medication. Okay, so the regional anesthesia, this includes, right, neuroaxial blockade, epidural and spinal, okay, paravertebral, erector spine, or truncal fascia plane block, TAP block, RS or QL, which we go further later on, and also the non-opioid systemic analgesia. And these new strategies, so-called, can help, all right, to reduce the post-op nausea, vomiting, ileus, VTE, delirium, and somnolence. So I think most of us here agree that epidural is a gold standard in open abdominal surgery, isn't it? This is because of few numbers of reasons. Okay, so the first reason is, of course, it is excellent pain relief, right? For me or for other colorectal surgeon, we favor this method because number one, it can promote GI motility, okay, motility, okay, promote GI motility by blockade the sympathetic and unopposed the parasympathetic innervation. Right. Besides, some evidence also shows that epidural can increase the GI flow if the hypotension avoided and the effect of the vasodilatation comes. This might increase the blood flow to the anastomosis site, which is good, right? And many studies have been done and managed to prove the superiority of the epidural, right? So I would like to show you here some small study with the 42 patients involved. Okay, what I fancy about this study, they make an effort to standardize everything that happened to the patient in the wards. Okay, when patients should be mobilized, removal of NG, what day, start feeding, drains, and catheter removal, all being standardized on a certain day. And they found that the epidural, all right, significantly provide better post-op pain compared to the PCA. This is based on the assessment by using the visual analog score. And there is also the reduction of ileus also favor the epidural as reflected on passage of flatus and bowel movement. And also readiness of the discharge about a day and a half earlier than PCA. So epidural gained more popular and stated as A level and also recommended in ERAS. And most importantly, he also recommended in European Society of Regional Anesthesia and Pain Therapy and was classified as a grade of recommendation A, okay, or GORA. However, epidural isn't always possible. There's a few limitations, which include patient refusal, right? And then local infections, all right, for example, skin or spine, and then coagulation defects or drug-induced, for example, antiplatelet or warfarines, patient allergic towards the medication, towards the LA, and technical problem related to the anatomy, probably scoliosis or morbid obese patient. And failure rate of epidural, okay, the epidural failures occur up to 30% in clinical practice. And this may be due to the technical or the drugs cause. So that's come where there is another alternative way that we could offer to the patient, include the truncal fascia block, right? And it got many types, as we mentioned earlier just now, which is transversus abdominis plane or TAP block, rectus sheath and quadratus lumborum, QL block, or more proximal, if you want to go, we could offer the paravertebral blocks, okay? And this TAP block, all right, is quite famous. It was started in 2001 and has many variants of approach where you could do lateral, posterior, subcostal, or you want to do it via blind technique, which is using the triangle of Petit, and using the ultrasound guided to give a better accuracy. And sometimes tap block also can be given by the surgeon, where we infiltrate prior to the closure of the abdomen. So this tap block coverage the anterior abdominal wall at T6 until L1. If you require supraumbilical coverage, posterior and subcostal tap is the choice. Okay, but the drawback is a short duration of both vacant and non-vacant, which is about 8 to 10 hours. And these could be improved by pharmacological modification or infusion of the catheters. Okay, tap block also, all right, is less hypotension, causing less hypotension and retention compared to the epidural. So if you have a look at the anatomy of the TAP, okay, here are the 3 layers of the muscles. It's the external oblique, internal oblique, and the transversus abdominis. So the nerve originate from the paravertebral space, then they travel from the posterolateral and go to the anterior and supply the anterior abdominal wall muscles. And the nerve lies on the transversus abdominis muscle. This is where we infiltrate, okay? We infiltrate the LA and the space between the internal oblique and the transversus abdominis, which is shown in the ultrasound. So this is LA. So a systemic review and meta-analysis revealed that tap block reduced 24 hours of morphine usage, right? And then which is the mean reduction of 23 milligrams. And what about the systemic non-opioid multimodal? Okay, beside morphine, this selective COX-2 inhibitor also can show that it can decrease the morphine consumption at 24 hours by 50%. And also the conventional NSAID, which is Brufen, about 60 milligram, is efficacious as 15 milligram of oxycodone hydrochloride. And IV lidocaine, all right, reduce the opioid consumption, reduce the opioid consumption and also decrease the post-operative pain, as well as a reduced length of stay in the hospital and earlier return of the bowel function. And last but not least is paracetamol, which reduce post-operative opioid use as much as 30%. And the efficacy is same with IV or oral, but the oral is less, in terms of cost. So these here are the algorithms based on the prospect recommendation for open colorectal surgery, where it suggests a mode of analgesia or type that should be given intraoperative and post-operative. So this is the guideline, and this is very a brilliant approach. And later, I think you guys can go through it. Okay, it is quite simple. And so we are going towards the end already. This is a take-home message for this presentation. So the old way and the new way. I think time has come to change the foundation of our practice from the opioid as a base to a multimodal practice is a new way. Right, wherein the analgesia is managed with the non-opioid based agent first, then layering on the additional of analgesic, serving the opioid as the capstones, the topmost in the analgesic management. Okay, and last but not least, surgeon and anesthetists should embrace the ERAS and the multimodal anesthesia with the intention to provide the best treatment for our patient. To implement this education or training, not only the doctors, but nurses, physiotherapists, occupational therapists, pharmacy, and dietitian is very important. Okay, set up a meeting, provide some consensus, also can help in the way to implement the this technique. And together we hope for the best. And this is the blue ribbon. It's actually represent the colorectal cancer awareness. And we wear this ribbon in March every year. And I think that's all from me. With that, thank you.
Assalamualaikum and a very good day to all participants of Northern Pain Refresher course. So I'm going to proceed with the latest prospect guidelines for elective cesarean section. There are 7 main recommendations based on the updated high quality systematic review. So it is important to actually have a good management of acute pain post-cesarean delivery, because not only we wanted to provide a good pain relief, but a good optimal pain management will lead to improved maternal-child bonding, successful breastfeeding, return to activity of daily living, and improved quality of life. And there has been numerous studies showing that if you had a patient with suboptimal pain management, they will have a persistent pain post-cesarean section, and they will have a much greater opioid use, and this will lead to a delayed functional recovery. Patient will also have an impaired maternal-child bonding, and there will be increase in postpartum depression. So these are the 7 recommendations for the improvement of pain control post-cesarean delivery. The strategies is actually to try to minimize systemic opioid utilization as much as possible, and also we are going to review it one by one. So these recommendations were taken from 145 studies. Out of that is 126 randomized control trials and 19 systematic reviews. We're going to start with the usage of the optimization of systemic non-opioid and opioid analgesics. So we're going to, what part of it is the recommendations of oral and IV paracetamol and also non-steroidal anti-inflammatory drugs. Both has been shown to reduce in opioid consumption, and non-steroidal anti-inflammatory drug is equally effective or much of a superior analgesia versus opioids. They have been shown to reduce opioid consumption, opioid-related side effect, and also leads to increase in patient satisfaction. So regular administration of basic analgesia should always include these two. What about the usage of IV dexamethasone? It has been proved from 4 RCT. The pain score is much better. It has been shown to prolong analgesic effect, reduce in opioid consumption, and also reduce need for post-operative antiemetic. Neurocell adjuvant drugs, morphine, has been the consistent recommendations from the previous prospect guidelines as well. The dosage recommendations is 100 microgram or much lower. You can go down up until 15 microgram without affecting the ED95. It can be used in combination. It should be used in combination with paracetamol, non-steroidal anti-inflammatory drugs, and dexamethasone if there's no contraindications. The dose to be given if patient had epidural as part of the cesarean delivery, whether you are using it for as continuous as combined spinal epidural, or you have a patient who had epidural catheter as pain as analgesia for labor pain and has been extended for cesarean section, the dose that should be given is 3 milligram. What about the systematic review evaluating norexamorphine and diamorphine associated respiratory depression after cesarean delivery? It has been shown that the prevalence is actually very low, relatively low considering all doses administered. However, you have to take into account that if you have a patient with risk factors such as above, you have to be considered whether not using it, or you have to think about other alternative rather than usage of norexamorphine. What about local and regional analgesia techniques? So for single shot local anesthetic wound infiltration and continuous wound infusion, you can use this because it leads to reduce in opioid consumption. And for QLB, transversus abdominis block, and rectus sheath block, it has been proven to improve pain relief, increase patient satisfaction, and resulted in a reduction of rescue analgesia. However, you have to bear in mind that if you have a patient who are already receiving intrathecal morphine, there is no added benefit if you use regional analgesic techniques such as the block mentioned. What about other non-pharmacological techniques to be used for pain relief? From these studies, it has been proven that usage of elastic abdominal binders can help in reduction in pain scores and also rescue analgesia, and it has been recommended in these guidelines as well. If you have these two technology, you can use that. Use these as well as part of your post-operative pain management, because both are recommended in the prospect guidelines. The pulse electromagnetic fields, based on the randomized double-blind placebo-control trial, it has been shown to reduce post-surgical pain and also analgesic use. And probably this has something to do with the fact that it reduced surgical wound exudate and edema significantly. It also had a very high level of patient satisfaction. Percutaneous electrical nerve stimulation of the auricle, I am not really well versed on how does it reduce the pain scores, but definitely it has been recommended as well in these guidelines. And if you do have this equipment, you can use it as part of the pain management for cesarean section. What about surgical technique? Does it really influence in reducing pain scores post-operatively? In fact, in fact, the answer is yes. And the incision of jaw Cohen is recommended over phalangeal incision because this incision actually very much avoid the nerve injury to the anterior abdominal wall compared to phalangeal incision, and has been shown to reduce post-surgical acute pain and also chronic pain. What about the avoidance of peritoneum closure? The two, actually a couple of RCT has been shown that closure of both peritoneum was associated with higher post-operative pain because the closure of peritoneum leads to traction and also leads to stimulations of the visceral and parietal nerve. So it leads to a much higher post-operative pain. So these are the summary of the overall recommendations for post-cesarean section. The major difference from the previous prospect guidelines was the fact that gabapentinoids, which were recommended before, is being removed due to the concern about side effects such as sedation and respiratory depression. And the 4 RCT evaluating the usage of preoperative gabapentinoid doesn't show any significant benefits when added to a multimodal analgesia regimen. Though you have to bear in mind that these are the recommendations for elective cesarean delivery. It's not applicable for patient undergoing cesarean section under general anesthesia or patient with pre-existing chronic pain. These are the summary, and I thank you very much for your attention.
Hello, good evening. My name is Usha. I'm from the hepatobiliary unit here in Hospital Sultanah Bahia. Thank you for the invitation to the Northern Pain Refresher course. The topic given to me to present today is about liver resection. Here, I'm going to talk to you regarding what we do in liver surgery. And the second part of my presentation will be regarding on post-operative pain recommendation, also in liver surgery. The outline of my presentation, I'll be speaking on the preparation and patient selection for surgery. What are the different types of incision that we do in open liver surgery, the different type of liver resection that we do, our aim for the patient in the post-operative recovery period. I'll be talking about the prospect working group analgesic recommendation in open liver surgery. And finally, a little bit of our experience here in our post-operative liver resection patients in Sultanah Bahia. The preparations and patient selection is very important in liver surgery. It is a major surgery, and however, most of our patients are elderly with comorbids. Some of them may have underlying liver disease, fatty liver, cirrhotic liver, hepatitis. These in turn may affect the patient's platelets and coagulation factors, where we need to screen them for. And especially in major liver surgery, we have to anticipate intraoperative blood loss. Hence, it's important for us to have cross-match ready for most of our patients. Our center, we do practice 6 hours fasting overnight. However, there are centers who practice carbohydrate loading pre-op. Most of our patients, especially those with major liver resections, we do prepare them with central venous line insertions. This will help us to monitor the central venous pressure intraoperative, and if needed, we try to always request our anesthetic colleague to keep the central venous pressure at less than 5. This is the reasons is that this helps to reduce the backflow from the hepatic veins. Hence, it helps to reduce the intraoperative blood loss for the patient. As you can see in this diagram, the liver is a big organ, more on the right side, right lobe. It's situated in the upper abdomen. Hidden, the right lobe is behind the ribs and the subcostal margins. And this is the reasons where most of our open surgery incision will be in the upper abdomen. In today's time, most of abdominal surgery can be done laparoscopically. Same goes to liver surgery. Big difference, as you can see on this picture. A liver resection can be done for a patient with just 5 ports, minimal access 5 ports. And post-resection, the specimen will be put into a bag, and the incisions at one of the port site will be extended, and the specimen will be delivered out through it. No arguments that laparoscopic surgery has advantage over open surgery in terms of post-op pain. And the prospect recommendations for laparoscopy surgery is simple: just basic analgesic plus local anesthetic to the port site, and with an option of interfacial plain block given to the patient. So these are the benefits that we can see in laparoscopic. In contrast to that, open surgery, we have different types of incisions, as you can see below. And all this depends on the pathology that the patient has, the site of lesions, and the planned type of liver resection that we have for the patient. So we have the right subcostal incision seen here, the first picture, and the lower left corner. This incision we commonly seen, especially in our open gallbladder resection. Second incision that we commonly use is the upper midline incision. And in cases that we need to gain further better access, we extend this incision to the right, laterally to the right. And this is what we call the Makoshi incision. In other liver surgeries, especially like in transplant, we have the Makoshi incisions, and another alternative is the Chevron incision. So the benefits of upper midline incision: less pain, less complications from the incision itself. This is particularly useful, especially if you're dealing with a left liver resection or small lesions on the right lobe in the anterior surface. However, for major liver resections or small lesions on the posterior segment of the liver, we may need to extend the incision for better access for us. And this is where you see the commonly used Makoshi incision. So just to briefly give you an idea of how we plan our incisions. For most liver surgeries, we start off with the upper midline incision. From this access, we will reassess again the tumors, whether is it resectable, how many tumors, whether we can remove the tumors with just depending on this incision. And we will decide if not, then we will need to extend the incision laterally. And as you can see in the second picture, this is called the Makoshi incision. There are certain times where for bigger liver lesions, that we will extend the incision lower down along midline, and sometimes along midline with extended right lateral. This picture shows us the self-retaining retractors that we use. Over here, this picture is a Thompson retractors. Sometimes we do have the Rajah retractors. All these are the same. The purpose of the retractors is to help us further increase the exposure of the operative field. One benefit is that it works very well. We just need to retract and lock it in place, and that's all, without needing many people to help to retract. One drawback is that if we retract excessively and need a prolonged long surgery, some of the patients, they do complain of pain because of the tissue stretching or the rib stretching at the site of the retractor placement. So this is something that we need to watch out for. The type of liver resection, it depends on what we are looking for to resect. It can range from a benign liver lesion, tumor, a metastatic tumor, primary liver lesions, or a liver transplant. So I'm just going to explain briefly on the type of liver resections. We can start off with we can range from a non-anatomical resections to a formal liver resection, of right and left, hepatectomy to extended liver resections, a liver resection with combination of ablation, multiple site of ablation of resections, and sometimes, especially in the liver tumor, if there is extension into the adjacent organ, especially in the diaphragm, we will need to do an en bloc resection. And there are cases where, especially in colorectal liver mets, we have primary liver tumors in the colon or the rectum and the metastatic tumor in the liver, where we can do a simultaneous resection at one stage. So in these cases, we will need to plan our incisions as try to minimize the incisions, and this will benefit the patient the post-op pain care. So this is an example of extensive resection that we do with below enteric anastomosis. This not just involve liver resections, but however, we do have bowel resections and anastomosis where we need to look after. The post-operative recovery period is a very important period. The very, very important part of it is the pain control. Most of our patients, we try to achieve an early recovery for them. That means early ambulations. We want them to breathe normally, early as possible. All this helps to reduce the post-operative complications. And we want to achieve early removal of the Foley's catheter, NG tube, drains when they're not needed, and we try and remove the excess lines as the patient recovers early. If the patient just undergoes liver resection without bowel resection or anastomosis, most of them we do encourage early back to oral intake. Coming to the second part of my presentation, I want to share with you is the PROSPEC. It stands for Post-Operative Procedure-Specific Post-Operative Pain Management. This is a working group recommendations which have on board anesthetists and surgeons, which come up on recommendation on what's the best post-operative pain management for patients undergoing open liver surgery. They assess the analgesic intervention types, the efficacy, adverse effects of analgesic events, and the outcome is mainly on the pain score, whether it's any rescue opioid use, recovery, patient's recovery, and any adverse effects from this. So the PROSPEC study recommendation is based on randomized controlled trial, systemic reviews, meta-analysis, all from a 10-year period from 2010 to 2019, all for open liver resections. The PROSPEC look into the primary outcome in pain. The primary outcome is pain, where they use the visual analog score and numerical rating score to determine the pain control. And the secondary outcome, they look into the cumulative 24-hour opiate requirement by the patient, any supplementary analgesic use in the period, then any opiate-related adverse effect to the patient, and the patient outcome. The recommendation by the PROSPEC, they use a methodology where the result is at least from 2 randomized controlled trials, and the recommendation must be relevant to the current practice. They also look into any excess, if any additional procedure-specific management, which benefits the patient on top of the regular basic analgesic regime that the patient has, which includes the PCM and the NSAIDs. 5 parameters that they look into, whether it's the need to add on the basic regime that patient already has, whether is the intervention clinically relevant to the patient, if there is a balance between the efficacy and adverse effects of the treatment, whether is the invasiveness of the intervention to the post-op pain, whether the reasons for not recommending the intervention appropriate. As we can see from the prospect, they have collected roughly 5,000 over papers, and through the exclusion criteria, they finally look into 31 randomized control trial and 3 meta-analyses to help them to make the recommendations. And over here, the preoperative, these are some of the papers, the relevant papers that I've picked up to show you. The preoperative intervention for NSAIDs, we can see is a comparison between intravenous Perioperative versus placebo, and where the post-operative patients are also given fentanyl PCA in these 2 groups of patients. And we can see the Perioperative, in the Perioperative group that the patient was given, there is reduced in the fentanyl usage in the first, especially in the first 48 hours compared to those with placebo. And for papers where they look into the interfacial plane block, especially in the use of transversus abdominis plane block. We can see over here in Go et al. Studies, there's a good early post-operative pain control for this group of patients. In the thoracic epidural analgesics, we can see that over here there is a reduced pain and increased overall satisfaction as compared to the conventional analgesic methods in patient as compared to patient with TEA. Okay, just briefly on basic analgesics use. The NSAIDs, most of them are given IV paracorsibs. The recommendation for NSAID use is before induction, intra, and post-operative round-the-clock 12 hourly. And acetaminophen, we don't really use them over here in our setup in liver resection, especially because of the fear of toxicity. Many of our patients, they have underlying liver disease, and because of intraoperative bowel clamping and intraoperative liver injury from the resection, most of our patients have post-operative transient increase in liver enzymes. There's also risk in patients, elderly patients, and also those with malnutrition. The second type of recommendation is the regional anesthesia. There's 2 types. One is the thoracic epidural anesthesia. Second type is the interfacial plane blocks. For the thoracic epidural anesthesia, it helps in the deep breathing. It has leading to lesser respiratory complications. It's helped in the opiate sparring. It leads to better GI functions. There's a use of intraoperative sympathetic blockage and vasodilatations, where intraoperatively it helps reduce the CVP, leads to lesser blood loss in liver resections. However, in patients with coagulopathy, there is a risk of epidural hematoma and there's also a risk of neurological injuries from the procedure itself. With the catheter at the back, there is a delay of ambulations post-operative in some patients, and in those with post-operative coagulopathy, this leads to delay of removing of the catheter. So hence, with all this, some patients may have a longer length of stay in the hospital. Second part of regional anesthesia that recommended is the interfacial plane block. Looking at this, a few types: subcostal transversus abdominis plane block, the quadratus lumborum block, and aortic spinae block. Out of these 3, you have specifically recommended towards subcostal transversus abdominis plane block. So the preference is this. I'm going to estimate a bit. It's a catheter placed in the transversus abdominis plane space by using ultrasound guided. It can be on the one side or both sides, bilaterally, subcostal to cover the surgical field. The analgesia given can be a single shot versus the infusion. There's no any studies comparing these two yet. However, some studies says that a large volume of a drug used in the infusion, most of them, the drugs used needs to be metabolized by the liver. Hence, there's a risk of liver impairment seen in those, especially those in post-hepatectomy. However, the author do recommend a safe use of ropivacaine in this. Recommended dosage is 3 milligrams per kg, given bolus 12 hourly through the catheter for 48 hours. The alternative to this is the levobutyrocaine. However, this drug still requires further studies. So at the end of the prospect study, you see the recommendations for them is they have simplified into this chart. Patients preoperative, intraoperative, given paracetamol, NSAIDs, especially Periprocedural, a choice of either thoracic epidural or a subcostal transversus abdominis plane block. Drugs can be given either single shot or continuous infusion. And in the postoperative period, recommendation is to continue with either paracetamol or NSAIDs, and the catheter-based regional anesthesia technique is recommended. So systemic opiates is only used as a rescue analgesic post-operatively. So the prospect studies also list down a list of drugs which are not recommended: ketamine, gabapentinoids, lidocaine IV, dexamethasone, intraoperative dexmedetomidine, intraoperative magnesium sulfate, morphine, quadrius lumbritum block, continuous wound infiltration, continuous parietal nerve block, postoperative intraocular local anesthesia. These are all not recommended due to lack of procedure-specific recommendations or limited procedure-specific evidence. So our experience over here in Hospital Sultanah Bahia, our aim, still we find that the pain control is important, especially our aim for early recovery for patients. We want the patient to get up, start ambulating fast. We need to remove their drains, their Foley's catheters, and we want them to be able to breathe well, all this to reduce postoperative complication risk. And one of the ways that I usually ask my patients to do in the postoperative recovery period is I tend to do the spirometry. If they have difficulty performing the spirometry because of pain, this is where one of the ways that we know that the energy cell that we're given to them is inadequate. Okay. Epidurals, from what we see is that there's always a fear that patient will have urinary retention if we remove their catheters, especially for males, when they are still on the epidurals. Okay, this leads to the cases where they will be dependent on the Foley's for sometimes many days. It sometimes affects their ambulation. Patient can't walk. Patient most will just sit up on the bed, and sometimes we do see hypotension in these patients. There are some patients who complains of pain, post-operative pain, despite we have given them epidurals, PCAs, even add-on oral analgesics. So these are times that we have to call our anesthetic teams, the acute pain service team, to come and look at them, especially at night. In our centers, we don't use much of a PCM, especially in liver surgery. NSAIDs, yes, sometimes Periprocedural, and but mostly we use Cerebrex for our patients. TAP blocks, I don't see much in our centers, but however, in other centers, I do see that cable box is being used quite frequently, especially surgically placed intraoperatively. They will place the catheter intraoperatively, as you can see on this picture. The catheter will be placed at the transversus abdomen is planed, and the patient will be given bolus drugs during the postoperative periods, and it works quite well. Okay. Lastly, I do find that pain care needs to be personalized, as in line with the theme of this course. This comes to the end of my presentation, and I thank you very much. If there's any questions, please do pass them to me.
Assalamualaikum and a very good afternoon. Thank you for staying with us up to this hour. I will discuss on prospect recommendation for rotator cuff surgery. Why the need for such guideline? Because there was no prior guideline, and hence there's significant variations in protocol. And as you can see, there are many factors that can affect outcome, modifiable ones and non-modifiable ones. The non-modifiable ones that is probably something that one could have a look at. Perioperative expectation, counseling could definitely improve outcome and pain relief following surgery, regardless of surgical technique. And we all know that rehabilitations post-operatively is desired in rotator cuff repair. And we all know that one of the reasons of prolonged stay or readmission is uncontrolled pain post-surgery. Jumping on straight to overall recommendations of prospect for rotator cuff repair, pre and intraoperatively PCM, coccyx, and DEXA has always been the practice and recommendations. Regional anesthesia were given a high grade of recommendation into scalene block, continuous or single shot, as well as motor sparing suprascapular nerve block with or without axillary nerve block. Post-operatively, again, PCM and coccyx both are recommended, as well as a presence of rescue opioid in 24 to 48 hours following surgery. And we all know arthroscopic, minimally invasive surgical technique has always been recommended by prospect. In view of high grade of recommendation for interscalene block, and this paper has been given highlight by the prospect group, one by Peter Mahofer, looking at retrospective analysis in one of the busiest East Europe ambulatory orthopedic surgery clinic, where they do a lot of catheters, interscalene catheters, which patient normally will bring home and manage themselves post-surgery. And what they found was that most of the interscalene block related adverse events are due to insufficient block, either because of this dislodged catheter that needs reinsertion, or catheter dislodgement at home, or distal disconnection of catheter at home. Very few proportion of patients get morbidities related to the block itself, whether it is secondary to pneumothorax or phrenic nerve injury or phrenic nerve paralysis. Why shoulder joints? We know shoulder joint is not a simple joint. It is a complex joint, comprises of 3 bones, 3 joints, and 3 muscle groups. You have clavicle, scapula, and humeral head connecting with each other, and 3 joints involved in functionality of the shoulder: the acromioclavicular joint, the sternoclavicular joint, as well as glenohumeral joint, and 3 muscle groups that is involved in mobility and functionality of the shoulder joint, namely the one that attach the joint to the head, the trapezius muscle groups, the one that hold it against the axis, the pectoralis groups, and the one that functions in all the range of movement over the shoulder, that is the biceps and the deltoid groups. And apart from muscles, one of the most important aspect of shoulder joint is also its innervation, which can be very complex and have some form of variations as well. If you look at this cadaveric dissection study by Philip Pang from Toronto with this group, looking at where to deliver radiofrequency block for nerves, and the cadaveric dissection showed that suprascapular nerve from its three main branches, the superior branch, inferior branch, and acromial branch, mainly supply the anterior and posterior, anteroposterior and anteroposterior and anterosuperior and posterosuperior quadrant, or what you call superior quadrants of the shoulder joint, where the anterior superior quadrant has also some innervation from the lateral pectoral nerve as well as nerve to subscapularis. Some also gets innervation directly from the posterior cord itself. In the inferior quadrants of the shoulder joint has mainly innervation from the axillary nerve, and with its main anterior or posterior divisions, as well as some branches from the lateral pectoral nerve, as well as direct contribution from posterior cord of brachial plexus. And in order to understand where one would deposit local anesthetic in the interscalene groove, we also frequently have to understand the arrangement of upper trunk of brachial plexus, which is mainly formed of C5 and C6 nerve root. Looking at what was previously thought as the simple division of upper trunk or stoplight sign, now people have understood it better with cadaveric dissection. The upper trunk itself is usually trifurcated, with the arrangement normally is formed of SPA arrangement from top to bottom, the suprascapular nerve, posterior division, and anterior division of upper trunk. So the suprascapular nerve can branch out much earlier in the course of upper trunk of brachial plexus. This has one who does interscalene block regularly have to understand this. And if you look at the fascicular map of the main root of brachial plexus itself, the arrangement that supplies the shoulder, mainly coming from suprascapular nerve fascicles, axillary nerve fascicles, as well as the posterior cord brachial plexus, are mainly coming from the craniodorsal topographical region of the root of brachial plexus, or upper trunk of brachial plexus. So if we come in from the lateral aspect of the nerve, we would definitely encounter this part first, and this is where we should deposit our local anesthetic rather than trying to get onto the contralateral aspect of needle entrance. And we also know from cadaveric dissection and recent publication that what we used to think as a stoplight sign comprising of three main roots of brachial plexus, C5, 6, 7, it could actually be the bifurcation of the actual root of C6 or root of C7. So it is not recommended. It could be dangerous if you try to dissect the stoplight sign to get onto the contralateral side to have a better so-called spread of local anesthetic around the root of brachial plexus, where you could actually cause nerve injury by trying to separate the main bifurcated root of upper trunk or root of C5 and C6. And next is where the motor sparing nerve block comprises of suprascapular nerve or axillary nerve block is normally done or performed. Suprascapular nerve, you want to cover mainly sensory branches, could be done or could be performed either blindly by our surgical colleague or by ultrasound guidance, looking specifically at suprascapular nerve notch and deposition of the local anesthetic just under the suprascapular ligament. And this is how it looks like in the interscalene region, where the nerve C5, 6, and 7, if you can, if you could scrutinize this image, you can see C7 just coming in at the lower bottom of the screen, 6, C6 just coming out, and then video is looping back and forth. And you could clearly see that the C6 is bifurcated as it goes and emerge underneath the sternocleidomastoid region. And this is where suprascapular nerve is located, just as it comes out from the brachial plexus underneath the omohyoid branch. And this is also another location in which you can block the suprascapular nerve anteriorly before it causes underneath the supraspinatus to dive into the suprascapular notch posteriorly around the scapula. So what is not covered here, briefly look at the nerve, the interscalene groove, the variations of nerve, but not in depth. I'm just try to cover the basics. The location of dorsal scapular nerve, which could be injured with interscalene injections, long thoracic nerve, how you would have to understand the dermatome, the myotome, and fasciotome related to innervation of nerve that gets injected. All this need to be understand in great detail so as to perform your block in a safe and effective way. Next is dexamethasone. We know that it comes from extrapolation of other surgical anesthetic related studies from major surgical procedures. It may carry small marginal significance in terms of reduction in opioid consumption 2 hours and 24 hours post-surgery. If you look at this pool analysis, it is quite heterogeneous. And the significant improvement is just 0.8 to 2.3 milligram of morphine over 24 hours, which may not be significant, but I believe dexamethasone has other role as well, reduction in nausea, vomiting, as well as some form of tissue inflammation and edema. Next is NSAIDs and PCM, one of the frequently quoted systematic review by Martinez in 2017. This is one network geometry analysis which he has beautifully organized. The green lines indicates how many studies involved, and the red dots indicates how many subjects that is pulled into the study. If you look at the dots here, the placebo looks like it is overrepresented. So meaning that there are not many trials or drugs used in combination to be studied head to head. They don't compare in between drugs to drugs, they just compare to placebo. So they can give you good number needed to treat, but they can't compare in between drugs, for example. But most of the drugs are effective. All the green lights show that these combinations are all effective, from tramadol with NSAID, acetaminophen with NSAID, acetaminophen with or PCM with metamizole. Metamizole is a type of NSAID. Nefopam, there are a number of studies involving nefopam, which are all effective if you look at the network geometry analysis. Nefopam is a type of, it's a cyclical analog of phenedrine, which I think our orthopedic colleague has been using all this while. And we also know that the combination of PCM and nefopam, or PCM and NSAID, has a better indicator of superiority compared to looking at pain relief in comparison to opioid use and opioid consumption. And lastly, interventions that are not recommended preoperatively: use of gabapentin, intraarticular injections, stellate ganglion block, cervical epidural block, perineural adjuncts, intraoperative hypotensive anesthesia technique, early in post-operative early motion protocol versus delayed motion protocol. All these, some of the centers, I believe, has been practicing it. I know we have been doing compressive cryotherapy, but this is not included in the recommendation because of lack of procedure-specific evidence. It doesn't mean that it is not effective. Maybe it has not been recommended because of lack of evidence. And surgical technique that was mentioned to not being recommended hypoosmotic irrigation, single row ankle fixation, and injection of PRP supplement following surgery. Okay, I'll stop here and I'll be glad to share more knowledge with the question and answer session. Thank you very much.
Hello, everybody. I will continue with the next prospect series. I'm going to talk about prospect publication on complex spine surgery. This is the latest update. This review article was just published this year in European Journal of Anesthesiology. If you are interested, you can look up for this paper. As we all know, complex spine surgery is almost always associated with significant post-operative pain. If patients continue to have pain, it will affect their post-op rehabilitation care and long-term outcome. If pain persists, this can become a chronic pain. In the study, complex spine surgery is defined as any thoracolumbar spine surgery with instrumentation. Second, any laminectomy involving 3 and more levels, and obviously scoliosis surgery. A bit on their qualitative analysis of outcome. From their search, they have identified 111 eligible studies, out of which 31 RCT and 4 systemic reviews meet their inclusion criteria. And pain intensity score were used as their primary outcome measure. Unless specified otherwise, it was assumed that all the pain scores were set at rest. In the study, they have identified 10% changes as a clinically important. It means that more than 10 mm different on the VAS score or 1 point on numerical rating scale, considered as significant. The effectiveness of each intervention for each outcome was evaluated qualitatively by the number of studies, showing a significant difference between the treatment arms. Then I will move on to the prospect recommendation. It's categorized according to preoperative, intraoperative, and postoperative intervention. First, preoperative intervention. It's advised to use paracetamol plus NSAID or COX-2 inhibitor. No oral gabapentinoids. Paracetamol and NSAID have demonstrated a good analgesic benefit and has opioid-sparing effect. It's recommended to use it at a fixed time interval, then on demand basis. This is a take-home important message. Please use it around the clock doses, no PRN. Earlier literature suggests concern that NSAIDs can inhibit bone healing and hence the risk of non-union. However, studies have proven the effect is dose and duration dependent. As long as we use it less than 2 weeks, it's well tolerated and does not interfere with osteogenesis. In addition, NSAIDs do not increase risk of bleeding. It is safe to be used in spine surgery. Next, I will go to gabapentinoid. Gabapentinoid includes gabapentin and pregabalin. We use it as part of our multimodal approach. When we talk about multimodal approach, we means we use 2 or more analgesics to improve pain efficacy, and it reduces the side effect of each drug. So the combination of oral gabapentinoid and IV opioids can reduce post-op pain score and opioid consumption as compared to IV opioids alone. However, the combination can have significant adverse effects such as sedation and respiratory depression. I would like to draw your attention to this paper published in Anesthesiology 2016. They study pregabalin, the combination of pregabalin and remifentanil in terms of analgesic, ventilatory, and cognitive effect. This is a randomized, double-blind crossover study involved 12 healthy volunteers. Tablet pregabalin 150 mg was served at night and on the next day in the morning of the surgery. So the addition, the combination of pregabalin and remifentanil had addictive analgesic effect. However, by adding in pregabalin, it potentiates remifentanil's induced ventilatory depression, and it had adverse effect on patient cognitive level. So this is a contradict to our multimodal approach. What we want is improve the pain relief, but no further side effect. So this result question the clinical benefit of combination of pregabalin and our usual opioids. Hence, gabapentinoid was not recommended in the prospect recommendation. Next, I will go to intraoperative intervention. Under their recommendations are paracetamol and NSAID if time interval allowed, low dose of ketamine infusion. Third is epidural infusion of LA plus minor opioids. However, here we have a long list of not recommended intervention, including IV methadone, IV lignocaine infusion, intrathecal opioids, wound infiltration, IV glucocorticoid, IV dexmedetomidine, IV magnesium, and epidural opioids. Let's look at ketamine first. It's recommended use in spine surgery due to its significant opioid-sparing effect, especially in opioid-dependent chronic pain patient. It can be given as a bolus dose of 0.2 to 0.5 mg per kilo and continue as infusion of 2 microgram per kilo per minute. If your patient is about 60 kilogram, it is about 0.1 milligram per kilo per hour. And ketamine infusion should not be continued in post-operative due to potential risk of side effect and insufficiency evident. Let's look at this paper published by Avidan et al. In Lancet 2017, or is called podcast trial. This is a very good design RCT involving a good sample size involving 672 patients, multi-center and internationally. They want to study whether placebo low-dose ketamine and versus high-dose ketamine can prevent post-op delirium and the pain control. They have recruited patients more than 60 years old, going for cardiac and non-cardiac surgery, not specific for spine surgery. They have concluded no difference in the incidence of post-operative pain, opiate consumption, and delirium, not effective in prevent delirium among this group. However, significant more post-operative hallucination and nightmare with increasing ketamine dose. This effect might even last for up to 3 days. This is the reason no ketamine infusion after the surgery. Next is epidural analgesia. I couldn't trace back who was the first person inserted or started using epidural for spine surgery. Anyway, this method, intervention, have gained a lot of attention from anesthesiologists and surgeons. Some support and some against the epidural use. Let's look at a paper, Support Epidural Use, by Park and Chesler in 2016. They had done an RCT compare epidural infusion, 0.2% of ropivacaine versus our conventional IV PCA opioids. So epidural groups, there is a lower pain score, low dose of post-op, lower dose of post-op opioid requirement, and even they have infused it intraoperatively. It is proven to reduce the pain score and no problem in assess the neurologically. However, this paper by Choi in 2014, they compare placebo control trial, compare PCEA 0.1% ropivacaine plus hydromorphone versus PCEA saline infusion. No statistically significant in the two groups. So when we talk about epidural analgesia, what comes to our mind is how about any side effect that we are worried? We are worried more about examples like difficult to perform neurological assessment after the surgery. If patient develop post-op complication such as epidural hematoma, would there be any late detection and we miss the golden hours? And let's look at the adverse side effect. Most of it are serious complications such as iatrogenic infection, meningitis, epidural hematoma, allergic reaction, catheter migration become intrathecal catheter, dural leakage, and violation of spinal cord. These are the few papers published. This is published in European Journal Spine. They have done a prospective randomized control comparative study of postoperative pain control using an epidural catheter in patients undergoing posterior lumbar interbody fusion. So they have concluded, in comparison with the use of IV-PCA, or conventional, continuous epidural infusion of ropivacaine result in lower pain score and opiate consumption and higher patient satisfaction level after posterior lumbar interbody fusion. Here, this is another paper published in Journal of Neurosurgery, Spine. They study postoperative patient control epidural analgesia in patients already with some inflammatory condition, spondylodiscitis, and posterior spinal fusion surgery. So, PCEA may reduce postoperative pain and it lead to earlier achievement of functional capacity at a lower complication rate in patients with surgically treated lumbar and thoracic spondylodiscitis. This is a positive, very positive outcome. However, one more paper in Orthopedic Review in 2010, they study efficacy of postoperative analgesia after posterior lumbar instrumented fusion for degenerative spine disease. So from the abscess, it stated there was significantly more side effect in the epidural groups, including complete, reversible loss of sensory function and motor weakness. There were no major side effects such as infection or persisting neurological deficit in either group. However, the routine use of epidural anesthesia for lumbar spine surgery has too many risks and offer very little advantage over PCA. So now let us look at our prospect recommendation. So it's recommended to use epidural catheter. It should be placed under direct visualization by the surgeon at the end of the surgery. The catheter tip can be placed one level cathelet to the level of instrumentation and tunnel distant to the incision and anchor to skin by a suture. Second, low concentration of LA should be used in view of possibility of delayed diagnosis of neurological complication. Third, the use of epidural analgesia should be individualized. It depends on our patient and the planned spine surgery. I go through some of the paper. Some have performed radiological imaging to verify the precise position of the catheter after the surgery. So far, no major adverse effect been reported in the literature. So now I list down some of the not recommended intervention in complex spine, such as gabapentinoid because of significant risk, as what I have already mentioned, IV glucocorticoid because lack of evidence, and these are the list of limited evidence as I have already mentioned. However, for LA wound infiltration, it's classified as limited and inconsistent procedure-specific evidence. Let's look at LA wound infiltration. LA wound infiltration is widely used in abdominal and colorectal surgery. Is one of the recommended tools. And in the market, we have this special catheter, multi-hole catheter with a special infusion set to be inserted at the lower end of incision along the length of wound. So maybe some of these data been extrapolated to be used in the spine surgery. Anyway, there are two schools of the thought about the technique of insertion. One school said that the first catheter, they position it under the paravertebral muscle, considered as deep level. Second catheter, same patient, is just placed above the deep fascia, considered as a superficial layer. Or maybe most of the surgeons are comfortable just insert the catheter towards to the subcutaneous tissue on either side of the incision just before the wound closure. So if let's say we look at Jagat, the paper by Jagat, they have done showed wound infiltration have shown an effective after laminectomy and microdiscectomy. However, another paper by Greece, negative result for complex spine surgery in adult. A placebo-controlled trial compared 0.2% ropivacaine LA infiltration after posterior fusion. No different in terms of pain score and rescue analgesia. So this technique is not recommended due to limited and inconsistent evidence. How about regional analgesia interventions such as erectile spinal pain block, thoracolumbar interfacial pain block? This is a very new block and have gained a lot of popularity. However, because of limited data, maybe we have to wait more for the time. So far is not recommended due to limited evidence. Then I will move to post-operative intervention. We can use post-op, we can use paracetamol and NSAID or COX-2 inhibitor, opioid as a rescue analgesic. If surgeon have inserted epidural, then we continue epidural infusion. No IV ketamine infusion as post-op intervention. So I have tabulated it in this paper. You see, it's very clear. This is the overall prospect recommendation from pre-op IV, from pre-op paracetamol and NSAID, intraoperative paracetamol NSAID plus IV ketamine infusion. Post-operative, as I mentioned just now, epidural analgesic, epidural infusion if surgeon have inserted the catheter. Continues around the clock paracetamol and NSAID, remember, and then opioid as a rescue medication. This is my last slide. So the review article have few limitations, such as heterogeneity across the study. They cannot control the type of surgery, the number of vertebral body involved. Also, lack of specific type of low back pain, whether it's just axial pain or is involve a radicular pain. Same as special patient population. How about patient with low back pain with opioid dependence, or patient with a major psychiatric disorder? We are lack of data. Also heterogeneity in drug doses, route of administration, and sample size. So I hope that I give you a very clear picture and recommendation intervention for complex spine surgery. I hope that we all can use the evidence-based approach in our clinical practice in the future. Thank you for your attention. Bye.
Very good afternoon to all. Today I'll be presenting on prospect guidelines for hip fractures. Falls seems to be quite common in the elderly age group, and most of them result in hip fractures. There seems to be serious consequences because of the hip fractures, and mortality is at about 10% at 1 month after the fall, and almost 30% at 1 year. Demographics, worldwide it is found that hip fractures are expected to surpass 6 million by the year 2050. And the average age of patients is around 80, and 75% of them appear to be females. And about 1/3 of these fracture patients go on to receive a total hip replacement. NICE came up with guidelines regarding THR for patients with displaced intracapsular hip fracture. So it is indicated to do THR for these hip fracture patients if they are able to walk independently outdoors prior to the fracture, if they are not cognitively impaired, and also if they are fit for anesthesia and procedure. Timing of surgery, it should be ideally done within 24 to 48 hours, and any delay of surgery beyond 48 hours results in increased risk of morbidity and mortality. If patient is bedridden for some time, there's also risk of developing fracture sores, which may lead on to sepsis. And an increase in length of post-operative recovery results in due to loss of muscle strength, leading to difficulty in ambulating patients. A New England Journal of Medicine came up with a study, published a study which showed that delaying hip fracture surgery for more than a day was associated with a higher mortality risk. Another study similarly done showed that there is an increase in the number of mortality among patients with hip fractures if surgery is delayed after day 3. Locally, also a study was done in Hospital Sultan Bahia, which is yet to be published, which showed that there was an increase in mortality rates in patients with hip fractures if there was a delay in ambulating them. So there are a lot of challenges in managing patients with hip fractures. One of it is multiple comorbidities. So these patients who are elderly, they often present with multiple illnesses such as ischemic heart disease, cardiac failure, COADs, uncontrolled diabetes, hypertension. So it may be a challenge in optimizing these patients prior to the surgery. Also, some of them may be on anticoagulants, antiplatelets, and we may need to hold the surgery for a day or two in order to withhold the anticoagulants or antiplatelets prior to the surgery. And mode of anesthesia, general anesthesia or spinal regional anesthesia may be a difficult option in some patients. Pain management also is a difficult challenge in these patients as many of them may have underlying chronic kidney disease, which makes NSAIDs questionable use of NSAIDs in these patients. Patients with underlying IHD or stroke, where there may be caution needed when using NSAIDs. Patients with underlying chronic liver disease, where PCM may be contraindicated. So there are lots of problems itself with choosing the appropriate analgesia for these patients. Post-operative rehab also may be an issue if the pain is not properly addressed, or if a patient is medical conditions are unstable or they are weak to start off with. And all this, if not addressed properly, may lead to increase in morbidity and mortalities. So if THR is done well, the effectiveness of it is often limited by the post-operative pain management itself. If the post-operative pain is not addressed properly, the rehabilitation part can be hindered, as when in pain, patient may have difficulty walking, may be reluctant to walk or move from their bed. So when pain is also not addressed, delirium may come in, depression, sleep disturbances, delayed ambulation leading to deconditioning, DVT, PE, associated pneumonia, and all these complications may then lead to delayed transition to lower levels of care, and thus delaying discharge and also increasing the medical cost for the patient. So some issues which may be a challenge in pain management include in the elderly, include their comorbid diseases and concurrent medications, as I explained earlier, diminished functional status, age-related changes in pharmacodynamics and pharmacokinetics, meaning that there may be a delay in the metabolism and elimination of drugs, and also the drug effect on the body may be stronger than usual. For example, opioids, it may be causing extra sedative effects and respiratory depression in the elderly. And also these patients, sometimes they may have hearing problems, they may have dementia, and they may present with cognitive impairment and also have difficulty in communication, and also making it difficult for us to assess their pain. So after looking into all these issues and challenges faced by patients with hip fractures, the European Society of Regional Anesthesia came up with a prospect guideline, which is a procedure-specific pain management guidelines for total hip replacement, which has been updated in 2019. And the perioperative analgesia in this guideline can be extrapolated to patients with hip fractures. All right, so total hip replacement is associated with significant post-operative pain. And the aim of this guideline is basically to provide the clinicians with an updated evidence-based approach to pain management for total hip replacement. So Joshi, one of the person involved in coming up with the prospect guideline, says that adequate analgesia with minimal side effects allows early post-operative rehabilitation, mobility, optimal functional recovery, and decreased post-operative morbidity. So basically, the guideline balances the efficacy and benefit of the analgesic intervention to the general risk and also the invasiveness of the procedure involved. So this guideline was produced after researching through 1,152 records. So out of these records which were screened, about 129 were picked, and after excluding the inclusion and exclusion criteria, and out of these 108 were RCTs and 21 were meta-analysis. So that's how the guidelines came about. So the prospect recommendations include pre-operative exercise and education. So patients should be encouraged to start their rehab even pre-operatively, because good muscle function and good general condition is very well needed for improved functional outcome in a THR. And also relevant education regarding the perioperative anesthetic management, perioperative analgesic management allows the patient to be mentally prepared and look forward to the different modes of anesthesia, analgesia, which may be provided for the patient. Okay, so for THR patients, mostly we recommend paracetamol and NSAID or COX-2 selective inhibitors. However, there is insufficient evidence to determine whether preemptively COX-2 administration has any advantage over post-operative administration. And short-term use of NSAIDs is not associated with increased risk of perioperative MI, and there's no evidence to choose any specific NSAID or COX-2 selective inhibitor. So opioids, it's found that there's no additional benefit over oral oxycodone when PCA morphine was used. So patients can be put on oral oxycodone regular doses plus PRN doses for breakthrough pain. And there were some other studies comparing IV morphine versus combination of IV oxycodone and morphine. So there appears to be no difference in pain scores. So a single opioid would be adequate. IV fentanyl showed lower pain scores and lower morphine consumptions than IV oxycodone. And then ITM doses of 0.05 milligram versus 0.1 milligram was compared. And it was found that in patients receiving 0.1 milligram, they had lower pain scores. And however, there was increased incidences of post-operative nausea, vomiting, and pruritus. So because of the side effect, there was side conflict among the prospect researchers, and not all recommend ITM unless spinal anesthesia was given, and there's and the benefits versus the side effects have been weighed. And modified release morphine did not improve pain scores, but was found to have increased opioid-related side effects. Dexamethasone was found to improve postoperative pain outcomes, so we usually give it in doses of IV 8 milligram or 10 milligrams, and it was found that with Dexa, it has got good antiemetic properties as well. It also reduced length of stay, reduced morphine usage, and also found to have a small but significant increase in blood glucose concentration in diabetic patients. So may need to monitor blood glucose in these patients. However, there was no difference in post-operative infections. Okay, some other adjuvants such as gabapentinoids are occasionally used. However, Prospect does not recommend it in view of the side effects related to gabapentinoids, such as dizziness and risk of fall. And also it's inconsistent regarding pain reduction. Ketamine was found to reduce 48-hour morphine consumption. However, no difference in pain scores and side effects. Neuroaxial anesthesia generally improved postoperative outcomes. Generally, the mode of choice for anesthesia for most patients for THR, unless contraindicated, and we have to opt for general anesthesia. However, the benefits of neuroaxial anesthesia with regard to postoperative pain control still remains inconclusive. Additional analgesic interventions in patients with chronic opioid use, chronic pain states, and also psychiatric disorders such as schizophrenia may be needed. So epidural, right? Epidural analgesia is found to be effective for pain relief, but not recommended due to the side effects related, such as limb weakness, bladder dysfunction, delayed mobilization, and in some patients who are very sensitive to the epidural, hemodynamic instability. Sometimes we see a lowering of BP and in the patients, especially when volume is also inadequate. Epidural levobupivacaine with sulfentanyl adjuvant was a study done comparing both this comparing with oral control release oxycodone. It was found that there was a better dynamic pain relief with epidural and lower opioid consumption on day 1 post-op. However, from day 2, day 3 onwards, oral oxycodone was more effective on pain control at rest. So maybe we can allow the epidural to go on for 1 day and convert to oral oxycodone for day 2 or day 3 post-op. Peripheral nerve block and local infiltration analgesia. There are a lot of potential benefits, and these benefits are balanced against side effects. So peripheral nerve blocks are up and coming. More and more are actually doing nerve blocks for patients with total hip replacement. However, some nerve blocks are found to have delayed mobilization, profound motor block, and also this gives rise to falls during ambulation of patients. So some nerve blocks have been found to lower the post-operative pain scores and also reduce morphine consumption. Lumbar plexus block, femoral nerve block, although effective, however, due to the side effects such as lumbar plexus block, which is a deep block with potential risk, and also femoral nerve block, which gives significant muscle weakness, is best to avoid in total hip replacement. Fascia iliaca block, which is a plain block, more of a sensory blockade, is recommended for total hip replacement for analgesia purposes. Single injection local infiltration analgesia has analgesic effect with no side effects. Another up and coming block, which is the PENG block or the pericapsular nerve group block. There are more and more evidence gathering around this PENG block, where it was first described in 2018 for post-operative analgesia and total hip replacement, had motor sparing benefits. Okay, so provided more complete analgesia to the hip, and it was found that the maximum pain score of patients was significantly lower in the control than the control group at all time points. Opioid consumption also seemed to be lower, and there was a better range of hip motion. Patient also ambulated faster, and this gave improved post-operative functional recovery. So in summary, these are the prospect recommendations. Pre-op exercise, general spinal anesthesia, paracetamol, NSAIDs, dexamethasone, single shot fascia iliaca block or LIA, and intrathecal morphine grade D evidence of 0.1 milligram. And post-operative interventions, PCM, NSAIDs, opioids. So multimodal analgesia is the way to go. Interventions which are not recommended include carbohydrate loading, outpatient status, so means patient needs to be admitted for the procedure and monitored at least for a day or two. And preemptive COX-2 versus post-operative COX-2, there's a limited procedure-specific evidence. Gabapentinoid shows side effects. Ketamine, limited evidence. Lateral femoral cutaneous nerve block and QL block, there's not much of evidence for this. Femoral nerve block and lumbar plexus block, effective, but because of the side effects, they've not recommended it. And LIA adjuncts to local anesthesia drugs, infusion or repeated injections, epidural analgesia shows evidence, but because of the side effects, it's not recommended. However, I feel there are still many of us who still give epidural as post-op analgesia, and monitoring the patient is very important post-operatively. And also post-operative tranexamic acid, partial weight bearing, topical fibrin sealant, TENS, all shows limited specific evidence. And surgical technique per se, anterior approach versus posterolateral approach, minimally invasive versus traditional incision. Also, there is inconsistent procedure-specific evidence. Okay, I would like to present two patients. Okay, one is Puan S. Puan S is an elderly lady who just had a total hip replacement done. She had a right hip fracture. Total hip replacement was done under combined spinal epidural, and fascial iliac block was given post-operatively, and the epidural catheter was removed. She was also given paracetamol, NSAIDs, and also oxycodone for breakthrough pain. And generally, immediate post-op in the recovery, pain scores were around 0 to 1. And post-op day 1, she's ambulating well, pain scores around 1 to 2. And she was discharged day 2 post-op. Okay, next patient is Mr. P. He's an Indian gentleman. Also had a right THR, he had an EVN secondary to a traumatic hip fracture. And we did the procedure intraoperatively under combined spinal epidural, and he was given a PANG block post-operatively, and the epidural catheter was removed. Also supplemented with paracetamol, NSAIDs, and also oxycodone, and for rescue analgesia. And patient fared well. Immediately in the recovery, he had a pain score of 0 to 1. And post-op day 1, during ambulation, pain score 1 to 2. He also was discharged on day 2 post-op. So in summary, prospect guideline seems to be a helpful aid in identifying appropriate analgesic regimens for optimal pain management after THR. So when the analgesic requirement of the patients is managed well, this leads to early ambulation, a reduction in morbidity and mortality in the patient. Patient feels satisfied overall, and also it gives a more holistic approach to perioperative patient care. There were some limitations in the study which were addressed, and unstandardized anesthetic techniques, variable dosing regimens, variable methods of administration, variable control groups, and time points of pain assessments. And those in high risk of excessive post-operative pain were also not included. So hopefully in the next update, these issues will be addressed. Okay, with this, I end my talk for today. Thank you very much, and please have a good day.
Assalamualaikum and good afternoon. Our next prospect pain management series is in breast cancer. This prospect guideline was published in Analgesia 2020. As we know, oncological breast surgery was associated with significant acute and chronic post-operative pain. Therefore, their aim is to provide clinicians with evidence-based approach for post-operative pain management in order to improve pain relief. This prospect guideline is unique due to the available evidence is critically assessed for current clinical relevance, and they will report true clinical effectiveness by balancing the invasiveness of analgesic intervention and also the degree of pain after surgery, and not to forget to balance efficacy and also adverse effect. Actually, in 2006, there was a systemic review of analgesic strategies in non-cosmetic breast surgery. However, due to emerge of several new analgesic regimes and also regional analgesic technique, an update systemic review on analgesic intervention dedicated to oncological breast surgery was consequently required. This prospect working group actually a collaboration between of surgeon and anesthetists who are working together to formulate procedure-specific recommendation for pain management based on procedure-specific review of RCT. They will evaluate the available literature on the effect of analgesic, anesthetic, and also surgical intervention on pain post-oncological breast surgery. This systemic review actually included total 62 studies, and majority of this study having a high quality impact, and most of them showed statistically significant result for the intervention tested. And their primary outcome, of course, the post-operative pain score, and their recovery outcome are opioid requirement and also adverse effect. And this literature review are published between 2006 to 2019. And this among the keywords they use during the literature review period. And some inclusion included full data from patients undergoing mixed procedure of cancer and non-cancer breast surgery. However, a meta-analysis not performed due to heterogeneity in study design, result reporting, and also restricting pool analysis. After that, the recommendation will be graded from A to D. This is the result, including the result analgesic intervention that are not recommended for pain management in patients undergoing oncological breast surgery, such as retrolaminar block, ESP block, perineural adjunct, and also transversus thoracic muscle plane block due to limited procedure-specific evidence. So, preoperative intervention using the gabapentin. Several studies had evaluated the efficacy of preoperative use of gabapentin for the treatment of acute and chronic post-operative pain following breast cancer surgery, including 4 studies concerning the usage of pregabalin. The doses for gabapentin used are 300 mg and also 1,200 mg, and the doses for pregabalin was 150 mg and 900 mg. They found the gabapentin able to reduce pain score in PACU 24 hours post-operatively and also able to reduce the 24 hours morphine consumption. With the subgroup analysis, they found at high dose of gabapentin, which is more than 900 mg a day, it actually superior in terms of pain score. And they found the usage of pregabalin able to reduce the pain score in PACU, morphine consumption in PACU. However, there is no significant difference was observed in pain score at 24 hours post-operatively, and the incidence of sedation actually increased with the pregabalin. And how about the usage of dexamethasone intraoperatively? They found the usage of dexamethasone able to reduce the pain up to 24 hours post-op, and it also able to reduce the risk of or evidence of PONV at 6 hours post-operatively. In 39 out of 62 included studies and meta-analysis, they found simple analgesic such as paracetamol, NSAID, or COX-2 inhibitor were given post-operatively. And this team able to retrieve one study comparing the paracetamol and also metamizole and placebo. The authors report analgesic superiority of paracetamol, which is 4 grams daily, as 42% of patients did not require rescue analgesia compared to the placebo and also the metamizole group. And this actually support by Kempi et al. They document that paracetamol was documented to be equivalent to metamizole. And the Oliver et al. In 2018 also documented that paracetamol 1 gram, which is administered at the end of surgery, able to improve pain control during recovery. And the combination of paracetamol with codeine or combination paracetamol with ibuprofen also found to be effective. And this support by Michel et al. In 2020 in ambulatory patient population, where the study was involved the paracetamol and ibuprofen combination and also paracetamol with codeine or caffeine combination, where they found both analgesic protocols had comparable effect on pain intensity. However, the incidence of nausea and also constipation was reduced in the group of paracetamol and also ibuprofen. Only one study in the search period specifically examined the post-operative pain control we can say after oncologic breast surgery. And they found also the addition of systemic COX-2 inhibitor to the paravertebral block has been demonstrated that it able to decrease the intensity of pain up to post-op day 5. And there is no effect on the occurrence of post-operative hyperalgesia. And going to our regional analgesic intervention, our first regional intervention is thoracic PVV, which commonly performed before the surgery. And this efficacy of PVV actually had been reported already in the 4 meta-analysis, including 32 studies. they found this thoracic PVV able to lower the post-operative pain score, lower the OPEC consumption, and also able to lower the incidence of QONV. And meta-analysis by Tawi et al., they found also the average length of hospital stay was shorter in those receiving the PVV. And what about the single level or multi-level of PVV? The study by Kasi Mahanti et al. In 2016, they found the multiple injection result in less post-operative analgesic consumption. However, there is no significant difference in terms of PONV. And the time to require to perform a single injection actually was shorter, comparable to the multiple injection group, 5 minutes versus to the 10 minutes. And when they use the ultrasound guidance to perform PVV or not, they found the result actually were not different depending on the use of ultrasound guidance or not. And how about the continuous PVV? Actually, they found this continuous PVV able to result lower pain score up to the post-op day 5. And according to Effect et al. Also, this continuous PV also able to improve the functional status up to post-op day 3. How about the incident of chronic pain? Study by Karmakar et al. In 2014, they found it is a similar incident, those who are receiving this continuous PVV or not. Even though, as we know, PVV actually associated with the reduced severity of chronic pain symptoms. And comparing this continuous PVV with the local anesthesia wound infiltration by Bowman et al., they found actually it has equally effective in terms of analgesia consumption during the first 24 hours. Our second regional analgesic intervention is PAX1 and also PAX2. They found intraoperative OPEC requirement actually significantly lowered if given a PAX2 block, and also post-operatively, it also able to lower the pain score and also the reduction in term of post-operative period consumption with the PAX2 block. When they are comparing this PAX with the PVV, they found actually they have the similar result on pain relief and also analgesia consumption. However, after 18 hours, they found the PVV group actually had lower pain score compared to the PAX block. And study by Cross et al. In 2018, they tried to evaluate the effect of PAX1 with together multimodal analgesia, including the LA wound infiltration. Actually, they found there is no reduction in pain score. And with the subgroup analysis, they found actually the pain score actually lower with the PAX block. Atipama et al. In 2019 also compared the PAX block with the ESP block. They found initial pain score was similar in both blocks. However, it is quickly inferior in the PAX block. And the post-operative opiate consumption actually inferior in the PAX block group. When the combination of this PAX2 block and also transverse thoracic muscle plane block done by Ushima et al. In 2017, they found able to lower the pain score and less rescue analgesic consumption needed compared to the PAX block alone. Our next regional analgesic intervention is stratus plane block. It also able to lower the pain score at rest, and actually it found to be less effective because total rescue morphine consumption actually was significantly higher in the stratus block group. And study by Kunigo et al., they compared between the volume of use for the stratus plane 40 ml versus 20 ml. They found actually there is no difference in terms of pain relief. And when comparing this ESP to GA alone or ESP to PAX block, obviously in the PAX block, group, the pen score and also opiate consumption actually lower in the PEX block group. Whereas in ESP block versus the GA alone, they found there is no difference in terms of pen score. However, the decrease of morphine consumption are available in the ESP block group. How about the LA wound infiltration? They able to assess near 10 RCT papers, which is stated this LA wound infiltration in breast surgery, and from them related to oncological breast surgery. And this report using a different solution of LA such as ropivacaine, bupivacaine, also lidocaine. And they found with this LA wound infiltration, it able to reduce the pain score in 4 trials, reduce the rescue opiate consumption in 2 trials, and this effect of LA wound infiltration actually ever lasted more than 24 hours. Come to our discussion. So based on prospect approach, the basic analgesics such as paracetamol, NSAID, and also COX-2 inhibitor should be continued perioperatively unless it is a contraindication. And this is the recommendation, the usage for the minor and also major breast surgery. We can see that the use of NSAID is supported by study performed before 2006 in breast surgery, although there are no recent data. In addition, the analgesic benefit and also opiate sparing effect of paracetamol and NSAID were described in range of perioperative setting. Therefore, NSAID was given a grade as a grade A, and paracetamol and COX-2 inhibitor was given as a grade B. And for the gabapentinoid, it was given a grade A for the gabapentin itself, even though the well-documented side effect of gabapentinoid such as dizzy, blood vision, or sedation are not reported in study, which is dedicated to post-operative analgesia after breast surgery, even in patient receiving the high dose. And for the pregabalin, they are not recommended as a observed pain relief, did not last up to 24 hours. And the usage of gabapentin actually need to be used in cautious, especially in the high dose, because it may induce a side effect that could be especially concerned in ambulatory patient. And the usage of dexamethasone was given as a grade B. And opioids, yeah, our opioid is actually given as a grade B, and it is recommended for rescue post-operative analgesia. And for the PVB, is being given a grade A, and should be considered in a major breast surgery. And for the single injection PVB, actually we able to achieve a shorter time to perform and less laborious compared to multi-level. And for the continuous PVB, it be given a grade B, and it should be considered for major breast surgery if the catheter is present in the place. But this continuous PVB actually should be interpreted with the cautious, because among this study, actually they did not use the basic simple analgesic in fully implemented multimodal analgesia program. And the cost effectiveness study actually reported higher in this continuous PVB group. However, with the reduction of duration of hospital stay, this cost actually able to offset. And others interfacial plain block actually able to improve the pain score and also opiate consumption, such as the PEX block itself. It is actually recommended to use the PEX block if the PVB is contraindicated, or if the azilinot dissection are not being performed. And these PEX block are graded as a grade A. However, the data concerning the use of this block actually limited, and the choice of the appropriate block, either PEX1, PEX2, or even status plan block itself, it meant to be validated. And it should also be noted that for some anatomical reason, neither the PEX nor the PVB itself can reliably provide sufficient analgesia to the axilla due to the T1 innervation. Therefore, this is the advantage of LA wound infiltration. And others interfacial plain block such as retrolaminar block or USP block actually can be alternative for mentioned before, and further study should be conducted to compare with this block with the PVV and also PLEX block. And for the wound infiltration, is still to be considered in the minor or moderate surgical procedure, even though the effect is actually in a limited duration, and is a grade being given a grade grade A. And for the major breast surgery, it is advocated to use the LA wound infiltration together with the regional analgesic technique, because the some anatomical reason also, and this is being a grade A. How about the surgical intervention? Actually, their research did not find any evidence regarding the choice of surgical technique that could prevent or reduce this pain after the breast surgery. There is also a few limitation and some considerable heterogeneity should be considered, such as variable dosing regime, methods administration, difference in baseline analgesic management of control group, variable time points of the measurements, and the sample size itself are small, and therefore it's hard to draw a firm conclusion regarding the side effect profile of many proposed intervention. Therefore, future study should be adequately powered study, not to assess the effect of analgesic intervention towards the pain only. It should be included the opioid consumption, adverse events, opioid dependence, complications associated with the intervention, outcome measures such as time to ambulation, length of hospital stay, and also patient-centered outcomes such as patient satisfaction or quality of recovery. Therefore, with my summary, we advocate this simple analgesic, gabapentin preoperatively, dexamethasone intraoperatively, and also local wound infiltration for the minor breast surgery. But for the major, even though the presence of a block is there, we also still advocate the local infiltration. And for the post-operative intervention, opioid for the minor or even the major breast surgery is considered as a rescue and can be graded as a grade B. And this is as I listed before, the intervention that are not recommended for pain management and for the breast surgery, oncological breast surgery. Okay. So with that, I think I end my presentation. Thank you. Assalamualaikum.
Hi everyone. I'm going to present the topics about the prospect view on open inguinal hernia surgery. We start with the anatomy, the iliohypogastric, ilioinguinal, and also the genitofemoral nerve have a primary sensory function in imaging the lower abdomen, the inguinal region, the anterior thigh, and the middle thigh, and as part of the genitalia. If you open up the inguinal canal, this is the tree nerve that will be present. Iliohypogastric nerve will go the other on top of the internal oblique muscles, and is diverted from the inguinal canal. And if you open up the canal, you can see there's a two important nerve, ilioinguinal nerve, and also the genital branch of the genitofemoral nerve. Notes about the pain after open inguinal hernia repair surgery is category as moderate to severe. And if it was not been treated appropriately, it can delay the recovery and it can cause unplanned admission because of pain. And furthermore, it was not treated well, it can end in hyperalgesia, persist as post-operative pain, and end with chronic pain. So what the prospect recommended? So we're going to divide this discussion into three areas: the preoperatively, intraoperatively, and postoperatively. So what the prospect recommended is that for preoperatively, they suggest us to give or NSAID or COX-2 selective inhibitor, oralized, and then or maybe intravenously. And then they also suggest, it's a great recommendation, to apply inguinal nerve block, field block or infiltration preoperatively. And they also suggest to use a long-acting local anesthetic. Intraoperatively, they recommended the same, either local anesthesia with or without sedation, or general anesthesia in combination with local anesthetic techniques such as inguinal nerve block, field block, or infiltration. This is grade A recommendation. And also the use of long-acting local anesthetic. Regarding about the operative techniques, either is open or laparoscopic surgery is a grade D. This is based on the surgeon expertise, availability of the local resources, and also the characteristic of the hernia. And mesh technique is a grade A recommendation. For post-operative recommendations, they suggest us to use leather pin management. We started with conventional NSAIDs or COX-2 selective inhibitors. It's a grade A recommendation, and then we can combine it with paracetamol. And if the pain does not reduce, we can add weak opioids for moderate intensity pain by continuing the rest. And if this does not working, then only we add in a strong opioids. I'd like to share this from the Annals of Gastroenterological Surgery website, where the surgeon apply a 3-step tumescent local anesthesia for inguinal hernia repair. So meaning that if we have a surgeon who has the capacity to perform a block, this help a lot in reduce the patient pain post-operatively. At the same time, maybe you don't have to apply a regional anesthesia or general anesthesia to the patient. So they are using a large amount of local anesthetic, consists of 1% lignocaine with adrenaline, and they dilute it 10 times until they reach 200 mils of solutions. And then there is another liquid where they consist of mix between the bupivacaine and lignocaine. They mix it together, but very diluted concentration. So before they started, they mark the skin, and after that, this the incision site. They infiltrate 80 mils of liquid of local anesthetic until the skin become bulge. This is tumescent. Then when they cut the skin, you can see there is a local anesthetic there. Then after that, as the surgeon reached the inguinal canal, they lifted it and they inject another 20 cc of local anesthetic inside the inguinal canal. This is important because inside there is a ilio-inguinal nerve and also the genitofemoral nerve. During the procedure, sometimes when the surgeon pull up the hernial sac, even with spinal anesthesia, some patients still complain pain because we didn't block the genitofemoral nerve. But if the surgeon can infiltrate a local anesthetic inside the inguinal canal, it can help to avoid the pain. And lastly, they will inject another 20 cc of local anesthetic inside the peritoneal space by attaching a syringe onto the edge of the internal inguinal ring that is injected inside. But for anesthetists who are interested in regional anesthesia, if the surgeon cannot apply the technique to measure local anesthetic that we mentioned just now, if we have the capacity and also the equipment, we can perform inguinal nerve block under ultrasound. I'd like to show you the video. This is the external oblique, internal oblique, tragus abdominis. So the needle comes from lateral. So we are injecting local anesthetic inside it. So the nerve, you can see the ilioinguinal iliogastric nerve inside. Okay. So let's see the overall prospect recommendation. So they recommend us to use a local anesthetic with sedation or general anesthesia in combination with local anesthetic technique such as inguinal nerve block, field block, or infiltration. They encourage us to use long-acting local anesthetic in preference compared to the short-acting, and open or laparoscopic surgery will depending on the factors that I mentioned just now, surgeon factors, the hernia types, and also the availability of equipment. Mesh technique is recommended to be used in preference. And for post-operative pain, either between the 6 hours and beyond that is based on the ladder of pain. We started with conventional NSAID or COX-2 selective inhibitor. It was not working, then you can add in with paracetamol inside it. It was not working also, you add in some weak opioids. And if the pain score is more than 5, then you can add in strong opioids. And surprisingly, this is the procedure which are not recommended. Like for example, like a spinal anesthesia. Probably one of the reasons why they are not recommended is because the risk of urinary retention, also bladder distension. And some patients also, they might have headache. So because of that, it's not favorable. Epidural anesthesia, on the other hand, is relatively invasive with potential for complication. So they are not suggested to use. The rest, for example, including corticosteroid, are not encouraged to be given. And then also adrenaline is part of local anesthetic solution. Even the tumescent that we performed by the surgeon is look very promising. And also paravertebral block are not encouraged to be performed. And repeating wound injection, okay, post-operatively with local anesthetic also are not encouraging. Wound infiltration with conventional NSAID, clonidine, and strong opioid also are not recommended. And the rest. Thank you.